Dr. Shafi is an ICU intensivist at Muimbili Orthopedics and Neurosurgical Institute. So he's going to take us through ICU management of traumatic brain injury. Karibu, Dr. Shafi.
Okay, let's talk about ICU management of traumatic brain injury. Okay, let's start with a case. This is the patient that we attended at the beginning of this year. He was a 27 years old male. He was referred from a certain hospital. And he arrived at Moi 16 hours after a sustained car accident as a passenger. He just presented with loss of consciousness for a known period of time. He had no seizures, but GCS was really low. And upon arrival, he was not intubated, but his examination, his pupils were anisocoриc, and vital signs were a little bit unstable, but it was all good. So he was intubated at emergency department, and CT scan, he came with a CT scan from the hospital that he was admitted at first time. So it showed acute subdural hematoma with a brain edema. He was planned for emergency craniotomy. So we started TBI protocol at Moi. So emergency craniotomy was done. And then this patient post-operatively, he was admitted in ICU. The pupils was good at this time. So the blood pressure, the vital signs were okay. So 24 hours when we were passing around, we realized that this patient GCS has dropped. I was 1 and motor was 1. And the pupils were returned to the baseline like when he presented at Moi anisocoриc. So we started TBI protocol. We gave mannitol, and then we did a little bit of hyperventilation targeting CO2 of 30 to 35. And we did an urgent CT scan brain. At this time, we consulted our colleagues of neurosurgery to do the surgical management. So hemicraniectomy was done, and GCS improved. So on the fourth day, when we were passing around, the patient GCS had improved significantly. And this is CT scan is the second CT scan which we did. So you can see the pericranial hematoma there, the significant midline shift. So after that, this patient, well, after the surgery, he came back in ICU. He just continued the severe TBI protocol. On 13th day, we did tracheostomy because it was really hard to extubate him. So we started wheelchair ambulation with the family. I'm sorry I didn't post the pictures where the families get out with the patient out of ICU. So the patient was transferred out to step-down care HDU and then general ward. At that time, he was planned to be discharged home. And the weaning off tracheostomy was not really done at that time. So on 26th day, in general ward, we were called, the patient has aspirated, and he went into cardiac arrest. So we did ACL sequence, and we achieved ROSC. So we transferred the patient back to ICU, and then we continue with ICU support. So at second time, he got cardiac arrest while he was in ICU, and we did CPR the second time, and then we achieved ROSC. Currently, this patient is out of ICU. He's just continuing with rehabilitation. So let's talk a little bit about traumatic brain injury. Just an application of to the brain, an external physical force, or can be rapid acceleration, deceleration force. It's not due to congenital, degenerative, vascular, hypoxic ischemic, or neoplastic. It's not due to infection, that's TBI. And it produces an immediately physiological disruption of brain function, which manifests with cognitive and neurological impairment of the patient. So we know globally TBI is estimated to affect 54 to 60 million people annually. it leads to either prolonged hospitalization or mortality. And WHO estimate that 90% of deaths due to injury occur in low and middle income countries, where 85% of the population live. This is where we live ourselves. So when we look at the studies which were done in the country, across many centers like Moi, Bugando, and KCMC, you find the mortality rate in TBI is very significant. So there is this study which was done at Moi in 2021, and it showed that the 2 weeks mortality from severe traumatic brain injury was 67%, which is higher than predicted estimate. So the reason was being underutilization of ICU care, CT scan imaging, ICP monitoring in tertiary and referral hospital setting. So improving TBI will require concentrated investment in pre-hospital care, as well as improvement in the availability of ICU resources, CT scan imaging, and expertise. So when we talk about the pathophysiology of TBI, as an ICU doctor, you need to understand the pathophysiology of traumatic brain injury, which is really divided into the primary and the secondary causes. So the primary injury is induced by mechanical forces, and it occurs at the moment of injury. And the secondary injury, this is where we concentrate much in ICU. It's not mechanically induced. It may be delayed from the moment of impact and may be superimposed injury on the brain, which is already affected by mechanical injury. So we can use the anatomical classification of traumatic brain injury, the epidural hematoma, subdural hematoma. This is where the surgeons come, the neurosurgeons do their work here. And once they have done, and if you look critically here, you'll find there are some condition like diffuse axonal injury where they don't need to operate. So these patients, they need a really intensive care rather than surgical. So we have the famous classification based on Glasgow Coma Scale, the mild, moderate, and severe traumatic brain injury. So the key concept in management of traumatic brain injury is to treat the primary injury and then to prevent secondary injury as soon as possible. So once the patient has arrived in our setting, we concentrate on treating the primary injury with the neurosurgeons, and then secondly, we prevent the secondary injury as soon as possible. So how do we achieve this? So we have a principle that we follow. We use the ABCD approach. We concentrate on the airway, breathing, circulation of the patient, disabilities, and on exposure, or we call it extracranial causes of secondary traumatic brain injuries. So, and the goal of treatment is mainly prophylactic. So we do the prompt management of intracranial hypertension prevention so as we may prevent the secondary brain injury. And the main target is to maintain cerebral perfusion pressure to ensure adequate oxygen delivery to injured brain tissues so as to promote healing. So management of severe TBI is ideally based on protocol, which we took it from Brain Trauma Foundation, and we tailor it to our relevant clinical setting based on available resources that we have. Because if you look at the Brain Trauma Foundation guideline, there are some stuff that you can't do in your setting, so you have to utilize what you can do. So we do effective utilization of the low-hanging fruit, which is ABCD approach. So we concentrate much here so as to we make sure we don't lose any patient. So the goal of treatment, we know we should maintain pulse oximetry more than 95% with a PO2 of more than 100. This we achieve this by doing regular ABGs. PaCO2 should stay 35 to 45, and systolic blood pressure should be above 100. Here with the mean arterial pressure, we target it to be in the acute phase within 7 days to be above 85 millimeters of mercury mean arterial pressure. And pH, we make sure that our patient pH stay within the normal range. What we don't do now at Moi is we don't do continuous ICP monitoring. We don't do PTBO2 with oxygen saturation of the brain, and we don't do CPP monitoring. We just do it hypothetically and with the monitoring of clinical presentation of the patient. But with the temperature, we concentrate on making sure the patient is normothermic. And sodium level, we make sure that we do serum electrolyte regularly to make sure that they are within the normal range. We do PT, PTT, INR. These are the markers that we do regularly. And we make sure the patient is not anemic, so that we know there are controversies here. With a brain injury, we target hemoglobin to be above 10 gram per deciliters, unlike more than 7. So we have a tidy protocol that we follow at MOI. The first thing is once you admit the patient in our ICU, if the patient is intubated and mechanical ventilated, so we make sure we follow the protective lung strategies to make sure that the patient is not hyperventilated or is not hypoventilated, because hyperventilation and hypoventilation would cause harm to these patients. And we do serial evaluation of neurological status of the pupil's activity. And currently, here we have quantitative papillometer that we use regularly to monitor this patient progress with the papillometer, instead of clinician-based papillary examination. We know there are bias, and it's not, it depends on the examiner. But with the quantitative papillometer, we have an objective measure that anyone can rely on it. And we do head of bed elevation, 30 to 45 degrees. We give the patient analgesics so that they don't go into pain, so that to monitor, we make sure the ICP is not elevated because of pain. And we do sedation. We sedate the patient based on PADIS guideline, and we do temperature management. So we consider anti-seizures medication for 1 week only. If the patient has no seizures after 1 week, is where we discontinue the anti-seizure. This is like estimated CPP monitoring. It's not actual. We make sure that the mean arterial pressure is within the normal range. The patient is not hypotensive. We advance to Tier 1 management, Tier 2 management, and Tier 3 management based on the patient presentation. So if we suspect there is a rise ICP, is where we escalate our care. And we do it very quickly so that to make sure that the patient is not going into secondary injury. And this is our MOI TBI protocol, severe TBI protocol management, which is maintain airway patency. We intubate every patient who GCS is less than 9. We make sure, with the breathing, we make sure that SpO2 of the patient is above 90%, and partial pressure of carbon dioxide is within 35 to 45, and we maintain systolic blood pressure around 140 to 170, and diastolic blood pressure 90 to 110. We measure arterial blood pressure continuously or with cuff BP. We don't do regular invasive blood pressure monitoring. And then we maintain cervical spine, because traumatic brain patient, they can have also spinal cord injury. And then we don't insert ICP monitors. Sometimes there is EVD placement in case the patient has hydrocephalus secondary to traumatic brain injury. And we do continuously cardiac monitoring. We do elevation of the bed, and we do GCS monitoring every 1 hour of the patient. This is done with the bedside nurses. So with this algorithm is where we make sure that all patients, they are monitors, and then we do the basic ICU care, like DVT prophylaxis, GI ulcer prophylaxis, and we do head CT scan when we suspect the patient has something which is going on. Maybe we suspect there is ICP crisis with this patient, or the GCS has been dropping, or the papillometer has been getting lower. This is where we do control CT scan. So this is our strategy. We use critical care bedside nurses as the backbone, because they do GCS monitoring every time. And we congratulate them in doing this. So we make sure there are bedside nurses who are doing GCS monitoring, papillometer, and they record the vital sign. So if there is any change here, they notify the neurointensive or any ICU doctor who is around to tackle that problem. And we do rounding with all these people. Neurosurgeons, they come to pass around during, now we do twice a day, and we have a clinical pharmacist who always pass around with us, and we have clinical nutritionists, because at first when we started managing these patients, we forget the part of nutrition. And nutrition is very vital to these patients because they get hypoalbuminemia most of the time once they're admitted in ICU. And we involve the social welfare. We know management of traumatic brain injury is it needs more financial stability. And we know most of our families within the countries, they can't afford the care that we provide to these patients. So we involve the social welfare to assist them. We do regular family conferences, and this one has helped to relieve the family questions. Once they inquire about anything, what we do to manage these patients is where we answer them here. And we have physiotherapists. They are not adequate, I can admit, but they do their best for some of the patient. And what we do here, because we saw that you might do a great work in ICU, but this patient might go and deteriorate in general wards. So we integrate with the general ward. We do continuous essential emergency and critical care program so that to enable them to attend this patient. So we face some challenges. We do our best, but we face some challenges. And the most challenge that we have, as explained previously, we don't have advanced cerebral monitoring. I know the Brain Trauma Foundation has, the guideline shows that advanced cerebral monitoring can impact the care with the level 2 evidence. But what we do, we just use SpO2 and lactate to predict the neurophysiology of the brain. And we don't have a dedicated rehabilitation services for trauma patient, especially TBI patient. With this one, what we do, we incorporate relatives and physiotherapists. We try to cling into them that they should instruct relative on how to take care of these patients once they are discharged and once they come to the clinics. And we don't have advanced invasive ICP monitor currently. And there are some medicine that we lack. For example, if we want to put a patient in barbiturate coma, we can't do that right now in our setting. And we don't have in-house continuous renal replacement therapy. We don't have bronchoscopy. With continuous renal replacement therapies, we receive a number of patients with the traumatic brain injuries that they go into acute kidney injury sometimes, because you may find this patient was under resuscitated previously, so they have pre-renal ACI. So once they have this, it's a very huge logistic setting up this patient to go to another facility to be dialyzed there. And you find the dialysis that is done there is not typically for ICU patient, it's for regular patient. It's 4-hour dialysis, and we need 24 hours continuous renal replacement therapies for this patient. We have some opportunities that we utilize. We know that we can do invasive monitoring, but we do multimodal non-invasive ICP monitoring. We currently discuss on using transcranial Doppler ultrasound and continuous EEG monitoring. We have papillometer now on site. We do optic schist nerve diameter, and we have continuous training and collaboration. I would like to acknowledge the MOI ICU team, the critical care nurses. They are doing a very great job. We have intensivists, registrars, neurosurgeon, healthcare attendants, clinical pharmacists, and I would like to thank this guy. He usually visits us in ICU, and we do regular Zoom meeting every Wednesday. And Professor Halinda Mangat, this is Professor Louis Carver that we discuss every day. And this is Halinda Mangat. We discuss on how we can improve our ICU care and how we can collaborate more. We establish some courses that we do every month on how to manage traumatic brain injury patient. And I would like to thank Professor Chiara Roba, who is the chair NIC section for European Society of Intensive Care Medicine. He gave me a chance to attend a course for free, which was a really expensive course, but I sent her an email, and then he just allowed me to attend that course, and we do it regularly on weekly basis. So thank you.
Thank you, Dr. Shafi, for a nice presentation. I think questions will come later after the other presenters have done their presentation. So now we are going to have Dr. Abdul Kitua, who is a resident at KCMC with interest to join neurosurgery. So he's going to have to talk about the understanding a postpartum headache, a diagnostic adventure. So, Doctor, you're welcome. Is he around? Dr. Kitua? It's not. Okay.
We apologize for some changes that we have to make to accommodate the guest of honor. So bear with us. We are not following the timetable at this time because we need to fix. There are other presentations that are online and they are time bound. So we need to, we have done some few changes.
Okay. Sorry, Dr. Kitua is from Aga Khan instead of KCMC. So, Doctor, you're welcome.
Thank you. Morning. My name is Dr. Abdul Kitua, as was introduced, and it is an extremely immense pleasure to address you all with a brief experience of the cases that we see at our hospital. I am a fourth-year general surgery resident at the Aga Khan University, and our teaching hospital is the Aga Khan Hospital, Dar es Salaam. So today we'll be taking you through postpartum headaches, and this will be a case-based presentation. So postpartum headaches encompass a diverse group of conditions that usually present within the first 6 weeks postpartum. And it can be from as simple as a primary headache to something more sinister, talking about secondary causes of postpartum headaches. And this is why it is important for us to discuss and address this, because at times it may be ruled out as a simple primary headache while it could be a symptom of something more severe. The majority of these headaches present in a similar presentation, hence the diagnostic challenge. And it is important for us to understand how we can best differentiate between primary and secondary causes of headaches in the immediate postpartum period. It all relies in a good history taking and a physical exam. And the important thing is red flags. So important causes of secondary headaches to consider are, first and foremost, that is relevant to this society and meeting. postpartum headaches as a result of dural puncture. The majority of women in our setting who have obstetric and gynecologic surgeries often have neuroaxial anesthesia administered, and these patients may present with a post-dural puncture headache. It usually starts within the first 48 hours, and majority disappears within the first week. So the red flag here is that if it does not subside within the first week, this is the first early red flag. And the majority of times, this is usually a positional headache. So when you have a patient in the immediate post-op period whose headache is severe and is not positional, that's also another red flag. The overall incidence has been estimated at about 3 to 6 to 9%, and it is important to note the risk in obstetric patients. It may also be accompanied by other symptoms such as pain radiating to the neck and back, photophobia, nausea. Again, similar presentation with some primary causes of headache such as migraine. And epidural blood patch is important to note if there is no response within the first 48 hours of conservative management, because this has been shown to actually resolve the situation. And this is important because the CSF leak, if persistent, is a cause for complications, such as we shall see in the case that I am about to share. Other important causes to consider include preeclampsia and eclampsia with severe features in the immediate postpartum period, and a patient who has elevated blood pressures. This is something we should consider. Strokes, it is not uncommon in the immediate postpartum period, particularly hemorrhagic stroke, pituitary apoplexy, cerebral venous thrombosis, and other causes such as reversible cerebral vasoconstriction and posterior reversible encephalopathy syndrome. These are somewhat rare but important causes to also consider. And then you have infectious causes, particularly in the setting of neuroaxial anesthesia and the patient presenting with headaches that is unrelenting for more than a week, with fevers and at times neurological deficits. In one review of patients in the immediate postpartum who, in this review, they reviewed cases of about 95 patients with severe unrelenting headaches within the first 42 days. Preeclampsia was 24%, post-dural puncture headache 16%, and pituitary lesions 3%. Then the other causes came in. Preeclampsia is mentioned here primarily because of the risk of it progressing to preeclampsia with severe features, one of which is stroke, hemorrhagic stroke. So an important mnemonic to kind of help us remember some of the causes that we should consider when faced with a similar patient is PATAM, where the letters as highlighted stand for those words, but in particular, the U, which stands for use your brain. There may be so many other causes, is important for all of us. We were first with a patient who was a 36-year-old female. She was 40 days out postpartum. This was her first child, and she was a self-referral to us. Her main complaints were headache for the past 1 month and a sudden onset confusion for 1 day, hence the self-referral. So she delivered by C-section under spinal anesthesia. The indication was a breech presentation, and started experiencing headaches immediately within the post-op period with accompanying neck pain. At this time, as we saw, one of the most important things to consider after neuroaxial anesthesia is post-dural puncture headaches, and this is what was diagnosed, and she was treated conservatively. However, headaches got worse. She then had episodes of vomiting and was readmitted. This was several days out. She was still treated for same with posterior puncture headache with analgesia, and then reassured and was later discharged. However, the headaches persisted and rather progressed. Later, she got more severe headaches, such that she was not able to just go on with oral analgesia and had to get injectable analgesics. She was then readmitted with severe headache now and vomiting and treated similarly. But on this third admission is where she became confused and agitated, followed by altered mentation. And at this point, this is where the family decided to bring the patient to us. There was no history of fevers, convulsions, weakness, or any visual abnormalities that was divulged. And a pregnancy period had been otherwise uneventful, and she was not on any medication. So on examination, patient presented in a stretcher, febrile with stable vitals at the time, but her pupils had been dilated and were sluggishly reactive to light. And of note, her GCS was 13 with altered mentation. However, she was moving spontaneously both upper and lower limbs with normal bulk, and the rest of the exam was otherwise normal. So important things at this point that we considered were what is, given the constellation of signs and symptoms our patient is presenting with, the cause of raised ICP in this patient in particular. It is not unheard of to have subdural hematomas arise following a persistent CSF leak and a patient presenting with dural puncture headaches that have persisted for a long time. So this was first on our list, but we also had to consider other causes, including hemorrhagic stroke and brain tumors. And infections, again, she had neuroaxial anesthesia, and this is one of the complications that can arise. Other than the routine medication, this is the initial CT that our patient had, and you can see from the fourth image, this will be your lower right. There is evidence of a subacute left-sided subdural hematoma and a small hematoma as well on the right. And you can also see from this image, which will be your lower left, there is some evidence of a midline shift. So if you can quickly go through the scan. She had an impressive left-sided subdural hematoma that had a thickness of about 27 mm, and there was a significant midline shift to the right of about 14 millimeters. So this is one of the most sinister complications of post-dural puncture headaches in the postpartum patient. As we can follow from the case, this was a neurosurgical emergency, so the patient was taken to the operating room, and bar hole evacuation for the hematoma, and about 120 mL was drained. The patient was then admitted to the ICU, but followed an uneventful post-op course, and these are some of the scans. This is the immediate post-op scan, and this is a month later during follow-up, 3 months later during follow-up with an otherwise uneventful recovery. So this is one of the cases that represents those challenging patients that we need to have a high clinical acumen to better differentiate between a benign post-dural puncture headache and a complication as a result of the CSF leak. The patient had a headache that progressed for almost 1 month, and surprisingly, it was a challenge with the initial treating team. They were only treating her for a post-dural puncture headache. So subdural hematomas post spinal anesthesia is a rather fatal complication. The majority are unilateral, but can also be bilateral, as in our case. And the most common presentation is a patient who had dural puncture headache, then that did not resolve and progressively worsened. Late diagnosis is important for us to consider because it has been linked to residual neurological deficit and an increased rate of mortality. So this is a brief schema showing the sequence of events and the pathophysiology around how patients with dural puncture in the CSF leak eventually develop subdural hematoma. Intracranial hypertension is at topmost, and as a result, you have increased vasodilation and leaky capillaries within the cranial vault, and as a result of the ongoing CSF loss and intracranial hypotension, you have sagging, which results in stress and shear on the bridging veins, and this eventually tear, resulting in a subdural hematoma. So the management, as was described in our case, at this time, we had to address the neurosurgical emergency, but it is important to consider that for patients who present early on, you can do a blood patch, which has been shown to actually be effective in these cases and prevent complications. So in conclusion, this is a rare complication, but it is rather more common in the obstetric patient, and postpartum headaches require careful follow-up so that we can identify red flags and complicated cases. There's a high index of suspicion that is required and vigilance when faced with a prolonged post-dural puncture headache or severe non-orthostatic headache post-neural and neuroaxial anesthesia. Early neurosurgical consultation and evaluation for patients with prolonged post-dural puncture headache is vital. This is the message for non-neurosurgeons. Thank you.
Thank you, Dr. Kitua, for a nice presentation. I think because of time, we are going to have questions for the two presenters before we go for the Zoom session. So, Dr. Safi and Kitua, be ready for the question. So you are welcome for if there is any question.
Thank you very much. I have, I think, 2 or 3 questions to Dr. Shafi on regard to the case that you presented. First, do you have the initial CT scan of this patient? And secondly, do you have a protocol for tracheostomy in severe traumatic brain injury patients? Because I've seen you have taken 13 days to do a tracheostomy, and I think this, I mean, we should be able to predict and do an early tracheostomy. So do you have a protocol on regards to the tracheostomy in severe head injury patients? And you told us that on day 26, the patient aspirated. Do you have any evidence for aspiration? Did you get an an X-ray, or there was any evidence that the patient had aspirated? And the other thing is just an advice or a comment. Can't you do ICP monitoring at MOI? Or would you just need, I think the machines that you have, the monitors, can do ICP monitoring. And why don't you use EVDs to measure intracranial pressure monitor with transducers? I'm sure you have EVDs, you have the bags, the pressure bags, and you have the monitors. I don't know whether you have the transducers, but I remember there were transducers in MOI ICU when I was there. So those are my few questions. Thank you.
Thank you for questions.
The first question on the initial CT scan, I don't have an initial CT scan. Yeah. I just attended this patient when he was admitted in ICU. And tracheostomy protocol, yes, now we have a tracheostomy protocol. Previously, we used to have a protocol which was not friendly. In the beginning of this year, it was, we should consult ENTs to review the patient and then to schedule the patient for tracheostomy. It was really tough for us and for the patient because you arrange the patient to undergo tracheostomy maybe on the 7th day, and the ENT has no time on that day, so you need to reschedule the patient. So I trained myself, and now I do tracheostomies myself. We do them very early, and our tracheostomy protocol is that you should anticipate within 80 days that you're going to do early tracheostomy as per Brain Trauma Foundation guideline. That's what we do right now. And evidence of aspiration, yes. The patient got sudden cardiac arrest while the relative were feeding the patient in the ward. And we saw that when we were doing suctioning the tracheostomy. Actually, the food particle were coming from, the porridge was coming out of the tracheostomy. Yes.
Thank you very much, Dr. Shafi, and I'm happy that now...
With ICP monitor, with the transducer that we have, they already expired, because we found that they expired maybe on 2021. And currently, we just, sometimes we try to improvise. We use the invasive arterial blood pressure monitor. We're just doing a testing, because we are not so sure that the real ICP monitor that we have currently can do that. The transducers, they are not working right now. Yeah.
Thank you, but I'm glad that you are taking note of that, and not only, we should not wait to get the proper ICP monitoring machines, that we should start, we can use EVDs, we can use transducers, and we can measure ICPs. And I'm happy that now, that at MOI we have a protocol for tracheostomies, because we used to have a high rate of ventilated associated pneumonias. I think the teaching in the ENT here at Muhimbili, and all ENTs everywhere who are graduated from here, they will only do ETV after 14 days. I don't know, 14, 13 days.
14 days.
And I've been arguing with them all the time, because the evidence out there is we need to do at least after 5 days, or when we predict that the patient can stay longer to prevent them from VAP and have all these things. Why am I saying this? I have an interest in this because I did my MED on ventilated associated pneumonia in severe traumatic brain injury patients. So I've been trying to educate them why we need to do early tracheostomy. We need to take them out early, prevent them from VAP. Cost is going down in everything. They stay in ICU, goes down, and everything else. That is the evidence out there. So I thank you very much, Dr. Shafi, for these changes. There's another question? Okay, Dr. Miranda?
Thank you, Doc, for the lovely presentation. So at your facility, do you have well-defined predictors for potential trach patients, or do you work on a Gestalt base? Or question one. Question two, how frequently do you do your ABGs, and what exactly are you monitoring?
For we have the predictors that we use. We do the patient assessment firstly on the first day that when we have admitted the patient in ICU, the GCS. So you receive a patient with GCS of 5. On the 3rd day, you don't expect this patient to be extubated maybe on the 7th day. So you plan tracheostomy beforehand, very early tracheostomy. So after 5 days is where we discuss as a team that this patient would be prolonged will be intubated for a very long time that we don't know. So we plan tracheostomy at that time. And we do ABG for this patient. If there is no any change, we do twice a day, in the morning and in the evening. When we are passing morning round, we have to see ABG of these patients so that we can see the CO2, we see the lactate, we see sodium, and the other electrolyte and ventilator parameters that we assess on ABG that we have.
So you step down the vent modes primarily based on your ABG findings?
Yeah.
Thank you. Because the ENT boss is here, you need to give us a little comment on this.
I mean, a woman caught off guard. Good morning, everyone. I think it was, I came a little late, but I think, why do we do tracheostomy in the first place? I was actually wondering, did you invite ENTs in the first place in this meeting? I think they were supposed to be here. I think they're very, very important, washikadau, yeah? So the most feared, why do we do tracheostomy? I think you know the reason, because of tunaogopa, tunaogopa subglottic stenosis. And in my practice, I'm actually an ENT surgeon for 9 years. I've seen only one case of subglottic stenosis in my entire, so I think it's a very, very rare late complication of prolonged intubation. So maybe that is one reason why ENTs are a bit worried, they're a bit reluctant to do a tracheostomy very early. And one reason is, patient akiwa prolonged intubated, there's that procedure of weaning it off, and you have to train the relatives and stuff like that. So I think their reluctance is because of the complications are very, very rare, and the weaning is also a little, tricky. It's not something straightforward, and it's really, when you tracheostomize someone, they cannot shout, they cannot talk. You actually bypass the vocal cords, and so I think those are the reasons why ENTs are very, very, very reluctant. But of course, in my opinion, I think it's better to perform it early than to wait until, especially for severely TBI patients that you anticipate that they need it early. If you anticipate that the patient might be intubated for a longer period, I think it's prudent to perform it early, in my opinion. Yeah. Thank you.
And thank you. And our reason is because the studies that we have done in neurosurgery, patients with severe head injury, they tend, they stay longer with a tube, they get ventilated-associated pneumonia, which is associated to so many things, including mortality. So that, I think, we have taken the message, and I think the president will respond. Next time, we will have a talk on this and with why we need to take early. Sorry, I will come to you, Dr. Kukima. The president wants to say something.
Karibu, Dr. Mfuko. Yeah, my question is to you, Dr. Mfuko. I need some clarification. Despite having subglottic stenosis and other complications, do we have any standardized operating protocol on this case? I mean, SOPs or evidence-based medicine, because if you depend on personal thought, it's like a level 3 kind of evidence. So what evidence do we have? The right time to do it?
I think now it's starting to be the ENT war.
Yeah, actually, kuna guidelines, lakini actually sasa hivi tuna develop standard operating procedures. Ni kweli, yani katika hii level ya care, huwezi kusema unafikiria tu. Yeah, I think I point taken, and please next time invite the ENT guys, please. Thank you.
And I think neurosurgeons in your training, some of us, where we were trained, we were doing tracheostomy as ourselves. Percutaneous tracheostomy. I think we need to do tracheostomy early. Dr. Kukwema.
Yeah, thank you so much for nice presentation. My question goes to Dr. Kitua. I just want to know, in the setting of postpartum intracranial hypotension, like how often are they doing epidural blood patch, and which kind of imaging modality are they using to ascertain the location of CSF leak? And for instance, in that patient with persistent headache for a month, they did evacuation of subdural hematoma. what about the CSF leak? Like, how did they control it so that the secondary complications cannot recur? Thank you.
Thank you. These are all nice questions. For our patient, the presentation was rather progression of the subdural hematoma that was already there following the CSF leak. There was no evidence of a persistent CSF leak. So following the hematoma evacuation, the patient progressed well and did not require any further intervention in terms of CSF leak post-dural puncture. So for these patients, it is rather a clinical diagnosis and does not require imaging evaluation. For patients who have had neuroaxial anesthesia, they will present early with a headache. You try conservative management, which includes rest, adequate hydration, and analgesia. And this does not seem to resolve within the first 2 days, or at least improve. Then you consider an epidural blood patch. And this is actually done by anesthesia colleagues. So there is no need to do any imaging at that point in time. The only reason to do further imaging is when a patient presents with a prolonged headache, persistent and severe, or other neurological deficit.
They locate the CSF leak before the blood patch, and then when they're doing a epidural blood patch, are they doing like in CT guided or fluoroscopic guided, or they just do it? That's my question.
Okay, thank you. The question is twofold, and I would like to leave the latter part of the question to our anesthesia colleagues. I think Dr. can speak on that regard. But with regards to where they locate, the patient has had a lumbar puncture for neuroaxial anesthesia. So it is clear that given there was no any other intervention, the lumbar region is where the site of the CSF leak will be. Yes.
So, the spinal anesthesia is done at L4-5 level, right? So that is the area where we suspect that the CSF leak will be coming from that, the puncture at that level. So they usually, anesthesiologists, they usually do another like spinal anesthesia, but they draw the blood, they go to the epidural, not the epidural level. You can do it under CM guided, or you can do it by the normal intervention using just anatomy, and then you inject that blood clot into the epidural space. So by doing that, that blood clot is going to tamponate the area where the CSF leak is. So we expect the CSF leak to be the same level at L4-5 where you did the lumbar puncture.
Just a comment. I don't know if we take it seriously because we do spine surgeries. We encounter CSF leaks, most neurosurgeons, and we know how to take care of it. In this case, I'm worried this was done by someone who didn't know how to put a needle. Yes, yeah, I'm talking in the sense of neurosurgeons. We encounter CSF leaks several times, and we have never encountered a hematoma or headache.
Thank you very much. Now I think we'll move. I know there are so many other questions because the next section is going to be an online session, and we are happy to welcome again Dr. Walter Mojin. Yesterday he was introduced here. We welcome you again, Dr. Walter Mojin. Thank you.
Good morning.
Good morning.
Right, everybody can hear me good. It was for me quite a complicated discussion with ENT and tracheostomy, but I hope you all had some peace over there.
No.
So this topic is also sometimes quite a debatable discussion. It's always clipping versus coiling. We recently performed a meta-analysis on this topic, especially on long-term outcome. I think quite relevant in low middle income studies is how your durability of your treatment options are. To quickly to repeat, no conflict of interest. Also, the co-authors did not report any conflict of interest of these studies. Just a small brief. Yesterday my presentation was a bit longer, so I didn't have time, but just to show you where the Netherlands is. It's a very, very, very tiny country. It's like as I was reminded last week, it's a little bit smaller than the National Park of Serengeti, in between Germany and Belgium. So it's not part of Germany. It's a very sensitive topic for Dutch people. So just to remind everybody, just to get to where I'm working, it's The Hague. So it's the center of the Court of Justice, and it's the city where the government is based in the Netherlands. I'm chairing for these 14 hospitals where we have neurosurgical clinics. These 14 hospitals, as you can scattered on the map, is area, catchment area of around 3.5 million people, 25 neurosurgeons, 14 hospitals, and average we have during weekdays 8 to 10 operating theaters solely for neurosurgery running. So that's quickly overview. Now back to the topic. The background is, of course, that like as you all know, coiling has become mainstay treatment for aneurysms after ISIT and BRAD studies, where these indicates lower rates of mortality and neurological disability at the short term. But of course, one of the main discussions already led us from Professor Spetzler and others, big vascular surgeons at that time, already stated, what about long-term follow-up? And so there are some comparisons, but I try to get back to this. I see, by the way, a question in the chat, I don't know. Yeah, okay, probably not. We'll see if it's a question for me later. So the background is there really like long-term follow-up to back up this statement? And as many know, like after the new intervention studies, also recent FDA approved implants after a longer period had problems. So we're more interested in what happens on long term. So the purpose of our meta-analysis was to perform this analysis of long-term rates of reoccurrence, retreatment, rebleeding after clipping and coiling. So we include all RCD probabilistic studies and in the end also some retrospective cohort studies. The study had to present efficiency, outcome, intracranial aneurysm treatment, and studies with surgical and an endovascular arm of at least 10 patients each. Median follow-up had to be at least 3 years, and we will show you later on, but there was also many studies with longer follow-up. We had a pooled analysis for rate of recurrence, retreatment, and rebleeding. We were trying to also add in, especially this topic, funnel plots, and also to assess publication bias. And we had the meta-regression for characteristics of the study patients and their aneurysms. So to quickly show you the flowchart of this meta-analysis, we had in the end almost 5,000 studies. We excluded a lot based on quality. We have on abstract and full text. Then we had to exclude patient series which didn't have enough follow-up time, and also the interventional arm. So literature search, we performed this in 2018, total amount of studies back then, and 11 articles were left after selection and exclusion. So in the end, we included 4,500 individual patients, 4,700 targeted aneurysms, and the mean number of patients in these manuscripts was around 176. And the median follow-up time was 55 months with a big range I'll show you up later. And only one study showed a follow-up range. These studies in total had 2,500 more aneurysms treated with clipping and 2,000 aneurysms treated with coiling. So in the end, we were happy to find almost, like both groups were big enough to have a conclusion. So here you can see the conclusion, the length of follow-up study, and you see we also have quite a number of studies with, in red, also time with follow-up with angiography. So there are also a lot of studies only clinical follow-up, but we also have quite some studies with aneurysm follow-up. So first of all, what's the recurrence rate? And here you can see the comparison study. So here in the red, I see the recurrence rate. So you see the total events, the total amount where you could find it, and there you see that that there was in the end a tenfold higher chance. If you can see here on recurrence in coiling patients in longer follow-up, and of course in this state it favors the clipping, so there was less chance, of course, than it favors. And you see there's a very statistical but also clinical relevant difference between recurrence rate between clipping and coiling. What also is quite relevant from this topic is that recurrence came not necessarily within the first follow-up period, so the recurrence can come in 3 months or 8 years after recurrence. So after this meta-analysis in the Netherlands, it's now obligatory to at least follow up patients after any form of coiling at least 10 years. One study reported a median of 14 months to recurrence, and there was one study who only reported a range of recurrence, so we cannot see exactly how many patients were recurred in the 144th week and how many in the 54th month. Retreatment, that is of course more relevant. All clinicians know that after coiling you can see some recurrence, but the question is it like really a relevant recurrence? That's of course the question. And this is an indirect way where at least you could see that it was a relevant recurrence because it was retreated. Again, here you see a higher chance and of course relative risk in this case higher, and therefore also a higher effect in the group where coiling was. And we're, by the way, still interested to see that also clipping there is a chance of retreatment, but it's very the relative risk is very low. And then of course in the end the main or the worst outcome, of course, or failure of retreatment is that you still have a rebleeding. First of all, we found out that it is happening. We're also interested, by the way, in this case series was a very, very small arm of coiling, Lehečka, that is like originally Czech vascular neurosurgeon who was working at Hennis Niemi's clinics in Finland. So you can see that they had a far more preference of clipping aneurysms, but even they found a re-bleeding in one clipped aneurysm. But again, here also the retreatment, the rebleeding chance is higher in the coiling arm, and there was a very far chance related to that. So publication bias, like here's you can get this triangle, and there you see that you when you find your outcome in this triangle, it is always important if you see in the end your result, which is we found in the meta-analysis here, that you have publications on both sides of the triangle. If this is lacking, then you could presume that there should be some publication bias. In this case, there is none. So to get to our discussion, so surgical clipping compared with endovascular treatment is superior for concerning long-term follow-up. Coiling was associated with 9-fold risk for aneurysm recurrence, and a 4.5-fold risk for retreatment and 2-fold chance for rebleeding, which means one of the main things is that these patients will have to be followed up at least for a very long period. And of course, in many cases where you clip an aneurysm, we also totally remove it from circulation. So these patients we don't follow up unless we are like in some chance after 1 year, but then we stop for sure. But the coiling, what we've also found in this meta-analysis, that the problem is that the recurrence can also come later, even some cases after 8 years. Of course, we had the limitations, so there was the limitation of the number of studies. We didn't have the analysis which we could perform for the safety. Individual studies can still be selection bias. We saw quite some studies where there was a substantial conflict of interest by the authors, and only on the financial, but also probably the fact whether or not they were radiologists or neurosurgeons performing the study. But all the other problem was that the recurrence was scarcely reported. So there was also a problem for us to include patients. And of course, the strength of the studies was in some cases low. So recommendation, take this in mind. So of course, like your endovascular treatment can be fast, but there is a very high retreatment rate, over 16%. So when a patient is treated with coiling, you have to take into account that there is a chance that they are not treated. Long-term results are very important, and like what now is very common, at least in the States, and in Europe, is a discussion about web device and other devices. And here we see that especially the research is lacking for long-term outcome. So that's another, we performed another meta-analysis and review. It is very important to first have your long-term follow-up where you implement novel devices. So more prospective long-term studies should be done before, and also to monitor and see if patients really get very good treatment. Okay, and that was quickly my talk. Just wanted to have some quick pictures of my experiences the past 3 years at the very beautiful team in Moshi, Tanzania. And I don't know, I think Gabriel is logged in, but otherwise, thanks sir again. And just for the colleague on the other side, I can exactly the picture where you can find Vermeer's paintings in The Hague. Thank you.
Thank you very much, Dr. Mujen, for the talk. So now we welcome, if anyone has a question, you can ask. We allow a few questions because we are going to have a guest of honor in a few minutes to come. So anyone?
Thank you very much, Dr. Mujen, for this talk. And this topic, as you lightly introduced, it is kind of, people have different opinion depending on what they do. My personal experience, I was in a unit where, when I was training, I was in a unit where we only used to do clipping. Then we moved to coiling. The same person who was clipping everything turned to be the person who started to do coiling of everything. So there's a lot of bias in this paper, and for us to make that conclusion that one is better than another, we need to have a longer study for the coiling group, because most of the studies with the coiling are fairly, they do not have longer time compared to the clipping group. So it is, there are a lot of biases in this topic. But what would you have done to a patient that is suitable for both coiling and clipping? Would we choose clipping or coiling?
Yeah, thank you for your question. I think you could also probably ask in the audience. You get many different responses, I presume. But it's a good point, like which we found out. Of course, like we know that in the studies which were done earlier, is that there is a superior effect for coiling on the short term. But don't forget, like these studies were done with bare coiling. So it doesn't until what we see now a lot is using stenting and all kind of other devices to close up the aneurysm. That is very debatable if that is such a like a safe treatment. And so I think what we do a lot in our clinic, we have all centralized from the 14 hospitals aneurysms in one clinic. And that is that we make sure that we have all the experience in one center. And we have a very great cooperation with our interventional radiological department. And we have also one neurosurgeon and one neurologist who are performing endovascular treatment. And actually, I think that's very important to see from both sides. So I will always be asked every aneurysm which they will try to is suitable for treatment if the patient is good enough after aneurysm bleeding. Then I will discuss with the group of interventionists, and then we see from both perspectives if it's good. So if it's so for standardly seen, so medial artery aneurysms, we almost always clip the aneurysm, anterior circulation, if accessible. Then if it's not easily coiled without any stenting or a balloon, we will do clipping. In the posterior fossa of the pica, then usually we do surgery, but if it's, of course, all basilar aneurysms are basically always coiled. I hope it will answer your question.
Thank you, Professor. My comments on the studies, if you look at the data when you are realizing the recurrences or retreatment or rebleeding, if you compare the microsurgical clipping vis-a-vis the coiling, you look at the number of the cases that were done. Of course, if you look at that data that you showed, it looks like the clipping is better because sometimes you see like in the data events that occurred is 199 vis-a-vis. They say this data, yes. So if you look at the numbers, coiling vis-a-vis clipping, you see the numbers of the coilings are 1,000 vis-a-vis the microsurgical, which are very less. So I think when you follow them up longer, the people on the coiling probably will get significant outcome in a long-term effect vis-a-vis the clipping that has been there for ages, and the outcome seems to be almost the same. I don't know what is your opinion on that.
Yeah, I think that's a good point. Like that's of course we see higher numbers, so that is at least what we concluded. That so this is a point we should take into account. Also, what I like discussed with the previous author, we now or the previous question was asked by your colleague, is we need better studies. So that's another thing. So like this is, you can see that we included 2,000 patients, but like in the end we found only 1,446 patients suitable for follow-up. So you see a lot of loss to follow-up, and the question is, are these patients the one who have even more recurrence? It's also possible, of course, or less. So that is difficult. So that's why we now are performing. We started basically 5 years ago. 3 PhD students started with ran a study where we prospectively follow up all the aneurysms in the Netherlands, and where we have quite some practice variation. For instance, in the department in Amsterdam, they basically coil everything. There is hardly any surgical performance. And we have a neurosurgical clinic in Rotterdam where there is almost everything is clipped. And in our departments, we have a little bit more like in the middle approach. And that's also interesting. Perhaps then we see if we can have the long-term results, which of course takes 10 years from now still, then we hope also better to see if what is now your real burden of healthcare. Also financially, all these patients have, the coiling have to have MRI scans, at least here in the Netherlands, because patients want to be sure. If they don't, because they read also our research, the patients nowadays, and they know that they can have a chance of recovery. So they want the MRI scan. So that is a good point we have to take into account, I believe.
Yeah, thank you, Prof. But the other thing, if you can comment, please, it's on the learning curve. Can you comment anything on the learning curve between the two? Clipping vis-a-vis coiling, the learning curve.
Yeah, I think a real good question as well. We see, so for instance, in our country of around 18 million people, we see that we nowadays clip around 200 aneurysms after bleeding. So for in our clinics it's around 60. We have 3 big clinics now around the clipping, and that you see that you need also to, like I'm now performing these surgeries around 13 years now, and there's also a problem like 2 of my other colleagues who were doing it, they are retiring slowly. So that is of course a big debate how to train these new younger neurosurgeons to be able to still clip an aneurysms. But like you said, the other side, like you have for the radiological department, we have 6 interventional specialists, one different, and so one is neurologist, neurosurgeon, radiologist, and also they have a learning curve. And since they're doing a lot of interarterial thrombectomies, that is their main on-call problem, that they have to treat cerebrovascular diseases, and the amount of aneurysm they do per person is also not so big. So in the end, from our 6, we have 2 who are really senior in clipping any coiling, any complex aneurysms. So also they have quite a learning curve, and probably in both cases, whether it's endovascular or surgical, you lead after after 100 cases, probably you should be able to be well trained. So it means that you, for a neurovascular surgical clipping, you at least need a couple of years. And the same is for radiological treatment. You need a couple of years before you're a good trained.
Thank you, Prof. And Dr. Shabana has a comment.
Yeah, thank you, Dr. Muji. What I'm trying to advise here is that the coiling is a minimal invasive compared to clipping, and I think we should promote coiling regardless of what is happening. What we need to do is to improve on patient selection, to involve the radiologists and actually help the coiling team to predict those cases which are of high risk of complications, so that we can streamline the process and the procedure. And the other thing is also to have a uniformity in the skills training in this part of the world about the coiling.
Thank you, Dr. Shabani, because we are, thank you, Professor. The other thing that I wanted to comment, and whether you can comment as to end with this topic, we should not forget that let us tell the patients and their relative, decide. We should give them options and let them choose in order to avoid the biases that we have. Now that the world has changed, we have interventional neuroradiologists and things. We explain to the patients and relatives and let them choose. The problem is, I think one of the problems, we have biases. If I am clipping, I'll only tell them about clipping. I'm not going to tell them about coiling. So let us give patients and their relative options. Thank you, Prof. So we are preparing for the guest of honor to come, and I think we'll give them a few minutes because they need to rearrange the setup for the guest of honor. Organizing committee, thank you.
New York. So just by introduction, the spine navigation system in background, it was just initiated just until in 1990, and this was by the work of Gesbein and Robinson classification system for screw accuracy. So the purpose of the neuronavigation system was to make sure that the screws which are inserted to the patient, they are accurately inserted to the patient. So this is just the classification of the Gesbein and other colleagues, in which you have class A, B, C, D, and E, in which class A is the screw is properly placed at the pedicle screw. Class B is just off by less than 2 millimeter. Class C is when the screw is just off the pedicle by less than 4 millimeter. And class D is when the screw is placed by less than 6 millimeter off the pedicle. And class E is when the screw is off, completely off the pedicle screw. And others are just the other views in which you can see how the screws are properly. So this is the system which guide a surgeon in order to improve the accuracy. And previously there are many trials which were done outside in animal, but in 1995 it's the one which was just a trial in vivo. So there are several evidence in several papers in which other papers were just trying to see the accuracy and reliability of spinal navigation. And this was just analysis to see how the neuronavigation system can well suit when you use it. And also other studies which comparison of the 3 imaging and navigation system regarding the accuracy of the pedicle screw placement in a sawbone model. But all of them just we are trying to see how the neuronavigation system regarding the spine, how does it work properly. But the other studies were just on comparison on the neuronavigation system versus fluoroscope guidance on the pedicle screw placement on the accuracy and complication rate. So first of all, on using the 3D neuronavigation system, which we are currently using at MOI, which is the Brain Lab, this one has an accuracy of about 95%. But there are other neuronavigation system. For example, this is the Meditronic O-arm, in which you have it in the OR, and you do like a CT scan. This one has an accuracy of almost 98%. But the fluoroscopy, which most of us neurosurgeons they don't have the neuronavigation system, this one has an accuracy of approximately 90%. So the aim of using the neuronavigation system is the first, apart from the accuracy, to make sure that you place the screws accurately, but the neuronavigation system reduces the radiation during placement of the screw. So in our setting right now, we have started using this, we have this Brain Lab neuronavigation system in which when you use it, you do fluoroscope, but the fluoroscope that you use is just to localize where the lesion is. And then another fluoroscopy, you do it later when you have already opened the spine to localize and make sure that you are at the same site where you are supposed to operate. And the last one, when you want to do the control and see if the screws are properly placed. So it's like you are doing 3 fluoroscopy. So the type of neuronavigation that we are having currently is the Brain Lab Kick 2.0 navigation system, in which this one is as it shows on the picture. It is a sleek design with a high performance. It's a full HD capacity, and it's a touch screen, and it has it's a patient-centric data in which you can put all your patients into the system of neural navigation system. And also, this one is compatible with all current brain lab elements application system. So this currently that we're using is only for spine, but the brain lab neural navigation system has several components. You can use it for radiotherapy, you can use it for also cranial neural navigation system, but currently the component that we are having is only for the spine. And also it has a optical tracking with the laser guidance, in which you can use the laser and track exactly where you are right away when you are operating the patient. Also, it's a portable one, compatible, so it's movable. You can move it in any theater that you want to move it. So these are just the images which you can acquire. The first image on your right, what you do is you take the CT scan, you put it in the brain-light neural navigation system, and then it will bring you a 3D reconstruction of the spine, in which you see it in the first image, which is the 3D model of the spine of your patient. And then other images, you can have a 3D, you can have an axial view, a sagittal view, and a coronal view to see exactly where you are. So when you want to register now, you can, after registration of the patient into the system, when you touch any point into the spine, you can see the spine in 3D model. So the other picture or other image on the right is now on patient registration. So after the installment of the CT scan into the 3D, into the brain lab system, you are required to register the patient. And this is done after exposure of the site where you want to do the surgery. So on this picture, there is, sorry. There is this array, we call it a patient array, in which you have to attach this array into the spinous process, or you can attach it into the iliac bone, so that this one has to be fixed. It should not be moving, because when you move this one, it will distract the image which you have acquired. So this one is fixed into the spinous process, and this one has to be fixed in the spinous process, in which it's very close to the area where you're operating. For example, when I'm putting the screw maybe here, or at this level, I can put it at this level. So after putting the array at this point, we have another system which has the camera, in which that camera will point directly at this patient array, and the camera will see this one, and it will transfer the image information from the patient directly into the neural navigation system. So the second is now we call it registration of the spinal level, where you to register the patient into the neural navigation system. So we have the probe, in which you will do like 16 point into the lamina and the spinous process of the patient. So these were the points where you have to touch each and every time. And after full registration, the neural navigation system, it will tell that the spine model has been fully registered, and you can use this array to test the accuracy of the spine model, in which you can touch at any point, maybe at the spinous process, and have, or anatomically at the site where you want to insert the screw. If you are accurately register the patient, you can see directly that you are on the pedicle, or you are in the transverse process, or you are on the lamina of the patient. So for example, here we have already registered our patient, and then the next procedure is screw planning. So on the brain lab system, you can preoperatively plan the screw size and the site where you want to insert. So this we plan at this point, for example, this screw, we can plan the thickness of the screw and the length of the screw in which we want to put. And then this is an array, a laser array in which it points exactly at the site where we want to put the screw. And this is just an axial view, and this one is the lateral view. So you can have 3D neural navigation system, which you can see at the point you have an axial view and lateral view, and also a coronal view of the point where the screws you want to put into the patient. So these are the instruments that we are using in the neural navigation system. So this is the table of the nurse, in which the first one, this is the screwdriver. But this screwdriver also has an array like this. You can see a 3 balls point, in which these arrays are the ones which they point directly to the camera. So this one you have to show it into the camera, and the camera will read exactly the level where you are into the patient. And also this one is the tap. Number 3, this one is this one we use as the pointer, or the laser pointer, to point exactly on registering the patient. Number 5 here, this one is the pedicle finder, in which currently we don't want to use it because it's distract the images. So you can use this one, or the best one is to using the drill. And then this one is just an awl, like any other spine cases that you can have. But all of these, and this one is the calibrator. So all these instruments, before surgery, they have to be calibrated by the nurse by using this calibrator here. So in history, the Brain Lab Foundation, which has their headquarters in Germany, with a collaboration between the Weill Cornell and us here in Tanzania. So in 2024, they had an agreement of initiating brain labs, using a brain lab system by Dr. Hato, in which they usually use this brain lab in New York. So they agreed in 2024 that they can donate a brain lab neural navigation system, and also this neural navigation system can be used in lower income countries. So by the good collaboration between us and Weill Cornell, and the good leadership and trust of Dr. Shabani here, so they agree to donate a set of a brain lab which is for spine neural navigation system. But previously, they were coming with this neural navigation system. They do surgery, and then they go into, when they go back into the US. But in 2023, they agreed to bring the brain lab neural navigation system into our country. So far we have in 2023 and 2024, we have managed to do some cases in which in 2023, while we had a camp, we success to do, we did 3 cases, in which 2 cases here were successful. All the screws were successfully placed, and for one patient, the screw was misplaced. So these were the cases which were done during the camp with the supervision of the visitors. And then after they left, we had 11 cases in which we are doing, in which because we were in learning curve, 7 cases, we successfully did 7 cases, and 4 cases were abandoned because of the poor registration system, because we are not very competent in registering this patient. And almost two patients, some of the screws were not properly placed. But in this year, they came again, we did a camp. Here they had, during the camp, we did 3 cases, and all the cases, the screws were placed very well. We have some reasons why these screws were very well placed, because we inverted the drill in which is, it doesn't make the patient to move so much during the surgery. And then after they left, we also did 5 cases, in which 4 cases the screws were placed very well, in which 1 case the screw was not very well placed. So just by summary, we have during the learning curve, we have a significant improving while using this brain lab neural navigation system. So this one is just an example of the patient with a degenerative spine disease with 3L4 spondylolisthesis, in which these screws were placed, were inserted using the brain lab neural navigation system. So we have also another cases in which 6 screws were inserted using the neural navigation system, and all the screws were properly placed. So there is one case in which there was some kind of poor registration. So this one is the case which we were doing during the surgery. But when you see these X-rays of the CM postoperatively, you might find maybe one of the screw here is not properly placed. But this patient soon postoperatively, he did another. We were not sure about this screw, and this patient had some weakness on the right limb, and right away he did a CT scan in which the screws were right here into the nerve root foramen, and this one were revised as soon as possible. And these are screws after the revision. So because we are on the learning curve, these are the things which you might expect while you are on the learning curve of the new system. So this is the graph which shows our learning curve using the neural navigation system. So the numbers in bracket, these are the number of screws that we insert into the patient, and this is the time the time from which we are starting inserting the screw. So this patient the screw was inserted, 6 screws were inserted by almost 150 minutes for this case. After this case, another case, 4 screws, we tried at least, we inserted it at 65 minutes, in another case at almost 70 minutes. So here another case, in this case you see there is increase in time, but the same screw. In here we had another nurse which didn't understand very well the brain lab, and then the time shoot up to almost 140 minutes. But during this time while we are learning, we found that during using the neural navigation system, the area in which we placed it, there was too much movement, and there was poor registration of the patient, in which we are bringing some errors, and some other times we have to register again the patient in order to attain the accuracy. So one of the things that we observed is while we are using the pedicle finder, we are using too much energy, and we are causing more movement into the patient. And we invented using an orthopedic drill, in which this system has a drill guide in which you can navigate this drill guide. So after the introduction of this a drill system, you can see here we placed 6 screws in like 65 minutes, and then 4 screws in less than 60 minutes. Another 6 screws recently were like in almost 50 minutes. So it seems that the introduction of this together with uh, acquiring knowledge on how to handle the instrument, and the same team that we are using while placing the screw, we have improved it significantly on how, on the time factor on placing these screws and also on the accuracy. So currently, there are some studies which are going on in which we have the qualitative study, which is about the experience of using brain lab and neural navigation system at MOI, in which we are just asking residents and surgeons which are using the brain lab system, how do they, the experience of using the neural navigation system. And also we have another study which is a quantitative study of about the learning curve, the phases in which we have currently, we're in phase 4, in which the first phase is when previously the introduction, when the neural navigation system was introduced, and the next phase is when we had visitors which are coming, and another phase is when we were doing it alone, and the last one when other visitors came. So also on the last phase where new visitors came, we also learned that in order to improve accuracy, we have to register in each and every level when we are putting the screw. We have to re-register again the patient so that we improve the accuracy. So if there was any movement while we are putting the first level, we can remove that in accuracy by registering again that next level that we are putting the screw. So our future is we want to do at least one case per week, and also to use the same team that we are present, the nurses together with the surgeon, so that we can all be aware of the brain lab system, and then later on we can introduce other people's coming to learn until all of us we become familiar about the brain lab system, and also to decrease the length of screw placement below the 60 minutes. And also the future, in the near future, is to use the brain lab neural navigation system for the brain. So these are just some of the pictures while we are doing the brain lab neural navigation system. This is one of the fellow, Dr. Sengua and Dr. Magogo. This is Dr. Hamisi, and you can see here, this is the drill that we are using on finding the pedicle. And this was the visitor surgeon from the US. And this is Dr. Shabani trying to calibrate the instruments before the surgery. Thank you.
Thank you, Dr. Salim. I think we will reserve our questions for the next session. Thank you, sir. So I'll let the MC continue with the program for now, then we'll get back to the academic sessions. I think our guest of honor is just around. Thank you. Miranda, welcome.
Thank you, Dr. Umba. So good morning once again. When the guest of honor arrives, we will all rise to welcome her, and then we'll proceed with the official part of this ceremony. Thank you. Kindly be seated.
Hello. I can see we are all waiting, and we continue to wait. Prof, anyone with something who wants to tell us something, some story or anything funny? People are sleeping. Prof. Yes, Prof.
And I should entertain them?
You're a good entertainer. I realized that yesterday.
Okay, that's a challenge, to entertain this room full of people. I'll tell you what I'm doing here. I'll just share. This is total transparency. I'll share what I'm doing, which is Barrow Global, which is housed in Moshi, and the faculty, it includes Dr. Carrie Vaughn here, is starting a Barrow Global quarterly newsletter that is going to be about the public health aspects of what we do as neurosurgeons. And, you know, please tell me to just give me the hook when the Minister of Health is here. Okay. Okay. Well, while we're waiting, so one of the things that I think we've talked about collectively and individually is this aspect of going from the primary responsibility that we all know that we have. Dr. Otham mentioned as well. It's that Hippocratic oath, you know, that we all take to take the very best care of the patient in front of us. But in our global world, this professional responsibility has expanded to include a second professional responsibility, and that is to advocate for access to that kind of quality neurosurgical care for everyone, everywhere, not just the one who's fortunate enough to be sitting in your clinic or Alvin's clinic or your clinic, Henry. And so what does that mean? Well, it means that we need to sort of grapple with public health issues. And really, a lot of the running theme behind the surface of this meeting has been that intersection between our desire to care for patients one at a time in the best way we can, but running in the background of that professional endeavor are public health issues, right? There are issues with the government not paying adequately to support the needs for spina bifida care, so that donors have to do it. There are public health issues related to the safety of roads or enforcement of helmet laws, or whether there even are helmet laws, so that TBI becomes a huge part of what we do. So even though at the top of your license, you're able to clip aneurysm, you may be spending 40 or 50% of your time doing things that are just as important, but, like taking out big subdural hematomas, but they require less technical skill of you. So we're thinking a lot together about that intersection between the problem that you face with your individual patient and always thinking in the background how that patient's issues are magnified, and that forms that aspect of public health nationally and internationally that are in our domain and that we're the experts for. So that's TBI, that's stroke, that's all degenerative spine conditions. And when you look at hydrocephalus, metastatic brain tumors. So when you look at it that way, our small specialty, and we only have somewhere under 50,000 neurosurgeons in the whole world, and we need another 23,000 or more. So we only have 2/3 of the number we need. But think about all of the public health that we are responsible for, caring for, when you think about those conditions that we treat. So now I'm getting pretty philosophical, but if you think about your life in neurosurgery, you only have, 30 or 40 years, if you're lucky and healthy, to be able to make a difference in that way. So I think it comes to all of us to think about, well, how can I make a difference? We're all just putting our own little brick in the wall of human existence over space and time, and, you know, what do I want my little brick to look like and feel like? So anyway, that's what I was doing when you asked me to step up and say a few words.
Thank you very much. I think you have sparkled out something, and Dr. Shabani here wants to also comment. Karim.
There's a lot of opportunity in the global neurosurgery projects. And I'm wondering how we can involve ourselves in those projects, because most of my colleagues here, if you talk of public health, they think about HIV, malaria, and anything which is no surgery. And if you talk of any neurosurgical disease as a public health issue, and then another challenge comes in, the knowledge of research, the knowledge of attending conferences and presenting. Not only that, developing registry. This is out of context of many here. And even our training programs do not actually address that issue. So where do we start? Because how do you pick someone who doesn't have this kind of background into the global neurosurgery project?
Well, I'm happy to tell you that your executive committee of the inaugural meeting here of the Tanzania Neurosurgical Society has determined that one way to do that would be to join the G4 Alliance. So they're becoming members, and what that means on a practical point of view is that there will be an opportunity for everyone in this society to be able to log on to monthly meetings of the people who are doing soda care all around the world. Or if you can't log on, there's a recording you can listen to when it's more convenient for you. Or if you don't have time for the 1 hour recording, you can look at the 80 slides in the deck that comes out every month. And so, but not costing you anything except your time and interest, you can start to know, well, you know, what is general surgery doing about this problem? What is ortho or anesthesia doing? How are the nurses globally trying to get organized? And that will both stimulate ideas that are pertinent to you, your hospital, your city, your nation, for things you can do. It'll also give you opportunities to contribute. And I think that's one very good way to get started.
Thank you, Prof. But also this meeting, to me and to some of us that we discussed yesterday, I think it brings the unity. You know, neurosurgery used to be identified only at one place, at MOI. Now we see great work that is being done at KCMC. This is good. And elsewhere, in Bear, in Bugando. And coming to these conferences, and we have ideas that we have been discussing, how to make this meeting popular and bigger next time, because we have small other meetings that we usually have, the conferences. We are thinking of uniting them, make them 1 week of so many other things together, so that we can get everybody around the world to come in and see. But it's also very important, you have shared, yes, we have so many public health issues in neurosurgery. We have recently having some changes in the healthcare policies that are affecting the neurosurgeons. So I think through this platform and having such topics being discussed here, we will be able to change this and air out. Because, you know, the politicians, we need to tell them. We are the technicians. We need to tell them. We need to inform them. They need to know these things. But with the guidance of our elders here, I think we should be able to do that in near future. But the other thing that in this meeting, also we have, you know, neurosurgery has always been partnered with orthopedic surgeons. This marriage started somewhere, I don't know, maybe Shaban knows how it started. And that one, I went to Dodoma, is is the same thing. I'm heading neurosurgery and orthopedics. So it looks, oh, you see, she's married to an orthopedic surgeon. So I think it's something universal. Where we meet, I don't know. We have orthopedic, please. Karibun, Dr. Masawe, you want to say something? Say, please. How do you see about this marriage?
Good morning, everybody. My name is Dr. Honest Masawe from KSMC. Sorry.
We shall continue later. Thank you.
Everyone, please rise to welcome our guest of honor. Honorable Umi Mwalimu, Minister for Health. Karibu sana. A round of applause, please. Please be seated. Honorable guest of honor, Honorable Umi Mwalimu, Minister for Health, ladies and gentlemen, distinguished guests, and esteemed participants, a very good morning to you, and thank you for gracing us with your presence. It's an honor to welcome you to the TNS First Annual Scientific Conference 2024. Our inaugural theme, expanding the horizon of neurosurgical care in Tanzania. As your Master of Ceremonies, it's my privilege to guide you through this day 2 of a 2-day scientific conference. It's a pleasure to see such a gathering of brilliant minds here today as we embark on this journey of knowledge and exchange of collaborations. I'm also filled with excitement for all the discussions and insights we've had and that we will have, the connections that we will undoubtedly shape in the course of our field. Together, let's explore new frontiers, challenge existing problems and paradigms, and inspire one another to push the boundaries for innovation. Kindly allow me to invite our TNS President, Dr. Othman Kiloloma. Thank you.
Good morning, everybody. Honorable Umi Mwalimu, Minister of Health of Tanzania, Deputy Permanent Secretary, Minister of Health, Dr. Grace, Director of Curative Services, dear participant, invited guests, ladies and gentlemen, my fellow neurosurgeons, welcome to this first neurosurgical meeting. First and foremost, we've passed through a long way for establishment of this society. And on course of the event, many things have happened which I would like to portray on my simple presentation. But before that, I would like to introduce various members of the delegations, various members, participants of this meeting. First of all, I would like to introduce our Vice President, Dr. Ngerageza. Secretary General, Dr. Ngaya Kaale. Our Treasurer, Dr. Mugisha. And this forms the Secretariat of Tanzania Neurosurgical Society. But also we have an international delegate, Professor Gale, who is a Professor of Surgery, George Washington University, Adjunct Professor Barrow Neurological Institute, who are doing great work at KCMC, but also she is a board member of G4 Alliance. I understand next month you're going to Geneva, Switzerland, possibly you'll meet there on discussions on multiple issues of health. Also, we have members from different areas of this country. We have neurosurgeons, neurocritical care nurses, radiologists from different hospitals. Please, for those who are coming from Muhimbili National Hospital, kindly stand up. or raise your hand where you are. We have those coming from Muhimbili Orthopedic Institute, right? We have those coming from Mbeya Zonal Referral Hospital. We have delegates coming from Benjamin Mkapa. We have delegates from Bugando. We have delegates from Zanzibar. I was expecting delegates from Haidom. Yeah, so this is a major team and participants which are available on this podium. If you allow me, guest of honor, if we can change position, I can give some short presentations on this. We have also delegates from KCMC. Yeah, we have also global fellows from Weill Cornell University, unfortunately not yet here. We have also other international faculty which are joining us with Zoom. These are world editor of major neurosurgical journals from Journal of Neurosurgery and the Journal of World of Neurosurgery. These are journals with high impact factor. Guest of honor, so this is among the participants of this meeting, but first of all, I'd like to thank the funders of this meeting, especially our platinum donors, and this is Gamma Pharmaceutical, and funding this event. So I'd like to take you through the global perspective of surgery and surgical problems. In global perspective, you can see the red markers which you see here. This is an area which does not have safe access to safe, affordable surgical and anesthesia. And our country, Tanzania, is among those. So in this world, 5 billion people do not have access to safe, affordable surgical and anesthesia. Our country, you can see, is one of them. If you look at the ratio between surgeons vis-a-vis the number of people, Africa, there is less than 2,000 neurosurgeons for 1.4 billion people. But look at the picture of Japan. It has 7,500 neurosurgeons with a population of 125 million. This is just about twice the population of Tanzania, and the country is quite small. If we decide to draw the picture indicating the number of neurosurgeons per country, you can see Africa is almost like not existing. It's like not existing. This is a world map where you can show the populations of practicing doctors in different areas. We are almost not existing. The number of doctors, neurosurgeons, and surgeons are quite very small. So you have a picture like this one. But if you, in this Journal of Neurosurgery, which was published about 3 months ago, it indicates that if you want to have a population growth of neurosurgeons, then the 3 things are very important. These are namely, which I highlighted by. One of them is National Neurosurgery Society, developmental aid, and the national gross domestic product. The Neurosurgical Society, Honorable Minister, is here. The other 2 things are beyond our capability, but at least we are one step ahead to start this Neurosurgical Society and push and assist on symbiotic way on training of neurosurgeons in this country and improving the neurosurgical care. We have a lot of collaborations in this country which have been made through a partnership from individual neurosurgeons to others. One of them is WFN, the World Federation of Neurological Surgery, where we have pioneer nurses for neurological training. Some of them are here. Please, can you raise your hand? Yeah. They underwent US curricular nursing for critical care nurses, and they are certified to perform their job. Unfortunately, the same problem, our scheme service not compliance to them. So they've already started training in Mana Hospital as well as Mbeya Referral Hospital. They are doing an incredible job. Thank you, Professor Gale, for this great job which you have done on initiation with collaborations with Tanzania Neurosurgical Society. Also, we have collaborations with Weill Cornell and Moi. We have Colorado University with Moi. We have Japan, Professor Hakaido with Benjamin Mkapa Hospital. We have Uganda Hydrocephalus Project. We have Barrow Neurological Institute, KCMC. They are doing a great job, and we can start seeing a lot of papers coming from KCMC, Madaktari Africa in Haidom and KCMC, and PNN Fitness programs and others. What's the situation in Tanzania? If you look at the situation in Tanzania, we have doctors at Moi, Benjamin Mkapa, Mloganzila, Mbeya, Bugando Hospital, KCMC, and Aga Khan Hospital. The total number of neurosurgeons are 25 in the whole of Tanzania. The population of 1 neurosurgeon to 2.7 million population. Recommended ratio is 1 neurosurgeon at least to 100,000 population. So we have a deficit of about 600 neurosurgeons. If you look at this picture, it denotes one thing. We have neurosurgeons on Eastern Zone, especially Northern Eastern Zone, Northern and Lake centers which can perform, but there is nothing on Southern Zone and almost nothing on the Western Zone. So a little bit more emphasis should be done, whether emphasis on outreach camps or emphasis of building up a center capable of tackling neurosurgical procedure. Training program in Tanzania, we all understand the MSc programs, which is, we have a College of Surgeons of East Central and South Africa programs where we receive patients even from outside this country, and we have some patients who graduate from this COSEXA program. One of them is Dr. Mayaya and Dr. Kivevele. I hope you're around. Okay. We have MED programs which has been accepted by the Senate of MUHAS for neurosurgical training. Pre-FALAB this year will be available. But also we have fellowship programs and PNNT training for nurses. As you understand, neurosurgery is not about one-man show of neurosurgeons. You need to have a well-trained neuroanesthesia, neuroradiologist, neuropathologist, and critical care nurses. Our theme for this meeting is expanding the horizon of neurosurgical care in Tanzania. If you look at the pictures, in relations to the population ratio, we thought we need to advocate in this meeting expansion horizon of neurosurgical care in Tanzania. Expanding in terms of the number of neurosurgeons, but also expanding in terms of instrument availability and others. We decided prior to this meeting we should do 3 activities on our secretariats. One of them was continuous professional development. This is a necessary part for any professional in medicine, as you have been guiding us through. Second, we did media coverage on themes of trauma, hydrocephalus, and spina bifida, stroke, brain, and spine cancer. Then we followed up with pre-conference surgical camps in 3 hospital. So this is CPD activities on one of the meeting. This is our fellow doctor who is currently in China, but we just had the time to discuss with him via Zoom on multiple issues of neurosurgery, but we had also Dr. Rabiel in charge of neurosurgery, KCMC, and that one from Bugando. But all institutions which deals with neurosurgery at Tanzania, they had to present every day, including our fellow colleague in Zanzibar. And I think this practice will be continuous not only through this conference, to improve and share professional knowledge which keep changing daily. We did pre-conference surgical camps in Amana Hospital, Mbeya Zonal Referral Hospital, and the Kilimanjaro Christian Medical Center. Why we decided to do these camps? First of all, we were astonished, amazed by countrywide investment of diagnostic services. We thank the Minister of Health, and we thank you in particular for the moves which you have taken to raise up the policy and being accepted by the government. But also we thank our President, Samia Suluhu Hassan, for taking an initiative and make sure that there is importance of improving diagnostic activity. We have CT scan in every referral hospital and the CT scan and the MRI in every zonal hospital. The only it's really amazing, something you cannot find in any country in sub-Saharan Africa if you take out South Africa, but the rest is quite amazing. So we started seeing a lot of patients coming to us, particularly stroke, diagnosed early. The number of other neurological ailments came early, and we thought it's important to do free surgical camps to various hospitals and share the expertise and see what's happening in those hospitals. So at Amana, we attended 8 patients in outpatient clinic, and there was 1 surgery of acute traumatic brain injury. This is the first brain surgery which was done at Amana. Dr. Mtei, thank you very much for doing this very successful. Almost 2/3 of our patients were done at Mbeya Zonal Referral Hospital. We operated 290 patients, and among those, we attended the 290 at outpatients clinic and operated 41 patients, had various surgical procedures, including craniotomy, brain surgery, and the stabilization of the spine. KCMC 101 were attended in outpatient clinics, and 20 cases of surgeries also operated there. Thank you very much, Dr. Shabani, for the kind job you did on the 5 days. Okay. The aim of our conference surgical camps was to train local surgeons, anesthesiologists, critical care nurses. And our team was not only neurosurgeons, comprised the same teams of local surgeons, anesthesiologists, and the critical care nurses. We also had the time to train medical students and share evidence-based medicine knowledge. We enhanced standardized operating protocol in theater, ICU, and general wards, as it is emphasized by your ministry you are leading right now. We had to learn also from Zonal Referral Hospital, particularly Mbeya Zonal Referral Hospital. We are astonished on the way they practice 5S Kaizen. It's quite a good example, I think, in this country. Also had the opportunity to perform surgery and attend outpatients clinic. This is an example teaching sessions at Amana Hospital, and that is the first neurosurgical operations which you said. This is our neurosurgeons, young neurosurgeons, Dr. Mtei. That's a nurse trying to demonstrate various. It was a team comprising a well-trained neurosurgeons, critical care nurses, and theater staff. Mbeya Zonal Referral Hospital has a catchment area of about 13 to 15 million. It's almost a referral hospital for 5 to 6 regions. We have noted there is a surge number of hydrocephalus in that area. We advise that possibly the neurosurgeons of Mbeya to be trained at Mbale Hydrocephalic Hospital in Uganda. Training usually is free under Cure International. But once they complete this, they'll be given endoscopic tower for free, which costs a lot of dollars, but also supply of VP shunts regularly. Currently, they just do VP shunts, and we understand the supply is not quite regular. So we think this will be a capacity building. Okay. We discussed with hospital in charge, Dr. Mbwanji, and accepted, and I think Dr. Kivevela, you've already enrolled for this. On the way, okay. Also, they have a lot of neurosurgeons which are on training. I think in the near future, 1-2 years, Mbeya Zone Hospital will be the second hospital to have highest number of neurosurgeons. I think 1-2 of them, they are completing this year. Dr. Mbwanji has a very, very good successive plan. And that he is taking care of these neurosurgeons in terms of their well-being and everything. One of them was supposed to be with us, but left April in India for training. He'll come back for exams and then go back to Mbeya. Amana Hospital, what we have noted, the strong thing, they have a very good emergency department capable of handling emergency neurosurgical procedures. They are equipped with a CT scan. Again, thank you, Minister of Health. The location is best for management of traumatic brain injuries patients, and there is availability of ICU. They lack trained neurosurgeons and associated staff. We think if there is a collaborations between possibly MOI and Amana, we can create a capacity building so that some of emergency neurosurgical procedure can be done at Amana Hospital. This is some of the cases which we did and operated in Mbeya Hospital. At one time you wonder whether you are there to take out the tumor or you take the child out of the tumor, because one is bigger even than the child itself. That one was on 8th day. The dedicated team which represented us at Mbeya, they had to work on 8th day and almost attended 80 patients on outpatients and operated that day 20 patients on the same day. This is another example we saw at Mbeya. This is the patients who had a fracture, as you can see, and they was being able to stabilize there at Mbeya. So maybe we should express this. Despite operating at, they lack some of the instruments, but we were able to operate these cases, and we had to order some of the instruments from Dar es Salaam. But there is a lot of efforts being done at Mbeya. We were able to operate brain tumor, Honorable Guest of Honor, this one at Mbeya. Actually, operations of this tumor, we need to have operating microscope. Despite lack of operating microscope, we were able to operate this tumor successfully, and patients was awake and discharged from ICU on day 13. We were not angels that we could do each and everything. No. A case like that is a demonstration, a case which is difficult. We were unable to operate. For those who are doctors and neurosurgeons, that patient is up and about walking normally, complaining of lower back pain. And you can see the kind of deformity and the kind of surgery which is needed. So these patients were referred to MOI for possible further surgery. It's not one-man show. It's a group of surgeons needs to do more, 2-3 neurosurgeons have to join hands. And it's a whole day job possibly. At Mbeya, for the first time, in my experience as doctor for the past almost 30 years, 23 years, we were funded by Chama cha Mapinduzi. So this is the office of Chama cha Mapinduzi, who paid for your air ticket to go and coming back, especially by the chairman of Chama cha Mapinduzi, Mr. Patrick Mwalunenge. So we had to visit and pay a courtesy visit prior to. Dr. Mbwanji is there. This arrival team at Mbeya. KCMC, I don't have much to say. It's a well-equipped hospital, and they have supportive collaborations from Barrow Neurological Institute. And they have neurosurgeons and neurosurgeons on training. And one of them have been awarded a Group 4 Alliance Award out of 74 applicants in all over the world. So it's a good hospital. Dr. Shabani, you see there. Dr. Sengua is here around? Yeah, Dr. Sengua, please. Just, yeah. Congratulations. Congratulations. So these are a number of surgeries which are performed. I'll go a little bit quick. So I'd like to thank the Minister of Health, executive directors of all these hospitals, Moi, Muhimbili National Hospital, Mbeya, KCMC, Amana, CCM Mbeya, and RC Mbeya. Thank you very much. I apologize, I forgot to, maybe I'll talk later, I have to be quick. This is an important, this is a very important slide here. I'll stay a little bit. It's a neurosurgery and the World Health Organization. As we know, on the 75th World Health Assembly, May 2022, we signed unanimously as a country a framework for research and clinicians to study and address national and global inadequacies. Among those, through IGAP, among those is advocacy of neurologists and neurosurgeons. Look at the red: stroke, hydrocephalus, traumatic brain injury, and brain and spine cancers. So we are needed to provide data of disease burden and need to IGAP for provision of intervention measures. So what we are asking on our strategic agenda, which I'm about to finish, one is research and publications. Research in terms of National Multi-Center, this is a powered research, so National Brain Trauma Registry, National Brain and Spine Cancer. We as a society, we are eager more than much to assist on this one, and we know we can assist the country to obtain fund from WHO through IGAP. Also training. I know training, everybody talking about it, but training not only of neurosurgeons, but neuroanesthesia, critical care nurses, but also now we are going for subspecialty training. Dr. Ngerageza is going for that. Scheme of service, it should be flexible to absorb those people who are undergoing subspecialty training. We should harmonize, standardize operating protocol. We have been studying different areas. We should have one neurosurgical operating protocol for the whole country, which we'll agree as TSA. And we have a minimum standard for establishing neurosurgical unit. And we need also to have a neurosurgical clinical audit framework. Clinical audit is different from the medical audit. It has multiple things, okay? As we are starting new centers, a lot of complications will arise. We need to tackle it very early and see and change the practice. Availability of commodity for health from NHIF, we need to participate, okay? We are requesting our participation as a society. We want not to talk much about it, so as a society when that thing arises. Honorable guest of honor, there is a say, if you want to go fast, go alone. If you want to go far, go together. We neurosurgeons, we decided to go together. And for this reason, we also decided that we want to go together with the Ministry of Health so that we can go far. Thank you very much. So I would like to take this opportunity to invite the Director of Curative Services so that can invite the Permanent Secretary. We'll invite our guest of honor.
Honorable Minister of Health, Umi Mwalimu, the President of TNS, DPS, Dr. Gracie, distinguished guest, dear colleagues, friends, good morning. Honorable Minister, first of all, allow me to thank you for setting aside your time to meet with this pure professional society of neurosurgeons. I understand how extremely your schedule is tight, but at least you managed to get some time to come and to talk with this society. We are here today for the inauguration of the new society of a very professional society in our country, the Society of Neurosurgery. Honorable Minister, just by way of background, inauguration of this society is happening today, but these professions have been in the country for quite some years, 7 lives of men in Tanzania, in many regions. But though there were very few, today we are inaugurating this society with about 25 neurosurgeons in our country, which is, of course, a remarkable milestone in neurological services in Tanzania. Because of the matter of time, Honorable Minister, I want to take this opportunity to welcome BPS to come for the few remarks, and then welcome you for your speech. Please, BPS.
Our chief guest, Honorable Minister Umeali Mwalimu, our Minister for Health, but also let me recognize the presence of the chair of the president of the Tanzania Neurosurgical Society, Dr. Othman, distinguished delegates, colleagues and friends, good morning. Honorable Minister, it is indeed a great honor and privilege for all of us to witness the first Tanzania Neurosurgical Society conference here in Tanzania. Hongereni sana. But I'm also delighted and honored to see such a distinguished group of neurosurgeons, clinicians, and staff from different cadres in the health sector. And this is the teamwork that I think Dr. Othman was talking about. But also it's my pleasure to see invited guests from around the globe. You're very much welcome in Tanzania. Honorable Minister, this first conference of neurosurgery, I'm sure will champion the action on scaling up neurosurgical services in the country, as Dr. Othman just alluded here. And we in Tanzania, we are not different from other countries. Our number in terms of neurosurgeons is still very low, but there's still much that is being done. And I must say that this conference has come at the right time, following the investment that the government has done. I wouldn't want to go back into that because Dr. Othman said it better. So I think the most challenging thing was, well, what do we do? We can't even detect. We can't even investigate what the problem is. Yeah, so now you said it yourself, and I'm sure the minister will say it even more, what the government has done actually within the scope of 3 years. And with this, Honorable Minister, I really want to applaud your able leadership, but also our President, Her Excellency Dr. Samia Suluhu Hassan, for the remarkable change that has been done within the 3 years in terms of improving diagnostic services in the country. And this has really enabled you, when you're doing your pre-conference camping, you are able to do your surgeries at Amana, Mbeya, KCMC. This is following the work that has been done by the government in just a scope of 3 years. Honorable Minister, as we gather here today to participate in this important conference, I want to remind my colleagues here that one way actually of increasing or raising the profile of neurosurgery services in the country is scaling up these services to other regions. Dr. Othman said it very well. Most of the neurosurgeons, actually, they're here in Dar es Salaam, but also places like, I think, in the Lake Zone. But really, what do we do now to make sure that we raise the profile of these services? I'm happy now we have a champion at Benjamin Mkapa, but also Aga Khan and also other hospitals that are, it's a small number, but there's a remarkable work that is being done. So one, I think, is what you have done to invite other colleagues, registrars, residents, but also general practitioners, because you have to emulate, you know, they learn from you. And I'm sure by doing that, most of them actually also be interested in joining the cause of neurosurgery. But as we wait to increase that number, what are we supposed to do? We cannot just sit there and say that we do not have enough neurosurgeons, we cannot do this, we cannot do that. So the minister will come here, but as a colleague and a friend, I really want to challenge you. And you started the challenge yourself. When you went out for your pre-conference camping, you see there was something you're supposed to do. You touched some people's lives. I want to tell you that we have a very open-minded minister. I've known Minister Umi for years. I've worked with her. She's very open-minded. So it's up to you as the champions, it's up to you as the people who are really specialized in the area of neurosurgery to come up with proposals, but also concept notes to the Minister of Health. What do you want us to support you? The ministry is here to support you. So there are some simple procedures like spinal bifida repair, but VP shunts, traumatic hematomas and such procedures. Those ones you can go out there, capacitate the registrars, the residents who are there, they can do it. And that actually will address one problem, the congestion that you have in the tertiary facilities, MOI and other facilities. Some of the conditions, they are not supposed to be coming there. They can be taken care somewhere else in the regional referral hospitals, and only those that cannot be managed there will be referred to your facilities. So the ball is in your hands, and we are here to support you anytime. Having said that, Madam Minister, I would now like to welcome you to the podium so that you can deliver your speech as you have prepared. Karib San.
Thank you very much, Dr. Gracie Magembe, Deputy Permanent Secretary in the Ministry of Health. Our hostee, Dr. Othmani Kiloloma, President with small p of the Tanzania Neurosurgical Society. We have only one president with capital P. Yeah. Dr. Hamadi Nyambea, Acting Director for Curative Services in the Ministry of Health. I'd like to recognize the presence of our esteemed guests from abroad, especially Professor Gale. Thank you very much for attending this important event. International and local participants, invited guests, media representative, ladies and gentlemen, habari za asubuhi. Allow me, before I proceed, to convey special greetings from Her Excellency Dr. Samia Suluhu Hassan, President of the United Republic of Tanzania. Of course, it has been said by Professor Dr. Othmani, Dr. Magembe, President Samia's visionary leadership has created a fertile ground for medical innovation and international collaborations in Tanzania. Our president's passion to health sector has always been the hallmark of her government, and the reason of my strongest will to work day and night to make sure her good vision on health services for all Tanzanians, whether in urban or rural areas, is realized. And Professor Samia's guidance, under President Samia's guidance, we have seen the blossoming of a healthcare ecosystem that is both inclusive and progressive. I don't want to repeat what has been said, but we all know that President Samia has invested a lot, has enabled us to invest a lot in terms of infrastructure, equipment, but also increasing number of healthcare workers, both specialists and other cadre. Ladies and gentlemen, at the outset of my speech, I would like to thank Dr. Othman and his secretariat for inviting me to be a guest of honor in the inauguration of this first Conference of Neurosurgical Society of Tanzania. Your invitation to me to be part of this new history was more than just a usual inauguration event I have participated, but this is a good history and another milestone in our country, especially in terms of improving access to safe and affordable neurosurgical care in Tanzania. Hongereni sana TSI. And I'm deeply moved by the overwhelming response also and participation from across the globe. Your presence here is a testament to the unified visions we share to expand the horizon of neurosurgical care in Tanzania. I would like to extend my heartfelt gratitude for your commitment to this noble cause. It is very gratifying to see the commitment that you attach to our country, and for this reason, let me extend to you my genuine and heartfelt word of thanks to you, Professor Gale, and other colleagues for your participation, but also for your commitment and passion, your commitment and willingness to work with us in order to improve access to safe and affordable neurosurgical care in Tanzania. Asante sana. And I remember it was 2016 or 17, Professor Dr. Othman, he invited me to attend a neurosurgical event here in Dar es Salaam. I think 2016 or 2017, I don't remember. 2016, yeah. And then I was newly appointed to me, and then I thought Mo is doing orthopedic. And then he told me, Minister, no. There is orthopedic surgery and neurosurgery. Then I told him, what do you mean? And then he repeated it in Kiswahili, mifupa, alafu kuna ubongo na mishipa ya fahamu. So since that day, I understood we have to focus or improve both on orthopedic care and neurosurgery care or services. So thank you very much, Dr. Othman, for sensitizing me about orthopedic and neuro. So thank you very much. So today, really, I'm very happy that we are inaugurating Neurosurgical Society of Tanzania. As Dr. Magembe has said, now we have a champion of neurosurgical services to Tanzanians. We have done a lot, as it has been said, in terms of equipping the facilities, putting appropriate infrastructure, but we need also to know more what needs to be done in order to ensure we have, first of all, I was following very closely Dr. Kiloloma's presentation. In Tanzania, we have only 26 neurosurgeons, 25 neurosurgeons. According to WHO standards, one neurosurgeon is supposed to save at least 100,000 people. With 60 million population, lakini umenambia ya for developing countries is 150,000, yeah. So it's like one neurosurgeon in Tanzania is basically saving 2.4 million people. This is too, I don't want to say, I think we have to do something here. I tried under Dr. Samia Super Specialized Scholarship to announce, actually I told my team, I want neurosurgeons to, we have first priority for me under Dr. Samia Super Specialized Scholarship. I said I want to make sure we train more neurosurgeons in Tanzania, but they didn't apply. I don't know why. So Dr. Shabani, Dr. Kiloloma, and others, you have to encourage and convince others to take advantage of this Dr. Samia Super Specialized Scholarship Program for super specialization, or to be trained as a super specialist on neurosurgery. I understand there are issues relating to scheme of service, because you have to do 6 years, and then your colleague is going to do 3 years, and then when you come back to the office, nothing, no increment in terms of salary and other incentives. We are working on that. I have already presented this to, yes, I have already presented this to, actually I presented this to Her Excellency, the President, but also to Chief Secretary. Actually, he told me, Minister, bring it even tomorrow. So the ball basically is sitting at Dr. Grace and her team. Seriously. No. Yes. they have to make sure we complete the review exercise. But because of this meeting, maybe you can provide input. Because Dr. Kiloloma was telling me, Minister, there is a direct way, yeah? You do MMed, 3 years, and then you do 3 years for neurosurgery. Or you can, after first degree, then you do 5 or 6 years. So I think we can pursue both channels. But what I want to say, we are committed as the government to provide scholarship for super specialized cadres, including neurosurgery and other related cadres. For example, Dr. Kiloloma told me we are not supposed only to train neurosurgeons, but we have also to train neuro anesthesia, intensive care, neuroradiology. So we have also a set, we have a package to train specialist or super specialized program as a set. So maybe we can also, you have already mentioned that we don't have one, for example, in southern Tanzania, Mtwara. Then we can convince Mtwara now. Actually, this is what we can do immediately. We can convince Mtwara, maybe we get maybe 1 or 2 MD to do neuro surgery, and then anesthesia, and another one on intensive care and other related field. But I just want to say that the government is also very committed to improve availability or accessibility of neurosurgical care, especially in remote and marginalized areas. And I'm very pleased to note that you had actually undertaken a number of neurosurgical camps in Mbeya, Mwanza, Dodoma, Dar es Salaam, Kilimanjaro. Hongereni sana, and doctor. But I would like to encourage you to do more, at least maybe twice a year. We say we go to, for example, Mtwara or Mbeya. Western Tanzania, maybe we can think of supporting Tabora Regional Referral Hospital. Yes, maybe to build their capacity, we have to find out whether they have a surgeon, a general surgeon kama yupo pale. Yes, so maybe I would also like to encourage you to do more of this neurosurgical camp or outreach program in rural and marginalized area. We are ready to support you. Come to me, to my office. You tell us what you want to do. For example, tell minister we want to do, let's say, 2 camps per year or in every quarter with your needs. For sure, we will support you. And but the government also is dedicated to advance neurosurgical field to the next level in strategic investment and policy initiative aimed at nurturing this vital field in order to ensure that this field will continue heads on. We are committed also to harnessing the latest technological advancement in this field and ensuring that our healthcare professionals are equipped with the knowledge and tools they need to provide quality services that Tanzania needs. Ladies and gentlemen, while the path to achieve this government aspiration is still hard, let me use this opportunity or platform to mention to you some of the ways on how government is persevering to improve specialized and super specialized services in Tanzania. Some of the key initiative could be, for example, the strategic deployment of medical officers across all health centers and district hospitals in a diverse range of up to 14 different specialties in our regional referral hospitals, ensuring that quality care is accessible to all. We have identified 14 different specialties in order to improve availability and accessibility of specialized healthcare services at our regional referral hospital. We have identified 8. 8 is internal medicine, physician, obstetrician, pediatrician, radiology, Gynecology, yes, and there are 8. Orthopedic. Yeah, orthopedic, anesthesiology, 8. Bado sijazipata 8. No, ENT is not. Yeah, whatever. So we decided also to add another 6 more. So we are basically assessing ourselves how well we are doing in terms of availability of specialized services in our regions. So we have identified 8 specialties, but we decided to add 6 specialties, including orthopedic surgery in all our regional referral hospital. Number 2 is about establishment of comprehensive neurosurgical services at zonal referral and the development of super specialties at National Referral Hospital, creating centers of excellence for complex. We have at least, as it has been presented by Dr. Othman, we have at least neurosurgical services in Mbeya, KSMC, Bugando, we have Dodoma, Benjamin Mkapa, so Mtwara. It is lacking. We don't have neurosurgical services in Mtwara. So I'd like to request to put a request to TNS to work with the Ministry of Health in order to establish neurosurgical care at Mtwara Zonal Referral Hospital for Southern Tanzanians. Actually, maybe this could be one of your performance indicator. Maybe I want to challenge you. I want to challenge you to support the ministry to make sure we establish neurosurgical services in Mtwara Zonal Referral Hospital. Sasa, Dr. Kiloloma and your colleague, I'm sure you can help us. I don't want to say probably maybe, Dr. Magembe has said, it is very difficult to say, okay, maybe we take 1 or 2 neurosurgeons to Mbeya from Muhimbili, from Moi. It's going to be another battle, which I wouldn't like to enter. Yeah. Anyway, maybe you can advise us. Mtwara is not bad, it's beautiful. We have, it's very near. And then maybe within 1 hour you are in Dar es Salaam. I think maybe, Professor, we can do maybe they can begin maybe like we have done for Chato, for cardiac services. JKCI, actually, they have assigned 2 or 3 cardiologists. They go to Chato, I think maybe, I don't know, maybe 2 or 3 times, whatever. So maybe we can do that. Yeah, it is very possible. It is very possible, but we can also attract a patient from Mozambique also. Yeah, so maybe I just want to put it as a challenge. But another thing is emphasize on continuous education in neurosurgical subspecialties and the associated discipline, as I have said, including neuroradiology, neuropathology. This is a new word to me, neuropathology. Neuropathology. Neuropathology, neuroanesthesiology, critical care, neurology, and neurorehabilitation. But also enhancement of diagnostic capabilities with the widespread availability of CT scan services across all regional referral hospitals and the integration of MRI and the angiography services at the higher level facilities, setting a new standard for diagnostic precision. Ladies and gentlemen, and maybe something which we can also discuss and share more information and knowledge with the Tanzania Neurosurgical Society. I have been actually consulted. Maybe it is the right time now to have a neurosurgical hospital in Tanzania apart from Moi. Yeah. Yeah. Institute, not hospital, neurosurgical institute. So we are open. Come to me. I'm going to table my budget in the parliament next week. If we are ready to go with it, karibuni sana with your proposal. I give you maybe 3-5 days, or we do it next year, but we better start this year. Yeah, at least the preparations in order to improve access to safe and affordable neurosurgical care in Tanzania. We have to establish a neurosurgical institute, in a national neurosurgical institute. Kwa hiyo something which I'm ready to proceed with it. But I've been challenging Dr. Othman and others, but where do we draw a line between orthopedic? You know, I'm trying to understand it. So, and then you say this is a neurosurgical case. This is an orthopedic case. I don't know, where do we draw a line? And then he told me, Minister, kichwa, ubongo, sawa, and then mgongo, and mishipa ya fahamu. How do you identify mishipa ya fahamu? And then he told me, we know, Minister. So I don't know if we can differentiate between what more we can do and the Mude. I have to go. Yeah, I have a meeting at the State House. Yeah, yes. So, but I just want to say we are open. Karibuni sana. Na, as I said earlier, this Tanzania Neurosurgical Society will actually add value on how we can improve access to safe and affordable neurosurgical care to all Tanzanians. But allow me also to thank our international faculty members who have joined us here. I have no illusion on how busy you are in your countries, Professor Gale, but I know what important task you have put aside just to join us in this FESI Tanzania Neurosurgical Society Scientific Conference. Your selfless dedication to improving global neurosurgical standard through volunteerism and humanitarian effort is both inspiring and transformative. Your presence here is not just a gesture of solidarity, but a powerful catalyst for change now and in many generations to come. On behalf of the government of the United Republic of Tanzania, please receive my sincere and cordial gratitude, and I'm looking for your further professional interaction with our local neurosurgical expert. Of course, we can also have a more detailed discussion in Geneva. So we can also talk about what has been presented by Dr. Othman, including have trauma registry and other related specialties. Ladies and gentlemen, let me conclude my remarks by stating that I commend this platform as a perfect, serene backdrop for the critical expertise, dialogue, and strategic planning that will unfold. We are eager to hear your insights. Of course, we have already heard some of the recommendations, but I'm sure you will continue with the discussion, so we are eager to hear your insights, practical recommendations emanating from this scientific conference, and we, on the government side, are fully committed to translate them into practical actions to improving neurosurgical services close to the people. Ladies and gentlemen, in concluding my speech, I wish to invite you all to, I wish to, hapa tena au nikishuka muda sawa. Ndugu zangu, ni kwamba tunazindua sasa Kiswahili bifupa ndo nasema metaje TNS. Okay, sawa. Ni kwamba leo tumezindua rasmi. Tunazindua. Kwa hiyo leo tunazindua rasmi, panatosha si ndio muda? Kwa hiyo nikae chini. Basi baada ya kusema hayo, I'd like to declare the first Tanzania Neurosurgical Society Conference official open, and I would like to announce the inauguration of Tanzania Neurosurgical Society. Hongereni sana sana sana. kwamba tuko hapa leo kuzindua chama cha madaktari bingwa wa ubongo na mishipa ya fahamu, Tanzania Neurosurgical Society. Tanzania Neurosurgical Society. David. Tanzania Neurosurgical Society, ambaye rais mwenye ara ndogo ni Dr. Othman Kiloloma. Kwa hiyo chama hiki lengo lake kubwa ni kuunga mkono jitihada za serikali za kuhakikisha kwamba Watanzania wanapata huduma bora na salama za upasuaji wa ubongo na mishipa ya fahamu, na tumesikia kwenye madhumuni ya chama pia. Kwa hiyo kwanza ni kuhakikisha upatikanaji wa wataalamu wa madaktari bingwa wa upasuaji wa ubongo na mishipa ya fahamu. Tumeelezwa hapa na ndio takwimu, Tanzania tuna madaktari bingwa wa upasuaji wa ubongo na mishipa ya fahamu 25 tu, na kwa mujibu wa WHO anapendekeza kwa nchi zinazoendelea angalau katika kila watu 150,000 basi kuwe na daktari bingwa wa upasuaji wa ubongo na mishipa ya fahamu mmoja. Kwa hiyo sasa ukichukulia idadi ya madaktari bingwa hawa 25, maana yake kwa Tanzania daktari bingwa wa upasuaji wa ubongo na mishipa ya fahamu anahudumia Watanzania kama 2,200,400. Kwa hiyo maana yake ni kwamba huduma hizi za upasuaji ubongo na mishipa ya fahamu bado hazijawafikia Watanzania wengi. Wengi tunawaona madaktari hawa wako Muhimbili, Moi pale, lakini tunaona baadhi KSMC, Mbeya. Kwa hiyo chama hichi pia kimeanzishwa, lengo kwanza ni kuweza kujengeana uwezo, lakini pili kuhamasisha madaktari waweze pia kusomea fani hii ya upasuaji ubongo na mishipa ya fahamu. Lakini pia nimefurahi chama hiki kinataka sasa tutengeneze mwongozo, standard operating procedures or protocols, kwamba je, ukiwa ndio daktari bingwa wa upasuaji wa ubongo na mishipa ya fahamu, masuala gani ya kuzingatia? Kwa kweli sisi kama serikali tumefurahi kuona chama hiki kipo, na tumewashukuru na tunawaunga mkono kwa sababu watatusaidia hata sisi utendaji wa wizara kujitathmini. Hapa hamjatusikiliza, hapa mmetusikiliza, hapa tunatakiwa kwenda vipi, vifaa tiba gani tunapaswa kuwa navyo, utaalamu gani tunapaswa kuwa nao, lakini na masuala mengine ya utendaji kazi wa madaktari bingwa wa upasuaji wa ubongo na mishipa ya fahamu. Lengo la serikali kupitia Wizara ya Afya, tunafikiria kuitenganisha MOI kwa sababu kuna upasuaji wa mifupa na upasuaji wa ubongo na mishipa ya fahamu. Kwa hiyo ni dhamira ya wizara, ili tuweze kuboresha zaidi huduma za ubingwa katika upasuaji wa ubongo na mishipa ya fahamu, tuanzishe taasisi mahususi ambayo itakuwa inashughulikia masuala ya upasuaji ubongo na mishipa ya fahamu, ili MOI abaki na masuala ya kupasua mifupa. Nadhani inatosha mshwaba. Asante. Ataeleza zaidi.
Ladies and gentlemen, let's take a group photograph, please. In an orderly manner, please proceed. Let's take a group photograph with the Honorable Minister for Health. In an orderly fashion, please, let us take a group photo. We're all going to fit.
Wa Somalia, moja ya jambo ambalo tunaenda kujadili ni jinsi gani Tanzania tunaweza kushirikiana na Somalia katika masuala ya huduma za ubingwa bobezi. Kwa hili nalo ni eneo.
Tushushe kidogo hapa chini. Sababu watu watasimama mpaka huko. Naomba tushushe, naomba tushushe. Tushushe chini.
We can do it in 2 different groups. Yes. So this will be the first group, and then we'll take another one with the second group, right? Awesome. Please rise as we escort. Please rise as we escort the Honorable Minister for Health. Thank you very much. Ladies and gentlemen, please be seated for a few announcements. We're about to go for breakfast. Let's just... Ladies and gentlemen, please be seated just for a few more minutes. Please be seated for a few minutes. Everyone's so excited.
I think we can go for tea and metabolize what the ministers just said. Then we come back with a hot discussion.
Breakfast is served at the first floor. Please, for everyone who wants to go have tea, it's at the first floor.
Ladies and gentlemen, please be seated. Have a seat, please.
Okay. Morning, everyone. It's afternoon already? Oh, it's afternoon already. Okay, good afternoon. Please find your seats. And we are about to start. We have to rush because lunch is almost an hour and a half to come. So it's a honor and a privilege to introduce Mr. Peter Gitau, who is the country head of the Kusumu Healthcare and Pharmaceuticals. He's one of the sponsors of this meeting, society, and he's going to present in one of the products, which is called Quanil. Please, Mr. Peter, the floor is yours.
Yeah, good afternoon, everyone. Yes, thank you very much for this opportunity. My name is Peter Gitau, and I'm from Kusum Group of Companies. We are one of the sponsors for this conference, and I'll just give you a brief introduction for our company. So Kusum Group of Companies is based in 2 countries. So we are headquartered in Ukraine, Kiev, as well as in New Delhi, India. And we have manufacturing plants in both countries. So that's just a show of our global presence. We are present in 38 countries. And just to give you confidence on the use of our brands, they are accredited by all the regulatory bodies that we work in, including TMDA. We also have GMO, GMP certified, as well as PIXIS, which is Pharmaceutical Inspection Convention. So without taking much time, let me give you a brief introduction on the product itself. So it's for brain injury patient, and we all know that the traumatic brain injury is one of the most devastating injuries because it leads to incapacitation by motor and cognitive deficits. So among the improvements in the treatment of TBI, neuroprotection is one of the most promising improvements. So elevating the patient condition with the use of citicoline, we've seen that it limits the brain lesions produced by acute ischemia, that is in neuroprotection. It is able to increase the recovery, plasticity, and neurodegenerative processes. So it complements rehabilitation and enhances the possibility of recovery and return to normal functions, that is in neuronal repair. So the use of citicoline in brain injury in acute ischemia, it has demonstrated efficacy. Also, during studies, it has shown that long-term treatment with citicoline is safe and effective. So citicoline improves cognitive decline and enhances patients' functional recovery post-TBI, and its prolonged use is remarkably well tolerated. So its mode of action is that it has therapeutic effects at several stages of the ischemic cascade in acute ischemia. First, it stabilizes cell membranes by increasing the production of phosphatidyl choline.
Recording in progress.
Sphingomyelin synthesis, as well as inhibiting the release of free radicals, whether it's through the ischemic cascade. So acetylcholine simultaneously inhibits different steps of the ischemic cascade, thereby protecting the injured tissue against the early and delayed mechanism responsible for ischemic brain injury. So improvement of behavioral performance, as well as learning and memory tasks, are the benefits that the patient gets from the use of acetylcholine. So we say in the treatment of head injury and stroke, we prescribe Quanil, which is our brand of acetylcholine, and it comes in the form of tablets. That is the presentation, as a pack of 10 tablets. And usually a dose of 1 to 4 tablets is recommended, but usually we give 1 to 2 tablets, one that is 500 milligram or 1 gram daily. But the dose of the preparation is determined by the doctor and the severity of the cerebral lesion. So usually a treatment course of between 1 month to 3 months is required for traumatic brain injury. And thank you very much. That's all from Kusum. I'm asking for your kind support for Quanil in traumatic brain injury patients. Thank you very much. Thank you, sir.
Thank you so much, Mr. Peter. That was a wonderful presentation, and we really support you from your products. Okay. So, so preserve your questions until when, at the end of the session, we'll ask you to ask your questions. So may I welcome Dr. Humba for the next presentation, because according to the timetable, Debalema is not here. So Dr. Humba is going to present on a patient with a pituitary macroadenoma and the brain abscess treatment challenges. Dr. Humba is the head of neurosurgery unit at Benjamin Mkapa Hospital, and he's the assistant director at Benjamin Mkapa Hospital. Dr. Humba, please welcome.
Thank you. As the IT specialists are doing their thing, the IT specialists, this case marks the importance of collaborative work. So my approach to this is going to be a multidisciplinary approach towards pituitary patients. Why? Because the neurosurgeons usually are not the first in terms of diagnosing these patients. It's usually the ophthalmologists or the gynecologists that are primarily diagnosing this. Rarely, yes, few times that the neurosurgeons diagnose. And I would like to acknowledge my colleague, Dr. Glory Ngajiro, who recently came back from London after training, super specializing in endocrinology. So at Benjamin, we have now an endocrinologist in the same building. As I've told you that these cases usually manifest or present in different ways. So it needs the importance to show that we need collaborative work with other departments. And this, including the gynecologists and the ophthalmologists. There are so many challenges in diagnosis. There are diagnostic dilemmas and the overlapping of symptoms. We know some of the pituitary cases classically will present classically with visual issues and headaches and other things. But coming to this case, you'll see why was interesting to us. So multidisciplinary team approach is essential for optimal treatment and care of these patients. as I told you, you need not only the neurosurgeons, we need the radiologists to be able to give you good images, and you need nurse practitioners, ophthalmologists, oncologists, radiation oncologists, and physicists. We have to do scheduled meetings that I know my colleagues who have trained elsewhere, they know. In Stellenbosch, we used to have one endocrine meeting, neuroendocrine meeting every month. And all these patients will go first to endocrinologists. They are the ones that will tell us, please operate on this, and that one will continue with medication. So comprehensive evaluation of complex pituitary cases, sharing insight and perspective from various specialists, developing a unified treatment plan. So every patient must be treated separately, and they must have a tailored plan. So, how to navigate the diagnostic dilemma in these pituitary macroadenoma cases? This is the case of a 33-year-old female, a primary school dropout, petty trader, lives somewhere in Dodoma. Actually, the complaint was seizures. She presented with seizures. Then we found out she had a history of amenorrhea, headache, and also developed some weakness. On the amenorrhea, she attained menarche at 12 years with regular menstrual periods, and but had failed to conceive, and stopped menses 3 years ago. She denied use of any contraceptive methods, oral or other methods. She denies excessive heat or cold intolerance, excessive sweating, or strenuous physical exercise. Also denies inappropriate breast milk production or discharge, and no significant weight changes. So on headache, the headache was dull, aching, also associated sometimes with projectile vomiting, body malaise, low-grade fever, but she denied history of visual impairment. She had the right side weakness, which was progressive, right upper and lower limbs, with a history of convulsions, initial recurrent generalized tonic-clonic for 4 minutes with eye rolling, urine incontinence, transient episode of loss of consciousness. Later, she started developing unilateral tonic-clonic convulsions on the right side. On the past medical history, there was no contributory finding. Only on the past medical history, this episode was her first admission. She denied any history of chronic illness, chronic use of medication, drug or food allergies. On family and social history, she's a school dropout. Family history, there was a family history of infertility on one of her aunts, but otherwise, there was no other contributory findings. On physical examination, she was healthy, as you can see. The vital signs were within the normal range. She only was GCS14 confused, but otherwise, the memory part, because she was confused, I think this is confounding. But she had no history of meningeal irritations, and other signs were negative. So we did visual field with the help of the ophthalmologist. You can see there, what was significant there, she had grade 1 papilloedema. And visual fields were not done because of her corpus mentis. Other cranial nerves were essentially normal. The power on most muscles on the right side was 4/5, hyperreflexia, positive Babinski. But otherwise, other things were within the normal range. So, our provisional diagnosis was, could that be possibly encephalitis? The radiologist will come and tell us more on the images. And, is she having a brain met? Is she having a neoplastic brain tumor for the reason that I'm projecting? And what are the things that are, the things that were against are on the other side, as you can see there. But because of her history of infertility, 5 minutes. So we also suspected endocrine issues. So other lab investigations were essentially normal, except the pituitary function. You see, raised prolactin, normal cortisol, but FSH was low, and other hormones, female hormones, were low. Otherwise, the others were normal. So imaging, these came from our colleagues, the radiologists. So they had a large pituitary microadenoma with the size that they project. There was also a left frontal parietal large cerebral abscess with grade 3 vasogenic edema. Also she had chronic sinusitis. So luckily we have an oncology meeting, neuro-oncology meeting. So this case was presented. Dr. Kukwima, you will appreciate there. Is it a straightforward abscess thing that looks like that? I didn't expose well, but you and me can see here, there's a large mass. Sorry, these pictures, Dr. Glory went and presented somewhere, so she took the pictures the medical people could understand. But as surgeons, we should have put better pictures for this case. But now, the question was, from history that we had, how did this abscess come about? There was no other history of tooth extraction. There was no history of fever. And if it is an abscess, what kind of an abscess is this? Is it a TB abscess or other things? She was HIV negative and things like that. But with the features, radiological features that we showed, she had also that, but that was on the right side. And this thing sits on the left side. So we're asking ourselves, why? And how would you possibly get this? And one of the person that in the meeting said, because of its characteristic here, before when we were discussing about this, the edema and restriction of the fluid, then they say, abscess, yes, number one, because the history is not very well. Don't go there and be surprised it's something else. What could this possibly be? It's an abscess. Say, no, no, no. And I've learned to respect the radiologists. Go and see if this is not, prepare yourself and make sure this is not a glioma or some sort. I was like, it is an abscess. They reported there, but in the discussion, that's what I was saying. So, the final diagnosis were these. So, medical therapy was initiated. And Dr. Glory, she decided to start her on cabergoline. So while she was in the ward, then while she was in the ward, second day, seizures continued and the weakness continued. Then we had to rush and take her to theater. So with the advice that in the discussion in the meeting, we decided instead of doing a small bar hole, then we did a craniotomy. So do a craniotomy, this is what you see. So did the corticotomy on one of the sulci, and that's what comes out. It is an abscess. Pass. So that was incision, finish and talk out. So it was an abscess confirmed. We did take it for culture and sensitivity because she was erroneously taking, I think, antibiotics. We didn't grow anything. We did TB workup, it came out negative. This was, I'm sorry, I was supposed to put it earlier, that's a fundoscopic finding. Then we went on to continue following her with antibiotics and other things. her prolactin level went on low. So why is this case important? It shows the importance of having multidisciplinary teamwork with a good collaboration, discussion with the radiologists, endocrinologists, ophthalmologists, and other things. So we have now started a teamwork approach. We have started a registry on pituitary cases. We are now, since Dr. Glory came, we are almost 23, we have 23 patients. And as she is the one that determines when we go for surgery, unless it is pituitary apoplexy, we leave them to her. Then she is the one, when they have a medical failure of some sort, she tells us, and we go and operate. So far, one of those patients had a pituitary apoplexy event. So she bled into the tumor. Then, because we were waiting for Dr. Edwin to come also to help us, starting endoscopic transsphenoidal approach, then I had to do it open. So I did open and removed the tumor. Because of time, I think I cannot continue, but these are the things. How did the abscess come from? These were the questions. So we postulate that possibly the sinusitis that caused the abscess. The other thing that we didn't do was a CT to check on the floor whether there's any penetration, direct penetration, or whether hematogenous spread. And why is it on the left side instead on the right? I don't know. So there are so many diagnostic criteria, but teamwork helps us diagnose this and treat these patients. Thank you very much.
Thank you so much, Dr. Humba. That's an eye-opener to most of us as surgeons, and the importance of MDT. For the sake of time, again, please reserve your question until the end of the session. May I call upon Dr. Goodluck Ndebalema, who is the resident year 1, COSEXA resident at KCMC, who is going to take us through a case, a central nervous system tumors, histopathology at KCMC, and the barriers to diagnosis. Welcome, Dr. Ndebalema.
Again. So my name is Dr. Goodluck, and I'm from KSMC. I've been a registrar in the unit for the last 2 years, and at the moment I'm doing my residency in COSEXA year 1. So it's an honor for me to take you through some of the steps you have taken in KSMC for the last 2 years, and I'll walk you through the CNS tumors histopathology at KSMC and how we were trying to identify the barriers to diagnosis and ways to go about them. So for those who haven't been to KSMC, that's KSMC right there. And it's as a short summary, it's among the 4 zonal consultant hospitals. And it's the neurosurgery unit is a new unit that has been there for the last 2 years under the leadership of our esteemed neurosurgeon, Dr. Rabiel, who has also been a mentor and an inspiration to us all. So that's Dr. Rabiel. Okay. Yeah, so that's Dr. Rabiel, and also what we do is in neurosurgery we go about everything. At the moment we try to tackle some of the brain tumors, traumatic brain injuries, spine and congenital anomalies. And with that, I've also been lucky to have another mentor in the unit, Dr. Carrie Vaughan, who has been here. I think she just left, who has been another mentor. So it's truly humbling when you come to a conference like this and you meet the mentors of my mentors. So when you hear Dr. Abel talking about Dr. Shabani and Dr. Kerry talking about Professor Gale, so it shows the steps we take in building this mentorship program. So I'll take you to the talk. As the neurosurgical unit in KSMC grows, our operative volume has also gone up. So we have seen a number of cases rising by about 20% from previously. We have had some of our CNS tumors going up and our operative volume going up. So this is how we got about trying to figure out how we'll go about managing and being able to have accurate and timely diagnosis to our patients. So a bit of background in what I'll be presenting is that as part of management of CNS tumors, it involves imaging, surgery, pathology. So I'll be focusing on the realm of histopathology, where with an increase in number of CNS tumors, it's necessary for us to understand how we diagnose this, how we treat them based on histopathological findings. So this is our pathology lab at KSMC. Though it's small, we are able to have tissue samples from the hospital plus surrounding hospitals that send our samples to our center. We are lucky to have 4 pathologists, but as in many of the low and middle income countries, the lack of neuropathologists, we don't have one. So we just have 4 pathologists, and by rough estimate, we receive about 40 to 50 tissue samples per day. And among the 40 or 50 samples, we just have a handful of CNS tissue samples. And our method of classifying them, we go about based on morphology. The reports are usually based on the histopathological appearance or plus or minus immunohistochemistry that's available. So what I'll be walking you through is an abstract that we had, and it's a study where we try to review some of the histopathology of our CNS tumors that we treated from the year 2022, which the neurosurgery unit started 2023, and to be able to identify some of the barriers to our histopathological diagnosis. So this is just a study that was done previously by Dr. Abel, way before she had transferred to our hospital. She was in Arusha, and she did similar to where she tried to identify clinical pathological patterns and surgical outcomes of primary brain tumors. So how we went about it, the method is that we looked at our theater patient registries, because most of the patients that were in there were the ones that we had operated. So we had a time frame of January 2022 through December, and we identified the histopathology reports for the surgical treated tumor patient. So this was a summary of the results that we had. So in summary, the cranial and spinal tumors that we did in the year 2022-23 was around 91 cases, and we had 80 cranial tumors and 11 spine tumors. And sadly is that we had only 66 results, we had only 66 results out of the 91 patients that we got. And so this is one of the issues that we wanted to identify, some of the barriers as to why out of the 91 we only got 66 results. So most of the common diagnosis that we saw is that meningioma cases were the leading one, with around 31 cases were meningiomas. We didn't break it down to find the grades, so it's just 31 cases of meningioma, glioblastoma 7, and various lesions also 7, with others such as tuberculomas and metastatic tumors, neuroendocrine tumors also were the others that also found on the results. So also, as we investigated, we found that there are some of the barriers that were there in terms of diagnosis, which the biggest one was financial constraints. And this came about with most of our patients. As we went through the record system, we had found that most of them had not paid for the histopathology, or even doing the immunohistochemistry became a bit of a burden, and most of them didn't decide to pay. So that was a problem. So we missed most of the data because this histopathology wasn't tested because they didn't pay. Also, we have an electronic record system that was kept in place after previously we were using the paper system. And still, when it was starting about in the year 2022, which had recently been updated from 2021, it was still a fragmented system where most of the data has been missing and has been hard to find most of the data, and the pathologist was sending out hard copies to the patients, and so missed data came about due to the electronic system. Plus, we have limited local histopathology testing, and this is what I was talking about, is the expertise. Because the unit has been a new one, and the pathologists that we had not been previously exposed to the CNS samples. So the quality of results first was a problem, and this made us have various meetings and discussions on to how to have quality reports. Plus, there was a big disconnect between the surgeons, the pathologists, plus the radiologists. So when we have a tissue sample histopathology coming out that doesn't tally with what was seen on the surgical table or what has been seen on the radiology in terms of the CTs or the MRIs, so that is a big disconnect that we saw as well. Plus, we have been outsourcing some of our histopathological tissue samples, sending them to private pathology labs. In Moshi, we have one private lab called Lancet Laboratories, but in Arusha, we have a number, like 4 or 5, and sometimes we've been sending the samples to Dar es Salaam, to some of the private labs. So this has been an issue because the reliance of the results had taken time for us to come. There's issues of transport, the samples to the area. It has been also a problem, and it was a problem to accessing the results of these samples. So if you were going back to look at some of the results of our patients, it had been a problem. So this had an impact in terms of the diagnosis timeline. So our patients had sent samples today, and then the results would have taken longer than they would have if they were done at our own place. So with all this, there's been some improvements that have been taken place in our unit, which number one was the biggest when you're going to 2023, there's been a big change in terms of the electronic medical record system, which now it's better in comparison to where we were. So our data is now being stored better, reserved, and you can find it more accessibly. So it's hopeful that from now onwards going forward, the electronic medical record system is now better, but it's still a work in progress. Plus, there's been efforts to centralize the pathology reports, which what we try to go about it is that when we have a patient and the results are out, we have a sit down with the surgeon, the pathologist, and the radiologist to be able to centralize these reports in a manner that can be understood and can be checked back or go back for review if there is an issue. Plus, there have been strategic partnerships, which I've just said, which our unit has been working hand in hand with the pathology department, where we have now scheduled meetings. Also, we involve the oncologist as well, where we have oncology meetings with our tumor cases and discuss them so that we can be able to efficient our results and better the care of our patients. So there's been a plan of expanding our histopathological services. As we can see, the work burden has been significant. They get 40 to 50 samples. There are only 4 pathologists, so the workload has been significant. So the expansion of the histopathology is something that has been talked about, something that is a work in progress, and as well as expanding it externally to our collaborators such as Barrow, where we involve some of the neuropathologists from Barrow who will be able to create this continuous medical education with our pathologists being able to help so that we can improve better. So in conclusion is, what we were trying to look at is what tumors or what sample or what tumors we get at our center. That's number one. So we have identified that we see most of meningiomas as well. And plus, we wanted to identify the challenges faced by our tumor patients. So which was that time and accurate diagnosis is a big challenge that our patients faced, where they would come 2-3 weeks post-surgery and the results were still not out. So that's the challenge that we identified in this abstract. Plus as well, we had seen some of the opportunities for improvement. As I said, is the electronic medical record system. It's something that is an ongoing work in progress. It's something that is still worked on continuously every day to be able to centralize our data and keep it safe so that we can be able to look at it back and have more research and things like that. Plus, there have been collaborative efforts, as I said, internally between the neurosurgery unit and the pathology department, externally trying to have collaborators such as the Barrow team, having neuropathologists come in and have these symposiums on medical education continuously. And yeah, And so what are the next steps for us as a unit? The next step for us is to have a continued evolution of the medical system, which is still ongoing, partnership, as I said, and advocacy of improved access to the medical services, and potential research and infrastructure enhancements. And with that, so thank you very much.
Thank you so much, Dr. Goodluck. Nadhani umesikia kuhusu waziri alivyosema kuna Mama Samia super specialist scholarship. So kindly consider about becoming a neuropathologist. May I welcome the next speaker, who is Dr. Rebecca Mwambengele, who is going to talk about temporary ECA ligation. Please welcome Dr. Rebecca.
Okay. So he was a 75-year-old male with a history of progressive swelling on the head for 6 months with no other symptoms associating. He was a previously normal male with no history of comorbidities, not on any medication. And on examination, apart from this scalp swelling, there was no any deviation from norm. So he did an MRI which showed a large extra-axial enhancing tumor mass in the left frontal parietal, extending both intracranially and extracranially and associated with bony erosion. As you can see in this photo. So our challenge was the best surgical approach that we could use in order to minimize intraoperative complications and maximize recovery for the patient. And the biggest question that we had was how to limit or to reduce blood loss intraoperatively, because the tumor appears highly vascular from the dura to the skull to the scalp. So this was our surgical approach, and this is what we did. Patient preparation in the theater took almost an hour with sedation and checklists and positioning on the Mayfield and preparing the surgical sites. And then the duration of surgery was approximately 4 hours. The first 1 hour was for the neck dissection and the temporary ECA ligation. And the next 2.5 hours we used for craniotomy and cranioplasty. And the last half hour we used was for wound closure. During the surgery, we had an EBL of 400 mils and no intraoperative transfusion was needed. Postoperatively, the patient was nursed in the ICU for 24 hours, followed by care in the HDU and general ward. And there were no complications during a hospital stay, and had a total of 4 days in the hospital. Patient was discharged, and the follow-up at the clinic with no complications. The biopsy showed mesothelioma meningioma grade 1. So why does this presentation matter? So what is the role of ECA in tumor access and blood supply, especially in this case? So the ECA provides the majority of blood supply to the meninges and the scalp. And so hypervascular tumors such as these are at risk of increased blood loss. So if we perform temporary ligation of the ECA, it will allow for minimal blood loss intraoperatively, therefore reducing complications. So according to literature, doctors who have used temporary ECA ligation as opposed to other methods that we'll talk on later, they had minimal blood loss, about 200 to 800 mils for patients who were, so there was a paper that compared patients who had temporary ECA ligation versus not. And the patients who had ECA ligation had very minimal blood loss, about 200 and 800, up to 800 mils, versus the ones who had no ligation, they lost about 600 to 1,400 mils. And intraoperatively, the patients who had ligation had maximum 700 mils of blood transfusion from 0 to 700, but the patients who did not have ECA ligation had to have about 700 to 1,400 mils of BT. And the operative time was shorter for patients who had temporary ECA ligation. It was 135 to 210 minutes versus patients who did not have ECA ligation. The operation took a total of 205 to 360 minutes. So this was very close to our operation that we did. We had we had about 400 mils blood loss, and we did not need to transfuse intraoperatively. So other alternatives to temporary ECA ligation include preoperative or perioperative radiotherapy. But the complications was, in some cases, patients end up having neurological and motor and sensory deficits that sometimes may require hospitalization and can affect the individual for a longer time. Another alternative to temporary ECA ligation is tumor embolization, but the disadvantage is it's costly and there is limited availability, as you can see, and there is need for training, and it's not suitable for large tumors. There was a paper that was done that's tried to compare and say that tumors that were larger than 6 centimeters were difficult for embolization because they had multiple streams of blood supply, so it was difficult to embolize the tumor. They can also complicate to thromboembolization by when the embolic agents are thrown. You can have thromboembolization, you can have scalp necrosis, hemorrhage in tumor, and subdural hematomas, and permanent neurological deficits. So the advantage for temporary ECA ligation, apart from the easy access and its practicability, is also, well, that's the biggest advantage. But some of the challenges that you may have for temporary ECA ligation include you have to know the detailed anatomy of the ECA and its branches. So there's a role of imaging. Studies do prefer that you do, let's say, CT angio or MRA that can help you to understand the anatomy of the ECA for specific individuals because it can vary across patients. But also another complication that you can have is scalp necrosis, as well as embolic phenomenon. If you, some studies have shown that because of during the ligation, you might throw an atherosclerotic plaque to further into the brain, causing an emboli and complications as such, as well as the duration of surgery. It depends with the technique, I would say, because for us, it took a little bit longer in comparison to other studies to access and perform the whole surgery in general. So maybe this is the room for collaboration with other surgeons that we can achieve a much shorter duration of surgery for such patients. So the final tips and takeaways are preoperative planning to reduce risk of intraoperative bleeding is of paramount importance, as well as temporary ECA ligation remains an effective method of choice to restrict tumor blood flow in large convexity meningiomas in low resource settings. Thank you.
What? Dr. Rebecca, that was a very interesting case. So we still have 2 presentations. May I call upon Dr. Musa Machibia? Is he around? Okay. Dr. Musa Machibia is a general surgery resident at Aga Khan University. So welcome.
Thank you. Yeah. Good afternoon. Yeah, as I was introduced, my name is Dr. Musa Machibia, a general surgery resident, year 1 from the Aga Khan University, also aspiring to become a neurosurgeon in the near future. Yeah. I'll be taking you through the challenging case of a bilateral lower limb weakness, for which we try to unveil the diagnostic dilemma of a suspected carotid board tumor. So here will be the outline of my presentation, for which we start the case presentation, then case discussion. Yeah. So this presentation delves into the intricate diagnostic journey of a 28-year-old gentleman with a complex medical history who presented with a bilateral lower limb weakness, for which the case evolved into a perplexing diagnostic challenge due to inconclusive histopathological findings. So we will explore the clinical cause of this case, the diagnostic investigations, the treatment interventions, and navigating through the diagnostic ambiguity in this unique case. Yeah, so we had a 28-year-old gentleman who was a soldier from the Comoros Islands, initially presented with an anterolateral left-sided neck mass with compressive symptoms for about 3 years. The swelling prior arrival to our hospital, it had been there for almost 3 months, progressively increasing in size, accompanied by difficulty in breathing and dysphagia. So upon diagnostic evaluation of this case, including the imaging, it suggested that he had the carotid board tumor. That's based on the MRI, which was done 3 years ago. But based on the tumor characteristic, additional concern for Hodgkin lymphoma was established. Due to that, the biopsy was taken, for which it concluded that this patient had Hodgkin's lymphoma with a subtype of nodular sclerosis. Because of those findings, he was referred to our oncology unit to proceed with the treatment. However, during the staging evaluation with the bone marrow, the results were inconclusive. Bone marrow just revealed he had the normal white cell morphology with a mild anemia, so didn't tally with the biopsy result. So that led us to take a step back and try to reevaluate again this patient, for which the second incisional biopsy was taken, which revealed reactive lymphadenitis. That caused furthermore confusions, and unfortunately, our patient lost a follow-up until 2 years later, where he presented again this year, around February, with a new complaint of bilateral lower limb weakness, for which I've been there for almost 8 months, progressive worsening with time, and 1 week prior arrival to our setting, he was unable to walk without support. He also reported to have the nocturnal back pain with altered sensation, starting from the level of umbilicus going down to the extremities, and also that mass, which have been there for 3 years now, have been increasing in size with worsening of the compressive symptoms, which were dysphagia and difficulty in breathing. Upon assessment, he still had the neck mass. He had significant reduction of power in lower extremities with ataxic gait. He had exaggerated deep tendon reflex and hypothesia at the level of the umbilicus going down to the extremities. So these new complaints triggers to further investigating this patient, for which we did the MRI, total spine. As you can see, I'm not sure if you can see, but there was a lesion starting from the level of T3, going downward to the level of T9, but it was more obvious and convex in shape around T5 up to T6. It was a hypointense lesion arising from the posterior aspect of the cord, compressing the cord anteriorly and provided the mass effect. Also, after the contrast, it was avid absorbing the contrast, suggestive that this tumor was high vascularized. Yeah, so this is the actual view of the same tumor, which reveals the same findings. As you can see, there is a clear demarcation between the cord and the tumor posteriorly, with a mass effect to the spinal cord anteriorly. And this is the T1 phase of the axial view with contrast, with significant enhancement involving the paraspinous muscles and the bone cavities as well. Yeah, so this is regarding the neck evaluation of the tumor, for which the neck MRI was done, and this is our axial view. As we can see here, there is a clear demarcation of the tumor with a mask effect toward the trachea and the clear demarcation to the submandibular gland. This tumor was also infiltrating both external carotid artery and the internal carotid arteries. And here the contrast imaging of it, as we can see, revealing the similar findings, and the fact that the contrast was enhancing, suggestive of the high vascularized tumor. So due to that, our patient was taken to theater, for which laminectomy was done with the extradural tumor excision, for which intraoperative the tumor was highly vascularized, and it was found at the level of T6, significantly bleeding, for which we lost almost 2 liters of blood intraoperatively, and the tumor was extensive to the bone, so some part of the transverse process of the T5 and T6 was taken out together with the bone, and the fact that it was extensive, as we saw from the MRI, we didn't able to resect all of it, so the subtotal resection of the tumor was done, and the sample was taken for histopathology. So the pathology results revealed he had the hyperchromatic nucleus, multiple, scattering around through the tumor with the abundant cytoplasm arranged in a nest, as you can see, multiple cells. The tumors also had vasculature. As you can see, the vasculature traversing through the tumor with the red cells scattering throughout the tumor, meaning that the tumor was highly vascularized with the nest cells arranged within the nest, suggestive of more of paraganglioma. Immunohistochemistry, which was done, revealed the chromogranin cells scattering out through the tumor, as we can see, and also the CD56, vimentin, S100, and synaptophysin were all came out positive, establishing the diagnosis of paraganglioma. Postoperative, the patient regained both power and sensation, was able to walk on day 1 postoperatively, and fit for discharge on day 3 after the operation without any complication. It was discussed on our tumor board, and we agreed upon repeating the 3rd neck biopsy after the initial one revealed lymphoma, 2nd one revealed lymphadenitis, and the 3rd one was taken, which revealed he had the paraganglioma. So the diagnosis of metastatic paraganglioma was established at the fact that the primary tumor of the neck with the distance spread to the mets to the spine. So due to those findings, is now awaiting to be started on chemotherapy and radiotherapy to address both the primary pathology and the mets pathology of the tumor. So in a nutshell, the paraganglioma are rare endocrine tumors which are arising from the extra-adrenal chromaffin cells of the autonomic nervous system, and according to WHO, they are regarded as the low-grade tumors. Their annual incidence is approximately 1 case to 100,000 individuals with a male predominance, as we can see to our patient, and they are most diagnosed to the adults. The CNS paraganglioma are very, very rare, and if they tend to happen, 90% of them, they tend to happen within the carotid and glomus glandularis. The spinal paraganglioma are particularly very, very rare, and if they tend to happen within the spine, they tend to happen in the lumbar region. But for our case, it tends to happen within the thoracic region, and to make it more peculiar and very rare presentation. They are commonly benign, with a 5-year survival rate of around 90%, with a rate of malignant transformation around 2.4 to 14%, and their prognosis is favorable, for which the localized tumor, they tend to have the very good prognosis, while for metastatic disease, they tend to have the poor prognosis with 5-year survival of around 40 to 60%. They tend to recur even after excision, for which for total excision, the rate of recurrence rate is around 2.2%, and for subtotal excision, which happened especially to our patient, the rate of recurrence is about 5.4% to 10%. There is a role of postoperative radiotherapy and chemotherapy, but it's still controversial, and it has been reserved to the one who didn't undergo the surgery at all. So this case highlights the complexity in diagnosing and managing complex medical condition as happened to our patient. The challenges such as diagnostic ambiguities and inconclusive histopathological findings emphasize the need for multidisciplinary approach and access to diagnostic tools. And despite the challenges, timely intervention and tailored treatment strategies are essential for optimizing the patient outcomes. I would like to acknowledge the team that have been involved, starting from the diagnosis and management of this case until now the patient is full normal. He can work and continue his daily activities. Yes, I'm a reference, and thank you so much.
Thank you. Thank you, Dr. Musa. That was a very good presentation, and it's good that you have published the case. Congratulations. May I now take an opportunity to welcome Dr. Mulhat. Dr. Mulhat is a third-year resident, COSEXA resident, based in Zanzibar, NEDI Institute. And he's also going to present a case of trigeminal neuralgia. Welcome, Dr. Mulhat. And I kindly remind you, keep on time, 10 minutes presentation.
Good afternoon.
Good afternoon.
So my name is Dr. Mulhat. I'm a neurosurgery COSEXA resident based at NED Institute, Mnazi Mmoja Hospital in Zanzibar. So today I'm going to present a case which is about trigeminal neuralgia, which presented itself as an unusual presentation of KRE1 malformation. So, introduction, we all know the symptom of trigeminal neuralgia. It presents itself as a disturbing, painful sensation on the face, most oftenly one side of the face. It can happen bilaterally, and it follows the distribution of the branches of the trigeminal nerve. So trigeminal neuralgia is a presentation of KRE1 malformation is very rare, and there are very limited isolated case reports about this presentation. And in Zanzibar, we present a clinical case of the only patient that has been diagnosed in our institute since its opening in 2014. So the case report involves a 34-year-old female who came to us with right-sided facial pain, typical symptoms of trigeminal neuralgia, which started as sudden onset. So the pain was intermittently relieved with medication. She was on carbamazepine and gabapentin. But the treatment, she was adhered to the treatment, but the pain was on and off throughout almost 2 years. So this was a preoperative image. You can see here, there is a tonsillar herniation from the foramen magnum towards almost to below the C1 level. And this is consistent with the diagnosis of KRE1 malformation. So 2 years after persistent right hemifacial pain, a surgical treatment was offered to the patient, and she was operated at our institute. A posterior fossa reconstruction was performed, and this involves suboccipital craniectomy and C1 laminectomy, also dural opening in a Y-shaped fashion down to the level of C1, partial coagulation of the right cerebellar tonsil, and duroplasty with muscular fascia was performed. So following the surgery, the patient had immediate relief of the facial pain, which sustained for the next 2 years, remaining just light numbness, which has been subsiding gradually. First of all, she was using neuro support and neurotones, but now she stopped and the numbness is subsiding by itself. So control postoperative MRI shows, as you can see, free posterior fossa contents with no brainstem compression. So discussion, KRE1 malformation as a cause of trigeminal neuralgia is, as I said before, is limited to a very small number of case reports. And this paper, Papanastasiou, showed that he found only 19 cases in English literature. The pathophysiology is still unclear, but also this paper showed 4 possible mechanisms which involve vascular compression at the nerve root entry, demyelination, microischemic changes, and direct brainstem compression, which can be caused by KRE1 malformation. But another paper, which was written by Gonzalez and Peker et al., tried to clarify the pathophysiology of this entity by looking at the anatomy of the trigeminal nerve and the trigeminal nucleus. So you can see here where the entry of the trigeminal nerve into the brainstem at the level of the pons passes from the extracranial division and divides itself into three nucleus. We have the mesencephalic nucleus, the principal nucleus, and the spinal nucleus. So we can see the spinal nucleus. It runs from the pons. The spinal nucleus, it runs from the pons down to the level of C2. So together with this spinal nucleus of the trigeminal nerve, we have the spinal tract of the trigeminal nerve also going to the level of C2 at the dorsal horn of the spinal cord. So these tracts most of the time are poorly myelinated or even sometimes unmyelinated and cause them to be more vulnerable when there's a compression. So these tracts, they relay sensation, especially temperature and pain. And the most input are from the three branches of the trigeminal nerve. So that's why they, when there is a damage or compression to these tracts, they can cause trigeminal neuralgia. So they conclude that KRE1 malformation causes trigeminal neuralgia by compression of these fibers around the foramen magnum. This is an image. This is an image which was from the paper of Gonzalez and Piquet et al. They tried to show how the spinal nucleus and the spinal tract goes along down to the C2 level. And here they pass through the foramen magnum, and if there's a tonsil herniation, they can cause compression of these tracts. And this image, I took it from this book. So you can see the same thing, the tract goes down, the branches of the spinal nucleus of the trigeminal nerve and the spinal tract go down to the level of C2 to the dorsal horn of the spinal cord. So in conclusion, surgical treatment for trigeminal neuralgic patients are a good options for these cases which are refractory to medical treatment. Different surgical options have been advocated for surgical treatment of trigeminal neuralgia, and performing lesions of Gaucher's ganglion or microvascular decompression of the trigeminal nerve root are the most commonly used techniques. But preoperative imaging with MRI are necessary so that we can decide proper treatment for these cases, especially if there is a sign of foramen magnum contents compression by KRE1, maybe tonsil herniation or others. It can be resolved by craniocervical decompression and posterior fossa reconstruction. So thank you very much.
Thank you, Dr. Ari. May I call upon Dr. Abdul Kituo for the next presentation, please? Dr. Abdul Kituo is the resident in KCMC. No, Aga Khan, sorry. From Aga Khan University. Karibu, Daktari.
Thank you. Once again, it's truly a pleasure to address you all. This is the second presentation that I'll be making today. As introduced, my name is Dr. Abdul Kitua. I am a fourth-year resident at the Aga Khan University, and our teaching hospital is the Aga Khan Hospital. So at this time, we'll have a brief talk and a case presentation around complications of spine surgery and CSF leak in particular. And this builds on from the talks that were given by our giants yesterday on spine surgery, clear indications, and complications that can arise. So this is the outline of my presentation. we had a 70-year-old gentleman, a retiree, who presented to us with history of lower back pain. He was a patient known to have hypertension and ischemic heart disease on medication, and the history of lower back pain was a long-standing one. And of note was that the pain was radiating to both lower limbs. Rather, the pain was also progressively worsening, aggravated by standing or walking, and relieved by rest and bending forward when walking. He also had transient numbness to both lower limbs, and there was no perceived weakness, foot drop, trauma, or history of recent falls. His past medical history and family and social history were otherwise unremarkable to this particular presentation. So, of note, on his CNS exam, he had a steady gait whilst bending forward, could not at all walk straight due to the lower back pain, with a normal stepping cycle, loss of lordosis in the lumbar region, and mild central and paraspinal tenderness on examination. The motor and sensory exam was otherwise normal. So in view of the physical exam findings and the history that was typical of neurogenic claudication, the impression was degenerative spine disease with lumbar canal stenosis. So we then proceeded to image our patient, and this is the MRI that was done. So there was disc protrusion and canal stenosis at the level of L4, L5 with compression, and that part, and there was also a mild disc protrusion at the level of L2, L3. Yeah, so this is a picture describing the same, and you can clearly follow the significant disc protrusion and compression at the level of L4, L5. So the patient was then planned for surgery, L4, L5 laminectomy and discectomy was performed, and the patient post-op course was otherwise unremarkable and was discharged by the 4th day. However, during progress and follow-up, at 2 weeks post-op, the patient presented to the follow-up clinic with headaches, and was then evaluated with imaging, which revealed he had, of note, bilateral subdural hygromas. And then he also had, at 4 weeks out, post-op, a cystic swelling that was noted at the incision site, suggestive of a CSF collection in the lumbar region in the lower back. So 11 weeks post-op, he then presented with worsening generalized headaches associated with drowsiness and unsteady gait. So the progression shows an unraveling complication of a CSF leak, and at the initial weeks post-op, the decision was made to manage the patient conservatively, managing his pain and addressing the collection which was drained, but without placement of an indwelling CSF drain. But however, the patient's condition continued to worsen. At this point in time, 11 weeks out, there was no altered mentation, loss of consciousness, vomiting, or any new onset neurological deficit. But given the worsening headache, we had to re-evaluate. So this is the MRI 2 weeks post-op. For the sake of time, we're just going to look at the MRI at 11 weeks post-op. An important finding from the initial MRI that was done was that he had subdural hygromas, and in the setting of a CSF leak, this is evidence for intracranial CNS hypotension. As you can follow, from the images that we are reviewing, there was an obvious bilateral subdural hematomas that was more on the right side with a midline shift. So the major complication that we got was a CSF leak post-op. It is important to mention that during the time of surgery, the patient had an incidental dural tear, which was noted and repaired. Therefore, while a CSF leak was one of the possible complications, it was not clearly anticipated because the dural tear that was noted had been repaired primarily. However, in the setting of a significant CSF leak and with intracranial hypotension, as we had seen in my previous presentation, there's increased vasodilation and blood flow. And with the sagging of the intracranial contents as a result of intracranial hypotension, you have shearing and tearing of the bridging vessels, which then results in subdural hemorrhage. And as the pathology unravels, neovascularization results in formation of leaky capillaries with eventual progression and worsening of the subdural hematoma. Across the literature, there's a wide variation in the incidence of durotomies following spine surgery, but a well-documented retrospective study looking at about 1,326 cases had shown an incidence of 3.84, and this compared similarly with other studies that were performed in the West looking at other things other than incidence. And they noted that when you're doing an open posterior thoracolumbar spine surgery, these were the majority of cases where they encountered an incidental durotomy. Jerry and colleagues working at the Spine and Scoliosis Center at Weill Cornell had published a paper looking at what are the common risk factors for incidental durotomy in spine surgery. And the key factors that they identified that were statistically significant were revision spine surgery, laminectomy, and older age, all with increased risk. And another work by Wong and colleagues at Northwestern Chicago, this was a prospective review of about 860 cases, both comparing minimally invasive spine surgery and open spine surgery. And of note was that there was an increased likelihood of incidental durotomy when open spine surgery was performed, increased risk of about twofold in comparison to minimally invasive spine surgery. So several neurological surgeons across the world have been trying to look at what is the optimal way to deal with incidental durotomy and CSF leaks after following spine surgery. And this is one that I adopted from a prospective study by Milton et al. At the Ganga Hospital. They had a prospective series of over 1,912 patients in the span of about 3 to 4 years. And all these patients had durotomies. So they were looking at how they were best managed and what worked and what didn't. And they also tried to look at what were the operative factors that could infer increased risk of durotomy. And intra-op laminectomy stage was the most common stage at which the durotomies were encountered, as well as during the use of a Kerrison Ronger, and those were the percentages. The majority were small durotomies that were repaired, and they are primarily median or paramedian. Only a small percent were bigger durotomies larger than 5 millimeters. And primary repair was done for the majority of the patients. Only a very few patients, 5 patients, did not have a primary repair done. Essentially, these were missed at the time of surgery. Postural headache and fluctuant surgical site collection were the most common presentation which raised suspicion for CSF leak in the series. And of all cause intracranial hypotension, only about 10% of the patients eventually can develop the complication of subdural hematomas. So this is a schema showing the most common sites for incidental gyrotomies during spine surgery. And you can see that rarely, if ever, you have a gyrotomy at the axilla or the shoulder of the nerve root, but the majority of the time it's the midline and most often paramedian. So key questions: what is the optimal approach when faced with such a patient? And how do we evaluate these patients with orthostatic headache and CSF leak post-op? And what are the treatment options and techniques that can be used in dural repair when you identify intra-op such patients to reduce the complication of CSF leak? I'm out of time. This will be an interesting talk for another day, but for our patient, at the time, 11 weeks post-op with the bilateral subdural hematoma and midline shift, we had to perform an urgent decompression and hematoma evacuation with bar holes bilaterally, draining about 80 mils on either side. And he followed an uneventful post-op recovery and was discharged on the 3rd day post-op. The CSF collection that was being followed and managed conservatively resolved completely, and he did not require revision surgery to address the CSF leak. At follow-up 15 months later, there was resolution of both the subdural hematoma and the pseudomeningocele, and the patient only had mild back pain. Thank you.
Thank you, Dr. Harry, for the nice presentation. May I call upon Dr. Eric Joseph? Eric Joseph is the resident from KCMC. Is also going to present about the interesting cases from the KCMC. Karibu, Dr. Harry.
Good afternoon. My name is Eric Joseph. I'm a registrar at KCMC Neurosurgery Unit, and we had a neurosurgery camp recently, and I'm here to present some interesting cases from the camp. So we have a picture here of some of the specialists who took part in the camp. And so this was the case distribution. The camp took place from 15th to 19th April 2024. We had a total of 20 cases which were operated by visiting neurosurgeons from Moi and Mloganzila in collaboration with our KCMC neurosurgeons. We did a total of 20 cases, and that's the breakdown. We had 5 brain tumors, 4 hydrocephalus cases, 3 spina bifida, 2 lumbar laminectomies, 2 encephaloceles, 1 fibrous dysplasia, 1 anterior cervical discectomy and fusion, and 1 cranioplasty. So straight to it, this is the first case. It's the case of ELM, a 10-year-old female patient who was from Arusha. So she presented with a history of headache, photophobia, neck stiffness, as well as lower limb and upper limb weakness. So the headache started gradually, started about August of last year, 2023, together with the photophobia. But the other symptoms, the generalized back pain, neck stiffness, together with weakness of the lower limbs, started gradually in October 2023. And by the end of February this year, she had severe quadriparesis and couldn't walk and was bedridden. And this was the state with which she was brought to our clinic. On review of other systems, there was nothing remarkable. Her past medical history is not remarkable. And she had normal developmental milestones, was a standard 4 student prior to the illness. On general examination was notable for the neck stiffness, and she was bedridden. The rest of the systemic examinations were normal, with the exception of the neurological examination, for which she had hypophonic speech with mild dysarthria and reduced power in all limbs. She could only flicker, except for the right upper limb, which could move a bit. She had intact sensation above the waistline, but there was decreased sensation on both bilateral lower extremities. So initially we did some investigations, and these are the investigations: the full blood picture, which was normal hemoglobin and platelet and white blood cell count. Electrolytes were notable for a slightly lower sodium, otherwise normal. This was the CSF done from a lumbar puncture. It was notable for very high CSF protein, 20,000, as you can see there. And also the culture results didn't have, there was no organism seen. So straight to the imaging. This is the MRI scan done. This is a T1 image with contrast. And, sorry. No, we can clearly see there's a hyperintensity here from the medulla cervical junction and extending down to the spine. It's mixed. It has a cystic component and a solid component. And we can see this better on the next image, from the medulla cervical junction down to the level of T1. And also, it was causing a bit of mild hydrocephalus, which can be seen by the transepidermal seepage on this image. Okay, so the medical management, initially we kept her on acetazolamide, 500 milligram BD, paracetamol for the pain, baclofen because of the spasticity, dexamethasone because of the severe cord compression caused by the mass, pantoprazole just to avoid ulcers because she was bedridden for a long time. And so this was the surgical plan. We did a craniotomy, actually a suboccipital craniectomy, and limited cervical laminectomy so that we could access the tumor. So this is some intra-op images. You can see the visiting neurosurgeons operated on this child. And this was the ultrasound-guided needle cyst decompression that was done intra-op. So intra-op, the mass was very hard to differentiate from normal spinal cord tissue. This is the pathology report, and they suggested a benign lesion, most likely a pilocytic astrocytoma. So the post-operative cause. Currently, this patient is still admitted at KCMC. She is in the pediatric ICU. She's in the ICU because she couldn't be extubated post-op. She kept desaturating. And also, okay, on day 3, she developed, on examination, she had decreased air entry on the left side. A chest x-ray was done, which showed an opacity, and a chest CT was done, which confirmed atelectasis of the left middle lobe of the lung. So currently she's on oxygen by nasoprongs and being treated for lobar pneumonia with IV vancomycin. So what's the way forward? We have to discuss with the Oncology Tumor Board for the chemo and radiation options, and also repeat imaging within 3 to 6 months. Further operation is not recommended due to the difficulty in finding intraoperative planes. So this is the second case. We have a case of HAS, 43-year-old female, who was from Moshi, Kilimanjaro. So the patient presented with a long-standing headache, which was on and off for more than a year, progressively worsening with time. No history of convulsions or weakness of lower limbs or vomiting. A bit of a caveat, this patient had a motor traffic accident 1 week prior to admission to, 1 month prior to coming to see us at our clinic. And in this motor traffic accident, she lost consciousness for a few minutes, but had no other symptoms. A brain CT scan was done. There was nothing from the trauma, but the brain CT scan was the one which showed the tumor, and then she was referred to our facility. So the review of other systems was unremarkable. She had one previous surgery for vesicovaginal fistula repair. On examination, there was also nothing remarkable. On CNS examination, she was completely normal. So these were the labs, also completely normal, to save time. Echo was significant for grade 1 diastolic dysfunction, but with normal ejection fraction. Okay, so this is the pre-op MRI. This is a T2 FLAIR image, and you can appreciate a mass, an extra-axial mass, arising this area on the right cerebellum, abutting the tentorium. And also on some still images. This is a T1 weighted image with post-contrast, and you can clearly see this mass, which enhances on contrast with a mixed solid and cystic component. And this image was also very helpful in deciding the operative approach due to the clear visibility of the sinuses. Some further images for the same patient. So the surgical management. The plan was to do a posterior fossa craniotomy for tumor resection and biopsy. And the craniotomy was planned across with consideration of the transverse sinus, ocular, and the occipital sinuses. So this was another intra-op image for this patient. This was the bone flap for the craniotomy done. So this is a post-op CT, which was done for this patient. And we can see it. Nothing remarkable other from that. Sorry. Sorry, I'm having some trouble with this video. Okay, so that was the post-op CT scan with contrast. So this patient was discharged from our facility on 24th April and is scheduled to attend clinic on 8th of May for follow-up. On discharge, she only had mild pain at the surgical site, no other complaints, and the pathology results for this case are still pending. So a special thanks first to Dr. Shabani, Dr. Makundi, and Mr. Juma. These were part of the neurosurgery camp that came from Moi and Mloganzila to KCMC. Here in the photo pictured is Mr. Juma, who is a nurse and one of our nurses at KCMC, Mama Umi. Also a special thanks to our own neurosurgeons, Dr. Rabiel and Dr. Kerry, as well as to the neurosurgery registrars, Dr. Goodluck, who presented here, who had a huge part in organizing this camp. Yeah, some more pictures from the camp, and this is a post-camp dinner with Dr. Shabani, our own EDR, Professor Masenga, Dr. Makundi, Mr. Juma, Dr. Rabiel, and Dr. Kerry. Thank you for your time.
Thank you, Dr. Terry, for a good presentation of the previous camp. May I give a short session for Q&A before bringing up our sponsors, Reliable Diagnostics? So we will be having 5 minutes discussions. And at first I want to introduce to you a consultant neurosurgeon from Switzerland, Dr. Bati Atta Alim, who is currently following us on YouTube, on Zoom. He wanted to put up a comment from the previous presentation that has been presented. So may I give this opportunity to Dr. Bati? Yeah.
Thank you so much.
Just a second.
It's
just
amazing to see this.
a second, Dr. Bhatti. We want.
Congratulations, Professor Shabani and team. It reminded me more than a decade ago when Professor Kenasha and Professor Kahamba were building up the basics of advanced neurosurgeries in Tanzania. I was there and I had a chance to interact with them. It's amazing to see how the residents have grown, and I'm impressed the way the complications are discussed openly. This is something which impressed me the most, the teamwork, the organization, especially a discussion, open discussions on complications, which are clearly showing a very bright multi-centers coordination and multidisciplinary teamwork in future also. So I just want to raise a very important area that not only in lower middle income countries, but all over this endovascular neurosurgery. So if you go to the background of this endovascular specialty, so all work was done mainly by the clinicians, by a neurologist, Igas Moniz, who started it in 1934. After him, Professor Krahenbol and Professor Yashirgul. But unfortunately, neurosurgeons and trainees are not getting that opportunity, and we are, as a fraternity of neurosurgeons, losing this ground. So this is something I would like to bring in, that the many presentations, like the the spinidal approach case for a complex abscess and prolectinoma, and the carotid tumor, those all, the one hello, the one where the proximal ligation was done. So all could have benefited with more endovascular facilities. So I'm an advocate of that neurosurgeons should be on the driving seat on endovascular. So I'm looking forward to have more interactions with you guys, and I'm ready to help you wherever you feel my need. Thank you so much, and it's my pleasure to be here.
Thank you so much, Dr. Bhatti. May I welcome other questions from the presenters? If you have any burning questions from the previous three presenters. Dr. Othman, yes.
Yeah, my question goes to KCMC on the patient who had a long spine tumor and currently still in PICU with lung collapse on one side. Is there any chance of doing bronchoscopy and see if there is a plug or something else on this lung? Or was there an intra-op accident, so accidentally maybe you entered you entered the chest cavity? But first, I think there is a chance of doing bronchoscopy.
Thank you, Dr. Hoffman, for that suggestion. First of all, there was no intra-op accident, but we will consider the bronchoscopy. And when I get back to KCMC, that's something we'll do, because I believe it could improve the outcome of the patient. Thank you once again.
Any other question, Dr. Magogo? Yeah.
Thank you. My question goes to Dr. Mulhat. So I think you did the posterior decompression for the KRE1 malformation. So my question is, did you do posterior decompression with or without uroplasty? And if you did with the duroplasty, did you had to use bipolar to coagulate the tonsils?
Okay, thank you for the question. I think I mentioned it in my presentation that we did the right tonsillar coagulation. We coagulated small part of the right tonsil. And also we did a duroplasty by using muscular fascia.
Yes, comment from Dr. Ruta. Thank you for the presentations. I was also interested in the case with the an intramedullary tumor from KSMC. How much subaxial bone work did you do, and how much myrotomy did you do in removing the tumor, which was exactly intercapsular and interaxial, but probably well encapsulated?
Can you answer that, or we give it to Shaban?
I'll attempt. So, intraoperatively, what was done was a small suboccipital craniectomy together with C1 and C2 laminectomy. So, after this, the dura was excised, and we could visualize the spinal cord, but it wasn't very clear which part was the tumor and which part was the spinal cord. I was with Dr. Shabani and Dr. Makundi, so they had loops, and I think they could see better, and they only chose to excise a very small part, which they were sure was the tumor, and that's what we got for the biopsy.
Okay, and I don't see Dr. Humba. I just wanted to comment on the big prolactinoma they operated on with the brain abscess. I think the brain abscess is the one which was causing the seizure. And now I was asking myself whether was the brain abscess incidental, or is it the prolactinoma which was incidental?
Could you repeat? He was away.
Okay, Dr. Humba. About the MDT, that's a very good practice, and that's what we are advocating, especially in pituitary tumors. The endocrinologists, they normally take good part of the prolactinomas, but most of the time the prolactinoma is not going to cause a seizure. Maybe it was eye-opener that when the patient has a seizure, most probably he has a cortical irritation, and that was being caused by the frontal mass, which we saw on the CT. So what was incidental? Was it a prolactinoma or an abscess? What was the CT for? I mean the MRI, what was it done for?
Thank you. To answer your question straight, the patient presented with seizures and weakness. So that's why we scanned. So although the case looks incidental finding, but to her, infertility issues weren't an issue. She had a history of headache for a long time. She never thought that was a concern to her. I usually joke with my gogo friends. I'm sorry kama kuna mgogo in this house. Kwamba kwake yeye kukosa mtoto kichwa kumuuma was not an issue. She only came to hospital when, in fact, she had seizures. But when she started developing weakness, that's when she came to the hospital. So, would you say that was an incidentinoma? I don't know. Incidentinomas or in prolactinoma, these are purely incidental findings. Somebody gets an accident, you scan for that, and this you find. And usually, the hormonal part, I am not sure whether in incidentinoma somebody would have such a history instead of infertility and things like that prior to that. So, but what brought the patient to the hospital was weakness and seizures.
Yeah, most time in the prolactinomas, we normally have the amenorrhea galactorrhea complexes. And for the clinician, when you see a lady in the age-bearing, childbearing age with the primary or secondary infertility, the only thing that comes in your mind is probably something in the pituitary. Okay? So that is very important to check on it. Probably she didn't come to the hospital, but whenever I come to the hospital, the first thing to do is to think about it. And then when you do the hormonal profile, together with the, you are going to see something on there.
May I cut short this because of the time? I give you 5 minutes, only 5 minutes. And thereafter, we have to go for lunch quickly, and then we come back here at 2 o'clock because we are going to have a live session from New York, a professor who's going to present. So it will be a quick lunch.
Okay, good afternoon. Good afternoon, all of you. My name is Caroline from Reliable Diagnostic Center, and we are honored to be part of this team, to be part of this inaugural meeting that you're having. And I have a short presentation about Reliable Diagnostic Center. I know most of you are aware, and we have worked with many of you, but let me have this opportunity to show others what Reliable Diagnostic is all about. So Reliable Diagnostic was started in, it was incorporated in 2016, but we started operations in 2017, end of 2017, and it was a center that was established to fill the gap that was there in the market at that time. We did not have enough MRI, CT scan machines in the market, and there was a need. So there was a need of having these services. And so we only deal with MRI and CT scan. So we have a small team. So our vision when we started was to provide quality, affordable healthcare diagnostic services, and we also wanted to be a choice, a premier of choice for Tanzania and Africa as a whole. So we started Reliable Diagnostic Center under the tenets of good principles. We were customer-oriented, focused. We wanted a culture of excellence and accountability. We also were looking for competency, commitment, integrity, and of course collaboration and CSR or something like this, what you're having now. So our team, when we started our team, comprised of professionals from Tanzania, from India, from Kenya, but we are happy to know that now 90%, all our professionals are Tanzanians. So we have grown to have good electronic management systems, and we are able to report the images remotely. Actually, Dr. Baloa, I'm sure Dr. Baloa is one of your colleagues, mostly reports, like 99% of the images are reported remotely. We are able to, he's able to log into our servers and get real-time images. So I have heard the team saying that you need to build a team of neurosurgeons, neuroradiologists, and I'd like to say Dr. Balo actually does have a postgraduate diploma on neuroradiology, and then he went and did intervention radiology thereafter. So if you visit our center, you'll find that we are patient-centric. We are focused on providing comfort and care, and we make sure that patients are feeling very comfortable. So we have what is available in most of the centers, especially like in the government setup. We have Siemens 1.5 Tesla MRI machine. That is what is also now found in most government hospitals. Our CT scan is 128 slice CT scan, which is also still available in most government hospitals. And we all know the benefits of having this high state-of-the-art equipment. So we pride ourselves in being people of integrity. We have strong corporate governance, and we are committed in working using the high standards of service, and we also try to be quite ethical. So This is some images of our center for those of you who've not been able to visit. The radiographer here was from India, and he helped us set up very good protocols for the MRI and CT scan. And I think we had a good foundation when we started our services. He's no longer with us. He traveled back to India, but he trained the team that was on the ground. So we have been fortunate to partner with most insurance companies, and we are happy that we are able to serve all members of the public, whether they are not insured or NHIF or privately insured. We can assure you we treat all our patients the same. There is no discrimination because of the cost of care, because the cost of care, of course, depends on who the payer is. So I'd like to welcome you to Reliable Diagnostic Center, and we hope that you're going to continue partnering and working with your team. Thank you.
Thank you very much. At this juncture, may I ask you, all of you, to lead the way to the lunch and make sure that by 2 o'clock you are back to the seat for the next session. We have only 15 minutes.
Ground floor.
Quickly, please. Roman.
Hello. Hello. Hello? Hello? Hello. This is Ed Benzel. I believe I'm to talk.
Yeah, I think it is lunchtime now, so after lunch. It's lunchtime, it's lunchtime.
So when do I talk? How far from now?
I had about 15 minutes.
Hi, Professor Benzel. Good afternoon.
Good afternoon.
Good afternoon, Professor Benzo.
Good afternoon.
We'll be back after 20 minutes from now. It's lunchtime.
20 minutes from now. Okay.
It's an honor for us, Professor Wenzel. So it's blessing in disguise. The delay has made us able to talk to you directly.
Well,
So I am Matabati. So I'm neurosurgeon, also trained in neurointervention with experience in lower middle income countries, practice now in Geneva, Switzerland. I just see how craniovertebral junction.
Hello, good
was
afternoon,
made.
Professor Benzel.
Yes.
Can you hear me?
Yes.
So my name is Dr. Miranda. I'm the MC for today's event. We've had some slight delays because of the inaugural ceremony. There were some slight delays by the delegates. So if it won't bother you so much or significantly impair your schedule for the day, we would like you to allow us to extend the lunch break for another 10 minutes, if that's okay with you.
That's okay.
Yes?
But then after my talk, I'm going to have to leave. Is that okay?
Perfect, perfect. So can we meet at 14:10 hours, Tanzania time?
Yeah, that would be 7:10.
Awesome. Thank you, Professor Benzel.
I'll just stay on, or what should I do?
Yes, please.
Okay.
Thank you very much. And we apologize for the inconvenience.
No problem. Thank you.
Thank you.
So, Professor.
Yes.
Yes, I just started my microneurosurgery when it was craniovertebral junction. Your research, your papers were my teachers. So indirectly, I'm your student. So
well, thank you.
it's honor, and I like to know the changing roles of neurosurgery and neurosurgeons. So, do you think the microneurosurgery and neurosurgeons are losing battles? Because my experience is that in lower middle income countries, now the few specialties are encroaching us and deciding things, and we have lost the driving seat. For example, when it comes to giving radiation, there are many places where radiologists are deciding without giving consideration that how important is biopsy, how important is microneurosurgery to give cure. And similarly in neuroradiology. So I'm 2 years trained from Professor Valavanis in Zurich in neurointervention. But when I went back to my country, I started practice. So I have to experience a lot of issues from the radiologists. Without any clinical background of training, so they at times, they try to play a role of clinicians without multidisciplinary approach. And our leadership is losing their credibility, at least in lower middle income countries. So I'm just trying to learn your view on change of neurosurgeons and their responsibilities now.
Well, this isn't so in the United States.
Sure.
Our neurointerventionalists are both radiologists and neurosurgeons, and at the Cleveland Clinic where I practice, they work together as a team. There's neurologists who do intervention, radiologists, and neurosurgeons.
Right. So this is how it should be. So I'm not against of other specialties to get involved. But the way the neurosurgical training is lacking in getting volume and training in these specialties is a major concern in lower middle income countries. So there is a lot recently moved towards stroke interventions and other fields, but what is happening is that the neurosurgeons they have failed to train the new generations, and they have failed to protect super specialty trained neurosurgeons.
Well, I don't know what to say about that. They need to. That's their responsibility.
Yes.
Is it not?
Yes, it is. Definitely it is. So the America, Japan, India, we had all the international fellows in University of Zurich when Professor Valavanis used to train them as international training programs. Yashir Gill was his mentor. Professor Yashir Gill used to visit to us, and the harmony between them and the clinical background was something impressive. And this teacher-student role in giving neurosurgeons training of vascular was amazing. And when in my practice, I went to go for craniovertebral junction issues like foramen of magnum meningiomas, the posterior fossa tumors. So this vascular understanding was helping me a lot. So in your days, were you using endovascular DSA for selective C1-2 pathologies? Because MRI was not that popular.
Yes.
So were you using selectively? What were your view on DSA preoperatively for complex posterior fossa and craniovertebral pathologies for a neurosurgeon who's...
Yeah, I'm not the right person to ask that. I do almost solely spine surgery.
Right. But even for complex spine problems, vertebral artery anomalies and variations could influence the outcome.
Sure. If there are anomalies, I would ask one of my interventional colleagues to help. I would ask, and the one I would ask is a surgeon.
Right. Right. Thank you.
Yes. Interestingly, or not interestingly, I no longer operate. I'm 75, and about 8 months ago, I was afflicted severely by Lyme disease, which is a tick-borne bacteria, and developed a tremor and balance issues, and so I quit operating.
Right. I wish you a healthy and active life, Professor. So your presence in meetings and your articles, because reading articles is something different, but listening you and your presence would always help juniors to get more safe knowledge. We wish you a perfect health.
Well, thank you. I'm going to step away for about 5 minutes, and then I'll be back, but I'll leave my screen on.
Sure,
Okay?
Professor. Sure.
Okay. Okay, I'm back now.
Good afternoon.
Good afternoon.
Welcome for the afternoon session from Dar es Salaam, Tanzania. In this afternoon session, we will start with Professor Edward Benzel, Chairman, Department of Neurosurgery, Director Center for Spine, Cleveland Clinic, Lerner College of Medicine. This is a renowned professor who is very active in the AANS, NASS, amongst others. He was a co-chairperson of the editorial review board of the JNS. Currently, he's the chairman of the review board of the JNS Spine. He has also served as a reviewer for Neurosurgery Spine and the Spine Journal, has authored more than 10 textbooks, 28 texts, and contributed to over 370 chapters. Welcome, Professor Edward Benzel, for your talk.
Well, thank you. I'm going to address for 20 minutes. I'm going to share my screen, correct?
Yep.
Thank you very much for inviting me. Can you see my screen?
Yes. Yes, we can. Yeah.
Okay. I'm going to talk about manuscript writing.
No, sorry, Professor, we don't see your screen.
What's that?
Can you share your screen?
I did. Share screen. This will stop others' screen sharing. Do you want to continue? Yes.
We can see you, but we can't see your presentation.
Well, I'm hitting share screen. I'm not sure.
Maybe you can close
Okay,
and share it again.
now we can see it. Now we can see it.
Okay.
Yeah.
Is that good?
Yes, now we're good.
Okay. Okay, my topic today is essentially manuscript writing. I am the editor-in-chief of World Neurosurgery, and I'm going to talk about how you can most effectively get a paper published. World Neurosurgery has a lot of sections in it that other journals may not. Socioeconomic neurogenesis, art, doing more with less. And there are a lot of creative people around the world who have limited resources and yet accomplish a lot. And this was an article written 7 or 8 years ago by a surgeon who made his own micro dissection tools because the cost of buying them was prohibitive. So let's start off with the fundamentals of writing. Mark Twain, author, etc., said, "I didn't have time to write a short letter, so I wrote a long one instead." It is so easy to be very wordy with a manuscript and not transmit appropriate information. Blaise Pascal said, "I have made this longer than usual because I have not had the time to make it shorter." So what is a properly constructed manuscript? Well, most of the time, we have a title, abstract, introduction, oftentimes with subheadings, a method section, oftentimes with subheadings, and the same for results, discussion, and discussion section, and then finally, a conclusion. We must organize our thoughts when we speak and when we write. And so I recommend writing a manuscript after you make headings and subheadings and then fill in the blanks, if you will. It is so common for people to put, authors to put information that should be in the results in the discussion section and vice versa. So one must be very clear and orderly when constructing a manuscript. Again, make an outline that's based on what you have just done. The subheadings help compartmentalize and put single thoughts or concepts into a section of the manuscript so that it is, these thoughts are not dispersed throughout the manuscript, but concentrated in the area that they should be. Remember when writing that the reader, or when talking, the listener is not familiar with your information that you're transmitting. Your job is to make them familiar, but don't waste words. Tell them what they need to know, not everything you know. So we'll start off with, by going through all of these. The title is a sparkling diamond. It attracts attention. So if a reader is perusing a journal, they may skip articles that don't catch their eye. So the title should catch their eye and attract attention. The abstract should be a summary. It should also catch the eye. It should be catchy, sensational, informative, descriptive. Usually it should be short and it should sustain attention. The reader needs to go into this level before the next level. So the title attracts attention and the abstract furthers the attention. The introduction asks the question, why? Describe the problem. Explain why that problem is important. Next, briefly review what has been done so far to solve the problem. And then finally, introduce the study that you're writing by pointing out what is different about it compared to prior research. Materials and methods section answers the question, how? Include enough detail so that others can repeat the experiment, provide relevant details, describe treatment and controls, and make sure that the section is easy to write. Hence, since it is usually the easiest to write, the author should probably start here. The results answer the question, what? State only the results. Other comments and explanations belong in the discussion. The results section can be short. Much information can be presented in tables or figures, and do not duplicate data presentation, for example, in text, a graph, or tables. Discussion answers the important question, so what? Expound on the results. Explain contradictory results. Discuss statistical significance. Discuss generalizability. Outline limitations of the study. Suggest future lines of work. And finally, sum up with a conclusion. And the conclusion should not be overstated. It should be derived from the data presented and supported by the data presented. It should be rational, useful, applicable, and novel, and it is not sufficient to present a large number of patients alone. It is common, plagiarism is common. It is the practice of taking someone else's work or ideas and passing them off as one's own. It is oftentimes innocent because authors may not have a great grasp of the English language, and therefore use phrases or sentences from other publications. But keep in mind that journal editors have, in one form or another, a tool called cross-check, where a manuscript can be compared to the literature, and in a few seconds, one can see the lines and sentences that have been extracted directly from other articles. So the reviewers are watching you, and so be very careful with that. Here's an example where 20% of the manuscript was copied from other manuscripts. I will often state there are many uncited phrases and sentences that are taken from prior publications. This precludes submission for review in the current form. Hence, the manuscript is rejected. Pre-review, the authors are encouraged to rewrite in their own words with English editorial assistance and resubmit to World Neurosurgery or elsewhere with English editorial assistance. That assistance should address usage errors, grammar, and syntax. Grammatical is anything that has to do with sentence punctuation or the correct way to write or speak a language. Usage is the way in which words or phrases are actually used, spoken, or written. And syntax is the way in which linguistic elements, such as words, are put together to form constituents, such as phrases or clauses. Sentence structure is critical, and World Neurosurgery actually provides a service called Global Champions, and I'll address that in a bit, to help authors whose paper has meaning, but it's hard to extract it because of poor English. This is the Global Champions. We have about 20, usually medical students or young residents who are able to review the manuscript, to not alter content, but to improve readability. We published our initial experience with this, and we're able to help 20 or so manuscripts that otherwise would not have been published to be published. Now I'd like to, I'm assuming that most of you in the audience, for most of you, English is not your first language. Is that true? So it's important to be the best you can be in this regard. And I've listed 3 books here. One is the Strunk and White, The Elements of Style, is just a boring book, but it has all the rules of English, the English language within its pages. It's actually a small book. The one on the lower right is by Stephen King, the novelist, who wrote a book also on writing. How does he write? How do thoughts come into his head? And how does he put it on paper? And then a editorial guru, Cormac McCarthy, who wrote No Country for Old Men, has some brilliant guidelines for writing, and I'd like to share them with you. First, use minimalism to achieve clarity. Remove extra words or commas whenever you can. Decide on your paper's theme and 2 or 3 points you want every reader to remember. If something isn't needed to help the reader to understand the main theme, omit it. Limit each paragraph to a single message, and that is related to what I was talking about earlier in making things clear, creating an outline and keeping single thoughts in each section or paragraph. Keep sentences short. simply constructed and direct. Try to avoid jargon, buzzwords, or overly technical language, and don't use the same word repeatedly. It's boring. Don't over elaborate, only use an adjective if it is relevant. Don't say the same thing in 3 different ways in a single section. Choose concrete language and examples. When you think you're done, I think this is critical. When you think you're done, read your work aloud to yourself or a friend. Find a good editor you can trust and who will spend real time and thoughts on your work. Finally, try to write the best version of your paper, the one that you like. You can't please an anonymous reader, but you should be able to please yourself. And when you make your writing more lively and easy to understand, people will want to invest their time in reading your work. From the journal's perspective, we have thresholds. Case reports provide unique information, are rare or not just uncommon, and unique. World Neurosurgery does not accept case reports anymore because we were being inundated with them. But if you do have a case report and you seek to have it published, make sure it is quite unique in what it presents. Again, not simply uncommon. Is your work of archival value? And if you're asked to revise the manuscript, address all comments in the revised manuscript, in the text of the manuscript, in red or track changes, so that the reviewers can then assess your changes easily. Do not argue and be collegial. What if rejected? Well, what is my motivation? Is this work worthy of dissemination? Have I optimally prepared this manuscript? If rejected, do I trash? Do I resubmit or submit elsewhere? Bottom line, heed the critique, take them very seriously, and honestly self-assess. Resubmit and heed the critiques. I already mentioned the global champions. Please use them if offered to you when submitting an article to World Neurosurgery. And I thank you very much. I think we have a couple of minutes for questions if you would like.
Thank you very much. Is there a question?
How many people are here?
Something like 55.
55. Okay, great. That's impressive. How many of the attendees have submitted articles to World Neurosurgery, Journal of Neurosurgery, Neurosurgery, or other journals? I see. Okay. Have you found that process rewarding?
It was a long time ago. It was a case report and case series, but it was a very nice process. I mean, very structured process of submission.
Yeah. Yes.
I have one question. What
Yes.
percentage of plagiarism do you reject the article? What percentage? And another question is, how true when it comes to bias, depending on the geographical location of the one who is writing the article? Is there any bias for people from Sub-Saharan and other parts? How true is it?
Okay, not sure about the second question. The first question is that the answer is that all three of the journals that I mentioned reject about 80% of the papers submitted. So there's a quite high rejection rate. I didn't really catch the second question, but I think it was relating to articles from lower income or resource challenged areas of the world. I know that we at World Neurosurgery really want these articles to be published, and so we give them more attention. And that, for example, the global champions, and help what may have been a hopeless manuscript to actually become published. And we've had some great successes there. Now, I don't think I answered your second question. Can you, or did I?
The first question was regarding to what percentage of plagiarism that you consider before you report?
Plagiarism.
Yeah.
I can't tell you. I would say, just thinking off the top of my head, and I'm going to include innocent plagiarism and blatant plagiarism. Blatant is egregious, where the authors are basically stealing information. Innocent is where the authors are just trying to publish, use words and phrases that sound good, and so they borrow them, if you will. Blatant plagiarism, I'd say, occurs in a fraction of a percent, or less than 1%. Innocent plagiarism is probably about 3 to 5%.
Any other question or comment? Well, if there's no other question.
Thank you very much, Prof, for the talk. If at all we wish to follow you up, are you on Twitter so that we may be able to follow you?
Am I what?
Are you on Twitter so that some of us are aspiring what you have achieved so that we may be able to follow you?
Are you on any social media, like X?
Oh, no, I don't use social media. I'm sorry. I'm sorry. I'm an old man.
Thank you very much for your time. I think we can proceed with the next talk.
Okay.
Thank you. Thank you, Professor, and have a good day. So we will continue with the next speaker. The next speaker is Dr. Romani. He's a global neurosurgery fellow. He will also make his presentation online. Dr. Romani, are you ready for your talk?
Yes.
You can start.
Thank you. Can you see my slide? Yes. So, hello everyone. Good afternoon. I'm Dr. Roman Sabas, currently a research fellow at Well Cornell Tanzania Neurosurgery Project, working at Moi Neurosurgery Department, Tanzania. I just got a 3-week visit to Scotland to observe the neurosurgical practice in UK. People, so to begin with, I got this opportunity to come here and see some practice, but also I got a fund for presentation in the British Neurological Society meeting in Edinburgh. So my talk today will be about can Tanzanian neurosurgeon access Tanzanian neurosurgical literature. This is a systematic review and a survey combined. To start with a little bit of background, we all know that for more than 10 years, probably 15 years, Tanzania has been involved in a long-term neurosurgical collaboration with institutions from high-income countries. And this has enabled knowledge transfer, skills learning, and research capacity strengthening. And of course, through these collaborations, a good number of publications have been coming out. So to have maximum impact, findings that are resulted from this initiative are needed to be open to researchers, clinicians, and the policymakers in our setting. So having that in mind, we wanted to know, to assess whether the published neurosurgical literature from Tanzania are accessible by the Tanzanian neurosurgeons. And we also explore the methods and the means that are used to access the data or articles that are resulted from our demographic, from our settings. So what we did a systematic review of all Tanzanian neurosurgical published articles from distant past to recent, and we also analyzed the authorship distribution and assessed for open access status. We conducted a survey to the active practicing neurosurgeon in our country and asked how do they search for and access Tanzanian neurosurgical literature. This review was registered in a Prospero database with that registration number. So to show a Prisma flow diagram of how we did this work, we screened around 73 articles across 3 databases, PubMed mainly, Web of Science, WHO. Through confidence, we automatically remove all the duplicates, and in the end, the work that we did in a collaborative way by the team that I mentioned later, we managed to get around 96 articles that were purely about Tanzanian neurosurgical practice. So, and these 96 articles were mainly published across 42 journals, specifically the World Neurosurgery, and they were started from 1982 to 2023. That were the most recent. Major and main topic of the list, the TBI, were mainly discussed, followed by neurosurgical education. This is kind of topic, paper that describing the practice, challenges, training, and the capacity building of neurosurgical activity in Tanzania. Of course, the third one was a spine trauma. The list was infections, hydrocephalus, dysraphism, like scoliosis, and so forth, with endovascular being rarely presented, like we only have one paper for neurosurgical endovascular intervention paper. So the blue line represents the number of articles, and the yellow one represents how many are open access that I will be discussing the next slide. After analyzing and checking this paper, we found out 59 articles out of 96 were openly accessible through the publishers. that this is the article that when you put their title, you directly get it freely through the internet. And we tried to search if there might be available in other repositories like institution repositories and so forth, but unfortunately we couldn't get one of those who were not open in those repositories. We found something interesting, that most papers that were authored by first or last author from Tanzania were highly likely to be published open as compared to those which were authored by non-Tanzanians. But also other factors like funding availability, if we are mentioned, and late publication date were significantly associated with high rate of open access. So this is a graph that's showing the trend of number of literature, Tanzania neurosurgical literature, that have been published from 1982 to 2023. There is a skyrocketing, like a sharp increase of literature, but also the number of open access are significantly increasing over time. We were interested to know the authorship distribution that have been consisted in this body of literature, and we found out the Tanzanians' first, second, or last authors were listly presented in this body, and mainly were populated by non-Tanzanian from mainly from high-income countries, USA, UK, and so forth. And if Tanzanian were to publish the articles, we found out they were likely to publish in the journal which have impact factor less than 2, as it is highlighted by the blue line, I mean the blue bars, and the red thing is represented for impact factor larger than 2, which were mainly populated by non-Tanzanians. So that was an interesting thing we found out about the body of literature on neurosurgical in Tanzania, were mainly represented by people outside the Tanzania. So findings from the survey that we did, we managed to contact the 27 active practicing neurosurgeons currently in our country, and 23 were able to respond, giving us a 85%, a very high response rate. And out of those 23 that were able to get their feedback, only 9% have an institutional login or use initiatives such as HINAL to access non-open literature about Tanzania. And of course, 44% use or ask friend with an institutional login to assist. The majority do not bother to look for the full text at all. They just end up reading the abstract. And of course, this is a sketch describing the process. The total number of articles are 96. Those that were available freely through the publisher that anyone can access was 62%, and non-open access were 38%. But neurosurgeons, around 56% of those articles were be able to access through HINAL initiative, and those that were not be able to access through HINAL can be accessed through Sci-Hub, and around 9 articles were completely inaccessible via the method that I have explained previously. So in conclusion, we found out around 1/3 of the neurosurgical literature about Tanzania is behind a paywall that half of neurosurgeons are unable to access. It is important to access literature, especially about our data, since this can help in developing and improving patient care based on the current evidence and published from the published literature that are coming out We are inviting collaborative initiatives such as the HINAL to be improved, to improve in coverage, like to have wider coverage of literature, that people who are using that such initiative to be able to get access to literature. As we know, the cost of publishing articles open freely is very high. Like some journal cost around $3,000, £2,000, etc. So that is quite big. So we need WHO established this initiative of HINAL, and it is freely for all institutes that are from low and middle income countries or in developing countries such as Tanzania to just join, and all the workers that are working in those particular institutes can get an access, can get a login access to be able to see and read a massive amount of articles in HINAL. However, HINAL is not a perfect, a comprehensive solution. We need further initiative like institutional repositories, university like MUHAS, hospital like Moi, and the others in Mloganzila can have the hospital repository or university repository where articles from Tanzania can be stored there, and the workers, the people, the neurosurgeons can be able to access through their own institutional repositories. Thank you so much for your time. I would like to acknowledge the team led by Dr. Shabani, Professor Hato, Julie Whitfield, Dr. Magari, and of course our executive director, Director of Neurosurgery, Dr. Remeli, my friend Anton Consolata, Chief Zarina. We had this team of they are working, the hard working of cross-searching the literature on Tanzanian neurosurgical. So we did a very good job for this. I have to acknowledge the whole team for the wonderful work. Thank you so much.
Thank you very much, Dr. Romani, for that very enlightening talk. This is a very pertinent subject. Anyone would like to comment or ask a question?
Hello, Dr. Romani, how are you? This is Dr. Magogo. If I may ask, and kindly allow me to ask I have no conflict of interest, but for example, if the topic was, can Tanzanian neurosurgeon access Tanzanian neurosurgical data instead of literature? Let's say things like Red Cup. Can a neurosurgeon from Benjamin Mkapa be allowed to access the Red Cup and publish in those, how do you call them, Red Cup, how do you call them, database? And in Swahili, kumekuwa na hisia za kwamba hawa collaborators wanaiba data. Naweza niseme hivyo, yani hizo hisia na tetesi. Kiasi wengine wamekuwa wakiogopa, au hao collaborators wamekuwa wakikashwa tamaa kuja kucollaborate kwa sababu ya hisia kwamba wanaonekana ni kwamba ni watu ambao wanakuja kuchukua data. Sasa how true is this? Nitaka nijue kwa upande wa hilo jambo. Is it true?
Yeah, of course. Thank you so much, Dr. Magogo. Yes, the topic, can Tanzanian neurosurgeon able to access Tanzanian literature? Literature or data, yeah, it's very good title. We can put it data, including both the published data and unpublished data. To speak about the data that are normally stored in LEDCAP, for example, from high-income countries, data are from our institute, stored in high-income countries, LEDCAP Institute. So I think that is the issue of management and administration staff. There is some agreement, and there are people who have have access to those data. Not everyone can have access to the data, but I'm quite sure that through certain agreement that the two collaborations, they have selected some individuals from our settings to have access, direct access to those data. There is challenges, and we have suggested that at MOI, for example, to have its own LEDCAP and other institutes as well, so that through in every collaboration, like in every research collaboration activity, all the data collected might be stored and remain freely to the people involved. But currently there is still a challenge on a good way of creating registry of our own and making it sustainable. That's why we are still remaining to have to depend on the international collaborators systems like REDCAPs. But I'm quite sure not everyone is able to access those unpublished data. But there are quite few individuals in these settings that have access to those login.
Thank you. Is there any other comment or question? Mr. President, would you like to comment something about? Thank you. Thank you, Dr. Romani. I think we'll pass to the next presentation.
Okay.
Okay, our next speaker is Dr. Ingaya Kale. Dr. Ingaya is the all-rounder, the Secretary General of our newly inaugurated society. She's a neurosurgeon and one of the pioneers of transsphenoidal surgery at MOI. Welcome, Dr. Ingaya.
Good afternoon, everyone. I wish I didn't take this post because I'm so tired now. Okay, so I'm going to talk briefly on how we started transsphenoidal pituitary surgery at MOI. We all know you can't hear me, oh, sorry. We all know that the endoscopic transsphenoidal surgery has been there for the past like 100 years, and it's been evolving ever since. So it started with, in 1907, this is when it was introduced, and at some point it was abandoned. But somewhere in 1920s, Cushing's improved the transsphenoidal pituitary surgery by introducing the transeptal, translabial approaches to the skull base. But he also abandoned it at some point. Dr. Jules Hardy in the 1960s, he introduced the use of microscope in the going through the skull base to take out the pituitary tumors, and the endoscope was finally introduced in the 1960s. But a series of endoscopic pituitary surgery was first written by Carrau and J. Hu, and it was done at around 1960s, and they wrote the first report, a paper on endoscopic pituitary surgery. So going through the cellar, through the skull base, you can either do it microscopically or endoscopically. So when you do it microscopically, it's like looking, this one, it's not mine, I borrowed it from somewhere. It's like looking through a door outside. You can't see properly. When you put in the speculums and you put microscope, you will not see properly in the cellar. But when you use a telescope, you can see nicely, you can see through the angles. You have a good panoramic view. And you can use different kind of scopes. You can use like 30 degrees. Normally we use 0-degree scope, but you can use 30-degree scope, and you are able to maneuver more. You can go in and out of the cellar using a scope. So it's easier with a scope. I just said that. So we started endoscopic pituitary surgery in Moi in 2018, but we somehow stopped because of unforeseeable reasons. There was at some point like COVID, and we had, we didn't have so much experience, and we were depending more on the visiting doctors. So effectively in 2019, we started creating teams, like, Dr. Humba talked about it so much. You need multidisciplinary. With pituitary tumors, you need to have ENT surgeons. You need somebody to help you navigate the way to the cellar, though you can do it alone, but sometimes the anatomy is not the way you think it is. Sometimes you can go in there and not see the ostium. Sometimes you have septal deviation. So when you have an ENT on board, it becomes a bit easier than when you're doing it alone. So you need an ENT, you need an endocrinologist. Sometimes these tumors, when you have hormone-secreting pituitary tumors, some you manage them with medication, like the prolactinomas. You give them bromocriptine or cabergoline. But for the growth hormone, like patients with acromegaly, you need to do surgery. So you need an endocrinologist on board. Sometimes these patients present with, like, panhypopituitarism before surgery. Or sometimes after surgery, they can have pituitary insufficiency. So when you have a team, it becomes easier for you to manage these patients. So, and also you need a critical care specialist, you need an ophthalmologist. So we made a team with an endocrinologist, ENT surgeon. We have an ophthalmology who we consult, but we work hand in hand more like closely with the ENT surgeon and the endocrinologist. At first we had one at Muhimbili, though he has moved to Mloganzila now, but we're still in touch on the phone. So after, we made a team, we had to train people. So we did first endoscopic skull-based workshop at Moi in 2022, February. So we had so many patients on our shoulders, we didn't know what to do, so we decided to have a first endoscopic skull-based workshop. We called in Dr. Blessing, and we operated 10 cases in a week. So we had sessions in the morning, like we have lectures in the morning, we had neurosurgeons teaching, we had ENT surgeons and endocrinologists, and the anesthesia as well, because we need to have safe anesthesia when you're doing these surgeries. So we had all team on board. So we were all trained. We made up protocols, what we need to do, and that's how we started. So we created also a checklist. I hope you can also, it's not so clear. So, but we had a preoperative plan, peri and post. So preoperative plan, like all our patients that we see with pituitary tumors, they need to have, if you're planning to do an endoscopic surgery, they need to have a PNSCT. You need to know your corridor before you go to the cellar. So all patients need a PNSCT because some patients have, you need to know the pneumatization of the sphenoid sinus. Some patients have free cellar, so you need to plan ahead that you will do a lot of drilling. And some have, with the cellar type, it's easy. We'll see on the kind of patients that we see in the anatomy of the sphenoid sinus. And you need an MRI pituitary, you need an hormonal profile. When you have the cortisol is low, sometimes the blood pressure can be labile. So you have to know, you need all the details with your endocrine review. You need to have an ophthalmologist review, a proper one, because sometimes most of these patients present with bitemporal hemianopsia, and some come in blind. So it's easy for you to assess, because sometimes you can go in, a patient can see, and when you're done with your surgery, the patient cannot see. So you need to do proper evaluation for you to manage these patients. We need some things that the patient needs to prepare, because some things are not in-house. You have to make sure you have everything. For instance, you get a CSF leak, and you don't have maybe glue. Most of the times we use glue for repair of the skull base. So you need to have everything. We use Merosil for packing, and when you don't have them post-op, sometimes it can be difficult. But when you have them all, you make sure you have them before the patient goes to a theater, your life becomes easier. And post-operatively, we do MRIs 3 months post, because sometimes when you do immediately, like when you do a CT scan immediately after surgery, you might find a hematoma, and you get discouraged, like you think that you have done nothing. But if you can do an MRI earlier, maybe within the first 24 hours, then it makes sense. But if you do it a bit late, sometimes it's confusing. So most of the times we do MRIs post-op 3 months post-op. And then ENT review 2 weeks after surgery. But the ENT comes in, we leave the packs in for 72 hours, and the ENT comes in, take them out most of the times when you have a CSF leak. Because when you take out the packs early, sometimes they tend to leak. Yes, we get CSF leaks, but when you leave the packs in for at least 2 or 3 days, then most of the times the construction down there stays, and we've never gone back to theater because of CSF leak, and we don't use lumbar drains because we don't have them available at the institute. So we also made a database. We have this database. I know it's pink. It's girly, that's why it's pink. So we have a database. So far now we have we've been collecting patients, like patients with pituitary tumors. We have about 100 patients, but the ones we've operated so far until last week were 60. So we'll talk briefly about the patients that we've been seeing, and So we have, most of our patients are females, and they always come in with a good KPS. They always come in walking. The main problems that they present with is visual loss. Some come in late, some are coming early, fortunately coming early, and for those you who come in early, at least when you operate them, you see good results. But for those who come in like they've been blind for like a year, it's very difficult to correct it. So we have to do proper counseling before we take them to theater. Also, some patients presented with endocrine dysfunction. About 22.8% had endocrine abnormalities. So all patients, as I've said earlier, we've operated 57. The ones, when we analyzed this, it was 57. For the 57 patients, most of them had a cellar type sphenoid sinus, the pneumatization, and just 2, because the other one was operated last 3 weeks ago, 2 had a pre-cellar. And for the 2 patients who had pre-cellar, it wasn't easy. Yeah, so there was a lot of drilling and the bone bleeds. So it wasn't easy. It's not as easy as the ones with the cellar type. So if you're a beginner, it's good to choose the right patients. Don't go in like with a patient who has a pre-cellar type sphenoid sinus. You need an ENT for that. At least it's good. When you have bad outcomes, you will shy away from the surgery. So it's good to choose good cases. For cases with pre-cellar, I think maybe it's good. Even when we did the pre-cellar cases, we had one, last time we did one, we had a visiting professor, Professor Lilehei. We did it with him. And it was not even easy for him as well, and with the experience of 30 years. So you have to know how to choose your patients. Also, the consistency of the tumor. The consistency of the tumor really depends. Sometimes you can get a patient, and I'll show a video at the end. I was like, this is pituitary apoplexy, it's gonna be easy. But when we went in, the tumor was fibrous, and when it's fibrous and you're there, you have to, okay, sometimes you need to abandon, but somehow we got out, safely. I'll show the video at the end. So you need, it's difficult to remove the whole tumor when the tumor is fibrous, but when the tumor is soft and suckable, sometimes it's easy. And I think I won't talk about the procedure maybe next time, because our camera cannot record, so I don't have so many video. The video I'll show is the one we've recorded with a phone, unfortunately. Also, out of all the patients that we operated, like 57% had like total resection of the tumor, and they had good improvement. And we also have CSF leaks. About, I think this is a mismatch, 17.5% had CSF leak. I'll show like just a few slides. I know people are tired now. They can't wait to go for and we have a meeting. So this is one of the patients we've attended. We operated this patient, came in with a visual impairment. And luckily she had a bitemporal menopsia and she stayed with the tumor for some time because she was looking for a good time for her to come to the hospital. And we did the transfemoral pituitary surgery, and that's our control CT. And then we have this also. This one came, I think this was a redo surgery. This patient came in with progressive visual loss and severe headache. So the first CT, he had a pituitary apoplexy. So we went in, did the surgery, blood came out, gush of blood came out. We took out the tumor, the arachnoid descended, and we were like, we're done. So he went home, stayed for 7 months, came back with this CT. So we did the surgery again, and he had CSF flakes, so he was packed with a lot of fat. That's why you can see this on this MRI. So I'll show this short video. I hope it will play. Yes, I'm not sure if it's so clear, but there you can see we're cutting the dura. So this patient came in with loss of vision and severe headache, and we thought it was an apoplexy, and we were anticipating it was going to be easy. But when we opened the dura, the tumor was fibrous completely. So we started slowly dissecting. Most of the times, at first we used to have single surgeon, like you hold the scope and you do the dissection at the same time. We're learning now somebody to hold the scope for you, and then you try use your 2 hands. I'm still not very good at it yet, but I'm used to holding the scope and doing the curettage myself. But I think it's best now. We had a visiting professor who encourages somebody to hold the scope, and then you use, like you're doing microsurgery, like using a suction and a dissector all by yourself. I don't think the video is so clear, but at least you can see something. So you see this, the tumor is completely fibrous. The person who was taking the video was just moving all over. So, bear with me. At least you get it. At least you know I'm not lying, we're doing the surgeries. So you see the tumor, we're trying to dissect it using the suction, but it's not coming out. So we had to do like dissection slowly. The ENT was busy trying to instruct me with her hand. So sometimes he wanted to take the suction from me. He was like, Ainga, move around, move. Yes, like that, you're doing well. That was the ENT surgeon, Dr. Martin. Anyway, I think I should end there. So lessons I learned and I'm still learning. Endoscopic pituitary surgery is an effective modality for treatment of pituitary tumors. You can do it microscopically, fine, but I think you're able to take out more tumor when you do it endoscopically. The controls MRI you see when you do it open microscopic, and when you do the transfemoral surgery is just too rewarding. So I think it's something that in your setting, if you're interested, it's something that you can embark on. It's not easy, the learning curve is steep, but you can do it. You need to be patient, you need to be persistent. You need to choose the right patients, because when you're starting, don't go take a tumor that is engulfing the ICA, you'll be in trouble. Or go take a tumor which is compressing the cavernous sinus. It will bleed on you and you'll be discouraged and you'll stop. So just go for the small tumors. You start small and then you grow slowly. I'm not an expert, I'm still learning, but I've been through that path at least. So choosing the right patients, it's the right key. And then you have to learn from your own mistakes. When you get a mistake, you're not supposed to run away or to, leave a patient there for somebody else to take care of that patient. You have to embrace it, you have to face it, you have to follow that patient. It's through our own mistakes that we grow. So for the young surgeons, when you make him, you learn every day. It's a new, you get a new step every day. You get a patient, you get you do the first transsphenoidal, you resect, just half of the tumor. Don't give up. You learn from it. When you have to, when you start taking the tumor, you start inferior, you go lateral. Don't start superior. You learn from the experts. And then there are different people, different teachings, all over. Like everybody, sometimes it's confusing. Some doctors can come and tell you, no, it's not correct to somebody to hold for you the scope. Another one will come, no, you have to hold the scope yourself. So you have to adapt the right technique, which is good for you, but you have to follow the principles. And don't be afraid to consult. You can always get good information from your colleague. Like, don't shy away. Don't keep patients to yourself. You put them on you put them on the list, and then you end up in trouble. So it's important to have like a collective decision, like the whole team. It's very important. So I have two pictures. This is me here. When I began, I could not even hold the scope, and the big guns were holding scope. I was just sitting there observing. And then these were my mentors. I was not taught by, in Japan like Humba or South Africa. I was trained here. I was trained here, and my mentors are Edwin, Dr. Lemeri. Those ones I've been working with. And Blessing, okay, from Uganda. At least there's somebody from abroad. But this is me now. If you have any questions, I can answer.
Thank you very much, Dr. Ingaya. I think we could not use better words. Baby steps is the way to go. Anybody has anything to add?
Congratulations, Dr. Ingaya, for a nice presentation. But then partly it inspires the young ladies in this room so that they keep shaping and refining their career. I have one comment. I'm happy with the chart that you shared, but I think probably it is an added cost, but then probably if it is considered to have a CTA, preoperative is important. It may help in two ways. One, at times you have anomalous cause of the petrous part of internal carotid artery. Then that may pose, especially when you have the concha type of sphenoid bone. Number two, at times you have two pathologies. You have the ICA aneurysm, ICA cavernous portion of the aneurysm. Then that could pose another challenge. So to make sure that at least to be very safe, so that your working corridor is clean and you know where the lions are, then you are safe to go. But otherwise, keep it up. We encourage from yesterday, Magogo, Mtei, Alpha, keep going.
Thank you very much, Dr. Ingaya, for a beautiful presentation. We're very proud of you. Just a small question from the chart again. How many of those 60 patients were above 50 years old? And because you mentioned that your patients are predominantly female, is it through and through female, or after 50 did the sort of the epidemiology switch to males after 50, or did it stay female through and through?
All my patients, these are the patients of MOI. Like when you come to MOI, we have a pituitary, like endoscopic pituitary, whatever, our unit. So all patients are, are taken care of under this wing or arm. And honestly, I think the age distribution, like we don't have predominantly like above 50, maybe above 35. but I don't have any patients who is below 30. There's just one with acromegaly. He's 25, and I think his mother is also had a pituitary macroadenoma, and Eric also had acromegaly. I think it's the only young patient we've ever operated. Most of them are above 30.
Hi, can I comment something? Congratulations for these cases. So they say that the surgeon should have eyes of eagle, heart of lion, and a sophisticated hands of a woman. So all three needed to do a transsphenoidal approach because the error margin is very low. Like now, the point raised was kissing carotids, so or carotid aneurysm, and if you did not plan, so CTA or DSA would help picking up patients. So I have some question. How neuroendocrinological tests and other things are currently supporting you? And would you consider having a DSA in some cases when would you think that it would help you further? Thank you.
We have a good functioning laboratory, so all the endocrine evaluation can be done in-house. Before we used to have endocrinologists in one campus, but they've now shifted the department to a hospital which is far. But if we need him, then he comes to see the patients. And DSA, we don't regularly order for these patients, but we have DSA in-house. So if need arises, then we can always order one for our patients.
And quick question, how many cases, because you mentioned 75% of your cases had CSF leakages. And did you did you experience through diabetes insipidus? And how was acute and chronic management in those?
CSF leak was 17%, I think. It's not 75%. It's 17%. And after, we normally put fat, and then we use, sometimes we use fascia lata and glue, and most of them they take, so we don't get CSF leak post after, you know, after extubation, after going to the wards. And diabetes insipidus. Yes, we get patients with diabetes insipidus. I just forgot to mention that one. And so far we have 3 patients who have permanent diabetes insipidus. They are on medication. But the rest are transient. They always, they have resolved after being discharged home. But when we get diabetes insipidus and it is confirmed, we start them on desmopressin, and then when it resolves, we stop.
Yeah, usually we come across biphasic pattern. Initially 24 to 72 hours, and then long term. So excellent results, because the research, the published numbers also mention similar things, like 1 in 4 to 5 patients do end up with some sort of pituitary insufficiency after pituitary surgeries. So I encourage you, because it's amazing that you are providing super specialty services at the doorstep, and that's the winning point.
Thank you.
Yes. Thank you, Dr. Ngaya. That's a very good presentation. It's just rather a comment. You did a good job, but to inspire more young neurosurgeons, it's good if you put a straightforward case where you do almost 100% and post-op CT. Your presentation will look much more greater. Fibrous, they scare people.
The biggest problem we have we cannot record with our tower. So, and that was the last case we did. So I was, okay, let me just get one video for the, but I think I'm taking it. We'll be recording more. So next year I'll do maybe the, approach and the videos and stuff.
So, congratulations, Dr. Ngaya and my team for great work. So, I just wanted to know on the follow-up. I saw there you wrote MRI after 3 months, right? And how is the long-term follow-up of this kind of patient? And for those patients you had recurrence, what was the length of follow-up so that you picked up the recurrence? And what are the, how do you plan for those imaging, repeating imaging for follow-up?
Okay, so we don't do any MRIs immediately post-op. We do MRIs, but if a patient develops something like, which is not right, maybe we can think of doing an MRI. But if a patient is like normal, fine, we do an MRI after 3 months. And we then keep on following them. Because the patients we operated in 2022, we did MRI after 3 months, and unfortunately I didn't bring the MRIs. The MRIs were normal. So we've been following. So we do MRIs yearly, just once a year. If you have a control MRI, no tumor, then we do it after a year. And then you can follow for maybe 3 years. For the patient who had recurrent tumor, he came in with 9 months, I think, post-op, started developing the same symptoms he had by temporal hemianopsis. And then he came back to the hospital. We did a control MRI and there was tumor left.
One question, Dr. Ngaya. I know you keep inspiring me on the patient selection pre-op. So, based on your experience, are you now able to differentiate the softy vis-a-vis the fibrous tumors on the MRI? And since radiologists are here, maybe they can comment as well.
Okay. Okay, Dr. Kukuma will help me. There is a paper, a radiology paper, which I think has stated somehow how to differentiate suckable. Might not be, suckable. Sometimes I consult the radiologist. That's why I said you have to do cross consultation. I've been working with Mwana Abasi, and I think a study that she's doing, so whenever we suspect it's fibrous, so I tell her we have a consensus, and then we go in. If it's fibrous, then she records them. But we don't have a real clear, different. Yeah, but if Dr. Kukwima, there is none. Yeah. But sometimes when it's hypo, too, sometimes it is fibrous. So it's not a straightforward thing, but I'll share the paper with you, Magogo.
Thank you. In the
they compare the T1 weighted image with the sagittal image, comparing with its density to the, what we call it, the brainstem. Then it predicts. There are several papers. Yeah.
Thank you. I think that is the last comment. In the interest of time, we have to continue. Anybody with any further questions, please feel free to consult Dr. Ngaya. So since yesterday, we've been hearing talks from the doctor's side. So we'll switch things a little bit. I would like to invite Sister Dorcas Magawa, one of the founders of the PNNT, and she will give us her talk on the neuroscience nursing. Welcome, Sister.
Good afternoon, everyone. Thank you, Dr. Zarina, for the nice introduction. I'm going to take you through the introduction of neuroscience nursing in Tanzania. Actually, before we didn't have this nursing discipline, but currently we started. So we are going to talk about where we came from, where we are, and where we are going. So neurosurgical operative skills, capacity, and scope of practice have been developing rapidly, but did not go accordingly with the nursing development. And actually patients have been cared by nurses who have no knowledge or skills in neurosurgical conditions. And this has shown a big gap between neurosurgeons and nurses, leading to inconsistency of care or poor patient outcome. This indicated a great need for nurses to be trained in neuroscience nursing to improve outcome and ensure safe and consistent care. And recognizing the need for neuroscience nursing experts, 5 nurses from MOI were joined with the American Association of Neuroscience Nursing, who undertook a neuroscience nursing course. We are 5 of us. We started in 2021. And actually, we were supposed to identify ourselves because there are several neuroscience nurses in the world. So we decided to name ourselves Pioneers of Neuroscience Nursing in Tanzania. Shortly, we call PNNT. We've been hearing since morning, Dr. Othman was talking about PNNT. That it means that's Pioneers of Neuroscience Nursing in Tanzania. So we learned from the neuroscience, the American Association of Neuroscience Nursing, and actually that knowledge improved the neurosurgical care at MOI and also across Tanzania and beyond. Because we have been training nurses from all over the country, we have been having parallel nursing sessions during the international conferences, and we're inviting nurses from all over the country, and we train them. And also, even in our neighbor countries like Uganda and Malawi, they are coming and joining our training. And after the training, we become trainers, disseminating neuroscience nursing knowledge and skills to improve patient care and outcome in Tanzania and beyond. We have 4 objectives in our program. The first objective is to conduct training to nurses on neuroscience nursing in Tanzania and low and middle income countries to ensure proper nursing care to patients with neurological conditions. And also we participate in supportive supervision to nurses attending these patients, as we did during our neurosurgical initiatives during camps which has been conducted on zonal hospitals in the country. And also one among our objectives is to participate in various projects focusing on prevention and improving care to patients with neurological conditions. And third is to coordinate international fellowship to nurses in improving knowledge and skills to ensure good patient outcome. So we have, since we started, we have some achievements. One among our achievements is about collaborations. Actually, the team has local and international collaborations. That includes the Tanzania Neurosurgical Society, as we are doing. And also we are collaborating with our Tanzania Nurses and Midwifery Council. We don't work without informing them of whatever is going on. And also we are linking with other nurses in Africa like Sierra Leone, Malawi and Uganda in facilitating a joint support for development of neuroscience nursing in their countries. We are also members of the Asian Congress of Neurosurgical Nursing. Actually, in this membership, we managed also to do this type of fellowship. We are doing a fellowship with Japan. We are sending our nurses to Japan for fellowship. And also we are collaborating with the World Federation of Neurosurgical Society, and actually our sponsorship came from there. Professor Gale, who was here in the morning, he's the one who facilitated our sponsorship during neuroscience nursing training. And also our collaboration has gone further, and one among our team has been allocated to be a member of the Asian Congress of Neurosurgical Nursing, and also she's a global committee member of neurosurgical nursing. And also, as I've said before, we are sending 2 nurses to Japan for fellowship. And actually the fellowship is ongoing. And also one among our team has gone to neurointensive fellowship for 3 months under Weill Cornell Medicine Scholarship. She went there to have an observership. Second achievement is about nursing training. We have conducted several nursing training, and actually our mode of training is on presentations along with bedside teaching. We have been going to several hospitals in Tanzania to train about neuroscience nursing. And also, as I've said before, we have been participating in international conferences carried at Moi on neurotrauma and also neurocritical care, which was done in 2022. We managed to train about 77 nurses. In a neuro-oncology international conference, which was done in 2023, we also managed to train about 73 nurses. And in global neurosurgery, we trained about 54 nurses. And also we did a neurocritical care at Mbeya Zonal Hospital in 2023, where we managed to train about 118 nurses. We also went to Shinyanga, where we trained about basic emergency and neurocritical care. We managed to train about 24 participants. We trained about 55 nurses at Moi. And also during neurovascular and scar base, we trained about 30 nurses. In 2024, in Neuro-Oncology International Conference, we managed to train about 31 nurses. And in global neurosurgery, which was in March this year, we trained about 37 nurses. Also, we did some training during neurosurgical camp, which happened in April this year. We joined the neurosurgeons, and at Amana we trained about 60 healthcare workers in neurocritical care on different sessions within a week. We managed to train about 20 nurses in different sessions on neurocritical care during neurosurgical camp at Mbeya. And we marked about 579 healthcare providers of whom we trained in different sessions. Also, during this training, we also we have a modality of collecting participant responses during pre-course and also during post-course. We are trying to measure how effective our training is. So we receive their responses so that we can at least see whatever we are training, how much is the impact. So attendees reported improved knowledge and skills between pre and post-course assessment, and commented on usefulness of the course in improving patient care practices. And also after the above mentioned courses, which has been carried by neuroscience nurses, it has shown high demand from referral hospitals regarding basic and also neurocritical care training. This is one among our training in neuro-oncology 2024, because we also collaborate with our fellow from Colorado, as you can see, where we are Tanzanians and also there are people from Colorado, same as this picture. And actually the next photo is about the neurosurgery training which was done in March this year with our fellow from US. And these are the participants from global neurosurgery nursing sessions. This picture reveals about bedside teaching, series of bedside teaching. Third of our achievement, we managed to write a manuscript which is describing about our experience of delivering in neuroscience nursing training courses, of which we conducted as explained above. We described the course participant, feedback from the courses, and their impact on improving nursing knowledge and skills on patient care. And actually this manuscript we have submitted in a Word Neurosurgery on Nursing section. Fourth of our achievement, PNNT has managed to participate fully in collaboration with the neurosurgeons in supporting Tanzania Neurosurgical Society initiative during neurosurgical camp done in this country. And we managed to do capacity building to medical staff in regard to neurocritical care at Amana Regional Referral Hospital and also at Mbeya Zonal Referral Hospital. These are some of the photos revealing whatever we are doing at Amana. And these are some of the photos which we were doing at Mbeya Zonal Referral Hospital. Thank you so much for listening.
Thank you very much, Sister Magawa. That was impressive. Comments?
Thank you very much, Sister Magawa, for the very nice talk and collectively explain how extensive you have gone. Mine is not a comment, but rather a compliment. I think this is the way forward. As now we have Tanzania Neurosurgical Society, then we walk and run together until when you are giant enough to stand by your own. But I think wherever we are, let you be there.
Thank you, Sister, for the good work. I think it's a high time to also to involve the private hospitals so that you expand your scope in terms of training. And I think we have in this room some of the nurses from Aga Khan. I think they will, if you have the WhatsApp group or what, then they can be also registered or they can join so that they get the updates and also the information about the training. But one question I want you to maybe to be open or to talk about, especially when you are doing the training camps. I'm sure you encountered some challenges when you are conducting your training. I'm sorry if you have said, but I did not hear about them. You can comment, especially we can choose like one center like Amana. Maybe tell us what challenge did you face, and maybe because in this room we have a lot of doctors and others they are head of units and they can communicate with those head of nursing and other departments. so that next time when you go for the training and the people on the ground are aware of the training, so that you also you get enough time for them to attend and participate. If you can comment on that.
Thank you so much, Dr. Mugisha, for your question. Actually, we meet some challenges also in our program. Sometimes we invite nurses from other hospitals to come and attend, because actually many these courses are sponsored. They use a lot of money. There are many institutions and also other funders. But unfortunately, some of the hospitals, they don't allow nurses to come. And they miss the opportunity, and also they miss, because there is high demand of nurses to come in these courses. So sometimes we invite other nurses, they are not given a chance to come and attend. So that is one among the challenge. And I also encourage hospitals to support nurses to come, because some of the hospitals, they want to come many. But you say, no, we need to at least distribute, because we have limited number of nurses to come and attend the conference. So if you miss a chance and also we have limited others to come, actually that to us, that is a very big challenge. Because we want nurses to go about this new discipline. It's not even taught in our country. It's a new discipline. And also another challenge, when we go in other hospitals, we really meet some other challenges, like you just go with your mental image, expecting maybe they are practicing at this level, so I want to go and teach this one. So when you reach there, again, you need to start at the grassroots. You just find some of the things. There are even basic practice, like oral care. You just find nurses, you stay in the unit, you ask them, at what time do you give birth? At what time do you do oral care to this critically ill patient? That doesn't mean that is a neuroscience nursing training, it's a basic training. But you just find that those ordinary practice, they are not carried out. So you find that patients are suffering from pneumonia because of, very basic things. So there are a lot of things which we are meeting there, maybe to mention the few.
Thank you so much for the good presentation, Mr. Ngawa.
Thank you.
I think concerning the challenges you face, I think it's the time now to make some sort of association, and starting with the hospitals which have neurosurgical services, to include the nurses in the department of neurosurgery. And then all of you can go together, as now we are doing as neurosurgeons, because this should be a must, because you cannot only go as neurosurgeons for this training, but the nurses, you are leaving them behind. As Dr. Osman presented in the morning, if you want to go fast, go alone. If you want to go far, go together. I think it is time now, you as the initiator of this program, I think you have to make sure that you make an association, and every hospitals which have neurosurgery should be included in this program. Thank you.
So the last presentation of the day will be by Dr. Humba. Once again, welcome.
Thank you very much. For this presentation, it's going to be a very short presentation. It will take maybe 5 minutes. I would like to thank one of the sponsors, the Gamma Pharmaceuticals, for helping me organizing this talk, especially because I'm involved in doing one of the study in post-traumatic seizures. So they have one of the medication that I am using as part of the study. So I thank them. I think they will speak for themselves about that medication. I'm declaring. I declare. I'm declaring conflict of interest. Yeah. So, post-traumatic seizures in Tanzania. I went to search of all the papers that were done and the big paper that were published in Tanzania, whether we have something on post-traumatic seizure. So this was the paper our president participated a few years ago. And this was the only paper that had records on post-traumatic seizures. So, this was the other paper. I don't know whether you can see. I'm sorry, I could only see myself as I was preparing. I wanted to show you. You know this paper? Yeah, you know. But I'm sure the rest of the guys don't know. I wish I would have expanded. But the issue is, this paper also showed post-traumatic seizure in severe traumatic brain injury. With a group of patients that were done, it was around 400 something in Moi. But this paper also did not quantify the prophylaxis anti-seizure therapy, whether there were patients who were given prophylaxis anti-seizures or not. Why did I decide to take this topic? It's because of this paper. So I had a patient. This patient was a young boy who was involved in a motor traffic accident many years ago before I went to Dodoma. Then this patient was given anti-seizure medication. He's been on carbamazepine, phenytoin, and phenobarbital. Then he had repeated seizures despite the medication that was on. We did the levels and everything was okay, but she has markedly elevated liver enzymes. I decided to switch the patient. I called the family, the father and the grandfather who lives with the child, canceled the patients, the parents, telling them that I need to switch the patient to a safer medication. But that medication, since they're poor and depending on the NHIF, that medication is not on the NHIF package. So you'll need to pay it by yourself. What happens? The grandfather texts, he listens to me, he says, no problem, write me a prescription. I write him a prescription. He goes to the PM and complained why NHIF doesn't pay for this medication. His child is about to die and so many other things. So it went around to the Ministry of Health. He came back to me with a letter to explain myself. Why did I choose to give the patient that medication? So I took this paper and printed. And my choice was levetiracetam. Because of the safety in that paper, you'll see this is a much better and a safer medication. And now almost entire world has changed to levetiracetam as a first-line anti-seizure medication. This is in the same paper, which shows characteristics of all these other anti-seizure medication, interaction and every other thing. There's nothing in this review that was better than levetiracetam. So I went on to read, can levetiracetam be used in prophylaxis for anti-seizure medication? Yes, I could. I found this was the paper done in the military science. So they used levetiracetam as their first-line medication for prophylaxis anti-seizure medication. And they had a very good outcome here, they commented. Why is it, is there any other document that supports using levetiracetam as prophylaxis for post-traumatic seizures? And these were the evidence. You can see the evidence is weak, but the practice shows that it is better than phenytoin and other medication that we have been using initially. So I wanted to use this platform to ask guys if we can create and make more data. Since we have a lot of these patients, what I've realized is post-traumatic seizure in our setup is is underreported. Is underreported, and in most of these papers, when we are evaluating and when we are managing these patients, as I've shown you there, not many papers are showing anything to do with post-traumatic seizures. And this could easily be attributing to the poor outcome. You'll hear this patient had aspiration as a reason for his or her death. But when you go back to take history, you are being told that the patient had probably had a seizure, then aspirated, then died. So I think it is underreported. We need to report more. We can join hands. We at Dodoma, we have started our registry. We have finished one paper. We evaluated on outcome of our severe head injury patients, and we have a mortality rate of 33%. Now we are analyzing other things. Now we are going to post-traumatic seizures. But the problem is that we didn't have anything else to compare with. Thanks to Gamma Pharmaceuticals, now they've come with Kepam. That is the only IV formulation of Keppra in this country. Thank you very much.
Thank you very much, Dr. Humba. Do we have any questions?
It's excellent presentation, and the topic chose was very relevant. We agree that it's underreported, and it's a very important thing to diagnose and treat. Congratulations for raising up this issue. Thank you.
Thank you very much, Dr. Humba. I wanted to comment on the paper. That old paper, the paper from Moi, actually it was because the cohort was being followed for 14 days. And then after 14 days, it's an exit. So there was primary outcome and secondary outcome. And the seizure was none of them. So seizure was something that was reported. These were the outcomes that were reported, but it was not primarily as one of the primary or secondary outcomes. In the findings, eventually it came out. So it's good somewhere to start, gives the room for more research. But then I think initially levetiracetam was not available in the country. And then what was available, eventually what Keppra that came in was very expensive. You remember one tablet of 500, it could have gone up to 1,500 per tablet. And then if somebody is taking BID, it means per month the cost is horrendous. It's not affordable. But at least currently, even as we are evolving, initially we had the only in the stock phenobarbital. Now we have levetiracetam. At least IV is available and oral medication available. And the cost has gone a little bit down. So that probably is quite recommendable. Then the question of prophylaxis for seizure. This is a little bit questionable. But then to our setting, we tend to give because for patients that have high risk, for instance, you have an open fracture, skull fracture. You have a contusion in the frontal, temporal, less parietal and occipital. You have extradural hematoma, subdural hematoma. These are indicators that the patient is at high risk. And simply because we cannot do monitoring, continuous EEG monitoring, then we tend to give prophylactic medication. And the recommendation from the old textbook says we give for 7 days. If the patient is early onset seizure, the seizure within 7 days, we are happy. But then the risk the patient keeps on developing seizure, then we may have to continue treating as an epileptic patient.
I want to raise 2 points. One is that traumatic brain injury is still top 10 causes of morbidities and mortalities. So this post-traumatic epilepsy, if you go to Angel epilepsy textbook, it shows that there is a classification early and late. 5% would manifest early, and 5% of traumatic brain injury patients do have lifetime risk of seizures. So if we pick up the early, and these two chunks are very different. So people who have early post-traumatic seizures may or may not have delayed presentation. So not having early traumatic seizures cannot assure that that group would not get seizures in the long run. So just like you mentioned, the higher risk factors. So we have to keep a very low threshold for the diagnostic, and we should give the best and safe medications. It's very important for all of us.
Thank you very much. Dr. Umba, what is the recommended dosage of levetiracetam that you want to use for prophylaxis? You have to bear in mind that you're not going to see all the TBI patients. Some of them will go to a GP, they'll give 500. Some of them will go to a neurologist, they'll go with 500 BD. Some of them will go to a private neurologist who will give 1,000 BD. So how do you decide? And then two, so NHIF covers for levetiracetam, right? But what about, yeah, it covers, our hospital is covered and most hospitals is. No, even the regular ones. So yeah, that brings us back to how much is the prophylactic dose. What about, now you want to create a registry. What about the majority of the patients who are the public, the poor, the cost sharing, etc.?
Thank you, Miranda. Prophylactically, even in most of these papers, for adults, they've been using 1 gram as in a prophylaxis for 7 days. But, OD, in most of these papers. But, to tell you surely, if they have started paying NHIF, they must have started with a new catheter. The old one, I'm telling you, I have letters here in my phone. I have letters. No. I have letters, my friend. I have letters. Why didn't I choose this instead of that? Because NHIF wasn't paying. It wasn't paying. So maybe now they've decided to pay.
Thank you, Dr. Humba. Right now, those old guys to guide the profession. I would like to remind you, and to connect dots also. If you remember the presentations of the editor-in-chief of Surgery, Juno, he said among the studies with high impact factor is brain trauma guidelines. Okay? These are well-established guidelines with a very good impact factor. It was very clear on the presentation. Fortunately, it's recorded, you'll see it. Okay? And in brain trauma guidelines, there is a guidelines for management of seizure. There is guidelines for management of seizure, which is evidence-based and beyond sector. And it has been there standing for quite a long time. And it says which medications you have to use at the first line, okay? As a prophylaxis, not as a therapeutic. You know better, you've been talking about this, and the type of the evidence which we have. But let's go back again. We have the so-called International League Against Epilepsy. There is guidelines in the type of medications to use. So for levetiracetam also, it's good to have a strong guidelines and to see what level of evidence do we have. In taking in consideration of all these things, you know, I usually say there is a translation of studies. Things are changing, and we come up with the better studies like the findings you have seen. The one which you have noted is an experienced surgeon opinion, and that one is a level 3 recommendation. It's just a level 3 recommendation.
Thank you very much, Dr. Othman. Any more questions to Dr. Umba? So before we hand over the mic to our respected president to end this prestigious conference, I would like to invite Dr. Ingaya. now we have a tiny award giving ceremony. Dr. Ingaya, please proceed.
When we announced the meeting, I think somewhere last year, we encouraged the residents, registrar to submit like posters, cases which they've attended or they participated in operating for presentation. So the intention was for you to come in with, like you send your presentation and bring in posters, so we could have posters all over the place and people can go through the posters and review them. We have one poster at the back. That poster was, like, yeah, you're standing in front of it, yeah, that one. You'll have a look at it. Maybe next year, most of you, for those who are interested, and will come with posters so that we'll have a hall with so many posters that people can go through and have more presentations, like normal presentations here, and the cases should be on the posters. And we promised present to the first winner. But because most of you didn't know that you're supposed to bring in posters, so we've decided to give presents to all of you, all those who presented cases or brought in cases. So all of you are going to, so the winner was supposed to get dollars. That's what I promised. But unfortunately, because of the misunderstanding, so the prize is going to be distributed among all of you who brought in cases. So I would like to call upon the chairman and the president to give the presents to the winners. It's $10, don't worry.
So, Dr. Rebecca Mwambegele, Muhimbili National Hospital, Registrar Mloganzila, can you come forward?